we have utilized DSM-5 criteria for disease categorization as well as WHO internal and TCDD classification for utilization analysis. We have used Open API software for the statistical calculations. We have included adult age group with both the genders, those who are suffering from a psychiatric illness with a confirmed diagnosis and prescribe at least one psychotropic drug. We have excluded those lacks the confirmed diagnosis with acute substance abuse and with certain CNS abnormalities. We have enrolled total 707 patients, among which 224 that has been highest diagnosed from depressive disorder, 198 diagnosed from schizophrenia, followed by anxiety spectrum and bipolar mood disorders. The most effective age group is 21 to 40 years. Around 49% of patients were from this age group. We have found that the female were more prone to get psychiatric illnesses than males in our study. Anti-anxiety drugs were the highest prescribed drugs among all those group, the drug group. Among that, around 91% were benzodiazepine. Benzodiazepine have been extensively prescribed in all the types of psychiatric disorders prescription. Antidepressants were the second most prescribed drug group, that is 61%. Among that, 46% were SSRIs, followed by 8% TCA, 6% SNRI, and atypical. They were extensively used in depressive disorder as well as anxiety spectrum and other psychiatric illnesses. The third most utilized drug group is antipsychotic drugs. Among them, atypical drugs was lastly, we have seen the mood stabilizer. There are 12% among the prescription. Reviewing the drug indicators, the average number of drugs per prescription and psychotropic drugs were 2.46 and 2.14 respectively. Only 9% drugs prescriptions were containing the FDCs. There is around 77% of drugs prescribed by the generic name. Only one injection was prescribed. There is regarding 70% of drugs prescribed from NLEM 2021, while 52% are prescribed from the WHO MLEM 22nd list. There are 61 drugs actually dispensed from the hospital drugstore at free of cost. Reviewing the prescribing indicators, there are only 1.27 prescription was lacking of the dose, 4.80% were lacking of the duration of action, 10.18% were lacking of the frequency of drug, and there are no therapeutic duplication seen in our study. So in major depressive disorder, the mainstay will be antidepressant. So among them, sertraline has been prescribed mostly 42%, followed by escitalopram, amitriptyline, nortriptyline, venlafaxine. Benzodiazepine, clonazepam was highest prescribed, and it is as a supportive drug therapy. Among anxiety spectrum disorder, the mainstay therapy will be anti-anxiety drugs. Among them, clonazepam were the most prescribed drug, followed by lorazepam and buspirone. And among SSRI, paroxetine were prescribed the most, followed by sertraline and escitalopram. Among bipolar mood disorder, the mainstay therapy will be mood stabilizer. The most prescribed drug is valproate, followed by lithium and lamotrigine. If psychosis is present, then olanzapine is highest prescribed drug, followed by risperidone and quetiapine. If depressive symptoms are there, escitalopram and fluoxetine has been equally prescribed. Clonazepam has been mostly prescribed to give a calming effect, and anticholinergics to relieve the EPS symptoms that are from antipsychotics. Among schizophrenic spectrum disorders, the mainstay therapy was atypical or typical antipsychotics. Among atypical, they are mostly prescribed olanzapine, followed by risperidone, clozapine, aripiprazole, while in typical, the most prescribed drug was trifluperazine, followed by haloperidol. Benzodiazepine are still the supportive role. Triazepanidine was prescribed 30% to relieve the EPS that are from the antipsychotics. In obsessive compulsive disorder, fluoxetine and clomipramine has been prescribed in most of the patient, followed by buspirone. Here, clonazepam will be giving a supportive role. In somatoform disorder, we have observed that the duloxetine has been prescribed the most, followed by desvenlafaxine and venlafaxine. Clonazepam and lorazepam has been given for the relieve the anxiety. In PTSD disorder, stress-related disorder, the mainstay will be SSRI or SNRI, that is sertraline followed by escitalopram and desvenlafaxine. In personality disorders, we observe that the fluoxetine has been prescribed a lot. We have categorized 80 anaerobic therapeutic classification and daily defined dose as PDD, and the ratio suggests that if ratio is greater than 1, that shows overutilization. So it can be seen in most of our antipsychotic and antidepressant drugs. The ideal ratio is 1, that is seen with bupropion, and less underutilization can be seen in the most of the drugs. So we have computed overall rational drug utilization with fewer deviation due to economic status, as well as the prescribing practices. Benzodiazepine were essentially highly, so it should be limited to a short period of time. As per newer guidelines, typical antipsychotics are the preferred drugs to be prescribed. But our study, olanzapine is prescribed a lot, which is excluding aniline. Anticholinergics should be used only in selected cases with antipsychotics, and more drugs should be used from the national and WHO essential list to have more rational drug prescribing. We have not observed any polypharmacy in our study. Thank you so much for your kind attention and giving me such a prestigious platform to perform. Thank you.
I request the judges to please put up questions.
Yes, Dr. Hirsch, the presentation was good. I just have a question. What was the duration of study and how did you reach that sample size?
Yes, ma'am. Total duration was 2 months, and our sample size is 707. All the new and followed up case of that we come to the psychiatric OPD.
Okay. And was any difference in the gender difference in the pattern of drug prescription was observed?
Yes, ma'am. Like giving anti-anxiety drug, males are more given escitalopram, while female are more given to sertraline, as PEM can be seen with escitalopram. So that with sertraline, that should be avoided into males. Likewise, in pregnant women, lithium are highly prescribed due to its safety data, and so on.
Harsha, after this study, what have you done in your institute to pass on these findings to the administration, and what actions are being planned based on your data?
Yes, sir. As we have analysis the utilization and prescribing pattern, so we should first see any there are any deviation from the standard guidelines or not, as well as the overutilization of so many commonly used drugs suggests that the cost burden on the patient. So we should create a hospital drug schedule that should be very cost minimal, and yes, certain drugs can cause side effects and drug-drug interaction, so it should be avoided. So by this, we can get a rational drug prescription, as well as we can chart a good hospital drug formulary by these.
No, should be is okay, but are you planning to have some action items being communicated to the psychiatric practitioners and to the administration also?
Yes, sir. We are planning to suggest some of our suggestion for pharmacological aspects, like they are prescribed a lot olanzapine. Rather they should give some atypical. So we will be given them standard guidelines suggestion regarding pharmacology, as well as by the pharmacoeconomic study we can minimize the cost of their prescription.
Okay, thanks.
Welcome, sir.
Okay, now I would invite the second speaker for the session, Dr. Jagdamba Aswathappa, Associate Professor, Sri Devaraj, Urs Medical College, Kolar. She would be talking on impact of internet addiction on heart rate variability in young adults.
Shall I share the screen, madam?
Dr. Jagdamba, kindly begin your presentation.
Yeah. Am I audible?
Yes, you are.
Okay, my screen is visible.
And just before you begin, ma'am, you have 8 minutes to speak. And just
Yeah.
before you finish your 8 minutes, in the last 1 minute, I'll let you know that you just have 1 more minute. And thereafter,
Okay.
it will be the judges to have question sessions with you.
Okay, thank you very much. Okay, good morning, everybody. Myself, Dr. Jagadamba, Associate Professor from Sri Devarajas Medical College. I'll be presenting on the project called Impact of Internet Addiction on Heart Rate Variability in Young Adults. One second. I'm not able to move the... Yeah. Internet usage among general population is increasing widely, though it has many uses, but loss of control over internet use might lead to negative impacts on our daily life. Young defined internet dependence as an impulse control disorder, which does not involve intoxicants, and that individual loses control on internet use to cause significant relational, occupational, and social impairments. Who is at risk? Anyone using the internet for more than 2 hours a day outside work commitments, teenagers and children who use the internet unmonitored, women and men in their mid-50s suffering from the loneliness of an empty nest. So 4 components are included in this diagnosis. Excessive internet use. One is loss of sense of time or neglect of basic drive. Withdrawal, including feelings of anger, tension, or depression when the computer is not accessible. Tolerance, including the need for better computer equipment, more software, or more hours of use. Adverse consequences like arguments, lying, poor social isolation, and fatigue. All of the above are linked to an autonomic imbalance. Review of literature suggests that in the findings, 60% of the youth is addicted to internet. Youth feel it is uncontrollable factor. And in one more article, they have suggested youth who are exposed to such inappropriate content tend to fare worse in their academics and also cause psychological damage. So vagus nerve is a part of system that communicates between the brain and the body. So control of the vagal brake can be measured non-invasively at rest with an ECG. So here we are mainly looking at the sympathetic and parasympathetic dominance. So mainly if heart rate if there is increase in heart rate variability, it is towards parasympathetic dominance. A review of literature where Lin PC has done, his findings suggest that internet addiction is associated with higher sympathetic activity and lower parasympathetic activity, where he has done this study in school age children. So internet addiction is stressful life event to onset of depression or anxiety, which is clearly endogenous. It is likely that both etiology and pathophysiology of internet addiction may remain elusive due to highly complex interaction between psychological and physiological factors. Parasympathetic activity is usually a component in the relaxation response, which can be studied by HR. Without the benefit of prospective studies in young adults, it is difficult to determine whether autonomic nervous dysfunction is the cause, effect, or epiphenomenon of internet addiction. As we do not know the exact mechanism involved, the intention of this study was to analyze the effect of internet addiction on heart rate variability in young adults. So, objectives of this study is to determine internet addiction in young adults by Young's Internet Addiction Test Questionnaire, to determine HRV parameters in young adults, to compare HRV parameters among the mild, moderate, and severe internet addictors. Coming to materials and methods, study design, we did the cross-sectional observational study. Professional students in the age group 18 to 25 years were selected. So who are using the internet more than 6 months, we included in the study. Exclusion criteria, it included like they had a history of hypertension, diabetes, cardiovascular disease, neurological disease, consuming medications such as beta blockers, sedatives, psychiatric drugs, smokers, and alcohol addicts. All these we excluded where it affects the HRV. Intervention, we did nothing. Like demographics profile of the subjects were collected. Young scale of internet addiction scale for evaluating internet addiction for around 350 professional students was done. Score, it depended on 20, if they had the score of 20 to 49 points, they had grouped into mild. Moderate was 50, if the score had come between 50 to 79, it was moderate. And severe internet addictors were 82, if the score was 80 to 100. So sampling technique, the systemic random sampling technique was administered to collect the data. That is 357 divided by 49. Every 1 in 7th, every third person were recruited. And for recording heart rate variability, we use the Audacity software for the ECG, this thing, which is an inbuilt amplifier. And Cuba's HRV analyzer was used to analyze the raw data. And we collected the data, we analyzed the data on time domain, frequency domain, and nonlinear results also. But coming to statistical analysis, SPSS 17 version was used to analyze the data, and graph prism software was used for the graphs. Descriptive statistics such as frequency, mean, plus or minus standard deviation were used to present the sample demographics. And the mean values of the acquired data between different groups were compared using one-way ANOVA, and the significance was calculated using Tukey post-hoc test. P less than 0.05 was considered statistically significant. Coming to results, around 63.87% of them in the present study were mild level, they had mild level of internet addiction, and 26.05% had moderate level of internet addiction, and severe level 10.8% they had. So coming to the data as such, this one-way ANOVA was done in this table. Only the significance was seen in duration of usage of internet per day, how much they were using. We collected the data. The internet addictors, they were around 36 in number, that is around 10%. So they use the internet more than 11 hours per day. And we can see with one-way ANOVA, it had statistically significant results. So only with high frequency and total power and LFHF, we had the significance value. The rest, we couldn't get the significance. So this is the graph showing whichever the significant values we had got. For that, we did the post-hoc Tukey test for significance. So one-way ANOVA for the mean of internet addiction score showed statistically significant difference between the groups, which is P less than 0.001. Tukey's post-hoc test showed that the mean of internet addictor score is significantly higher compared to the moderate. You can just see here. Compared to the moderate and the mild, it is significantly higher. One-way ANOVA for duration of usage of internet when it was done.
Last 1 minute.
Yeah, Tukey's post-hoc test showed that mean of duration of severe internet addictor scores is significantly higher compared to moderate and mild internet addictors. And coming to high frequency, even this showed that the mean of high frequency of severe internet addictor score is significantly lower compared to mild internet addictors. So conclusion, in internet addictors, the sympathetic activity is higher with lower parasympathetic activity, which is statistically significant. Internet addiction may not reflect physical or psychological impairments in young adults, but the need to assess the risk of autonomic nerve dysregulation to avoid subsequent adverse effects on cardiac activity. So future consideration is lower HRV have a slow recovery of autonomous regulation of heart rate. Studies need to be done on withdrawal effects of internet addiction, especially in young adults, where it might affect the vagal reserves of autonomic regulation of the heart rate and increase the cardiovascular dysfunctions. Thank you.
Yeah, hi, Dr. Jagdamba. Thanks for the presentation.
Thank you very much, sir.
My question is,
Yes, sir.
when was the internet usage maximum? At what time of the day or the night? Did you check that?
Sir, in that questionnaire, it was not there, sir. That is a validated question, Young's internet addiction questionnaire. That we didn't ask, sir. At which time it was more, that we didn't ask.
And did you collected data on the students' bedtime and wake up time?
No, sir. That criteria I didn't take up.
No, I think that is important because
Okay, sir.
once you identify internet addiction, what will
Okay,
be
sir.
your advice? How are you going to de-addict them?
Sir,
One of the things that is very common is
yes, sir.
youngsters are using
Yes.
internet more at night.
Yes, sir.
And the moment they start doing that, their bedtime gets delayed.
Yes,
Their
sir.
total sleep time is decreased.
Yes, sir.
They go in sleep deprivation. That itself is going to affect your heart rate variability.
Yes, sir.
results during
Correct.
the daytime.
Correct.
So I think this part of the information will be important, not only to understand that is it internet usage per se, or is it sleep deprivation is also contributing to it. Number one.
Yes,
Number
sir.
two, this will help you to give suggestions to the students, because suddenly asking them to stop using internet is very difficult.
Correct,
But
sir.
if you can at least make them use it during particular duration of the day away from their sleep time, that itself can lead to a lot of changes.
Yes,
Just a
sir.
suggestion
Yes, sir.
for
Thank you,
you
sir.
to take into consideration.
Thank you very much, sir. And what I am doing is like those who are severely internet addictors, we counsel them. We have a student counselor in our university. So with this, we take them to him as per their willingness only. After they give consent that they're ready for counseling, we take them, and we have done the counseling also, sir, for them. So this little bit changes we are seeing in those students also, the professional students.
Okay, congratulations for a
Thank you.
good presentation.
Thank you very
And,
much. ma'am.
was it, you could have added some open-ended questions,
Yeah.
like, as suggested by sir, or what site were they mainly involved in? Was it social networking site, or it was
Most of the
gaming
time,
gaming addiction? That is important
Yeah.
to, because the gaming addiction would have different effect.
Yeah. One more study I had done, ma'am. In that, like when we link smartphone addiction, there it was gaming addiction. Here mainly social interaction, networking only they were doing. Here mainly in the internet addiction.
And you have mentioned professional students. What
Yeah.
does this professional students
Mainly
mean?
in our university, we have allied health course and medical course and nursing. So from all of them, we collected the data and we just included here.
Okay, thank you.
Thank you very much. Can I stop sharing my screen?
Yes, please.
Yeah.
The next speaker is Dr. Kavita R. She is professor in Sri Ramchandra Medical College, Chennai. She'll be talking on anti-neuropathic effect of 3,4-dihydroxyflavone involving potassium ATP channel, adenosine and GABA A receptors against paclitaxel-induced peripheral neuropathy in mice. Dr. Kavita, please start the presentation.
Yes, sir. So is my scene visible, sir?
Not yet. Now, yes.
Good morning, one and all. I am Dr. Kavita, Professor of Pharmacology from Sri Ramachandra Medical College and Research Institute, Chennai. And the title of my study is Anti-Neuropathic Effect of 3-4-Dihydroxyflavone involving ATP-sensitive potassium channel, adenosine and GABA A receptors against paclitaxel-induced peripheral neuropathy in mice. In coming to the introduction, chemotherapy-induced peripheral neuropathy is a common adverse effects of first-line anti-cancer drugs like taxanes, platinum analogs, vinalkaloids, and protease inhibitors. Painful peripheral neuropathy is the most dose-limiting side effect of taxanes, affecting up to 97% of paclitaxel.
Change the slide, ma'am.
Dr. Kavita, your slides are not changing. Can you put in the
Actually, I
present-
changed, sir.
Can you change to the presentation mode, because we are not seeing the presentation mode yet. We are just seeing the title slide right now.
Ma'am, you can click on the refresh button from your side.
Okay, sir. Is it moving now, sir?
Not yet, ma'am. Slide number 1 is on display still.
Okay, sir.
Ma'am, try switching to slide number 2.
Now, sir?
Not yet. Ma'am, please click on the refresh button. Rather, refresh the whole slides once again.
Okay, sir.
Ma'am, share the screen again after refreshing.
Yes, sir. It's not moving, sir.
Log in again. Ma'am, please log in again.
Oh, yes, sir.
Or ma'am, share the screen, please. Ma'am, stop this and start it
Selected
again.
है सर ये
चलता रहेगा, आ जाओ।
आजा क्यों उठाओ
चलिए आओ।
Now it's able to see now, sir? Is it moving?
No, ma'am. For the judges, if we start with another offline contestant.
Yeah, sir, 1 second, I'll just. Now it is seen, sir?
No, ma'am.
No, not yet.
Now it's moving, sir?
Not yet,
No,
ma'am.
not moving.
Okay.
Have you shared the screen?
Yes, ma'am. Yes, ma'am.
Slideshow में. Slideshow.
It's in the slideshow mode only, ma'am.
Ma'am,
It's
please
not visible.
please disconnect or log out from your PowerPoint
Okay.
and then redo the whole process.
Okay, sir. 1 second.
Meanwhile, can we continue with the on-site presentation?
Excuse me, ma'am. We are beginning
Yes,
with the
sir.
next contestant, and in another 10 minutes, you can have your session.
Yeah, okay, sir.
Okay, ma'am.
So I would now invite Dr. Kiran Prakash For the next oral presentation, the topic of our presentation is association of autonomic functions, peripheral nerve conduction velocities, and insulin resistance in patients with recently diagnosed type 2 diabetes mellitus.
Thank you, ma'am. I'm Dr. Kiran Prakash, Assistant Professor, Department of Physiology, Government Medical College and Hospital, Chandigarh. Today, I'm going to present my work, Association of Autonomic Functions, Peripheral Nerve Conduction Velocities, and Insulin Resistance in Patients with Recently Diagnosed Type 2 Diabetes Mellitus. This study has been funded by Department of Science and Technology and Renewable Energy, Chandigarh Administration. So, it is a well-established fact that many long-standing complications, systemic complications are associated with diabetes mellitus, and early affection of these systems can be assessed by few of the tests. Role of heart rate variability is well established, although few papers have reported that there is altered blood pressure variability and baroreflex sensitivity in early cases of or recently diagnosed type 2 diabetes mellitus. And insulin resistance as well as hyperglycemia goes hand in hand with the diabetes mellitus. So what is the association of this insulin resistance, as well as if in the early days of diabetes, so recently diagnosed diabetic patients, if we assess the nerve conduction velocities, which is usually the late complication of diabetes mellitus, and what is the association of these parameters, the nerve conduction velocities or the quantification of the insulin resistance as assessed by HOMA-IR, and its association with heart rate variability, blood pressure variability, and baroreflex sensitivity. So keeping these things in mind, we aimed our study to explore the association of insulin resistance with autonomic functions and nerve conduction velocities in the patients with recently diagnosed type 2 diabetes mellitus. And to fulfill this aim, we have set the objectives to study the association of insulin resistance with autonomic neuropathy assessed by heart rate variability, blood pressure variability, and baroreflex sensitivity, and to study the association of insulin resistance with peripheral neuropathy assessed by nerve conduction velocities in peroneal, tibial, and sural nerve in the patients with recently diagnosed type 2 diabetes mellitus. So sample size calculation were directed by, as per the paper by Ko et al., and they have found the correlation coefficient, that is R value of 0.6, and based on that we have calculated the sample size, and the statistical analysis has been conducted as per the established methods. So the further assessment of baroreflex sensitivity, heart rate variability, and blood pressure variability, we have recorded the beat to beat blood pressure as well as the ECG minimum for the 5 minute at the baseline condition, and the subsequent parameters has been derived by the compatible software. For the baroreflex sensitivity, we have used the NeuroCard software, and for the heart rate variability, we have assessed with it with LabChart software. Sorry. So baroreflex sensitivity has been analyzed by sequence and spectral method. So BRS was calculated by averaging the slopes of regression line between the RR interval and the blood pressure. Blood pressure, we have calculated the BRS by sequence method for all the mean blood pressure, systolic blood pressure, as well as the diastolic blood pressure values. And for the spectral method, the baroreflex was computed by dividing the amplitude of RR oscillations with the amplitude of corresponding oscillations in the systolic, diastolic, as well as mean blood pressure changes in the low frequency and the high frequency band. And heart rate variability is assessed by the LabChart software. So this table is showing the demographic and other variables of the subjects, and usually the patient, as the table shows, the patient were from the age group of between the 40, we have set the inclusion criteria from the 35 to 55, but usually we found the patients more in the range of the 40 to 50 years of the age group, and other parameters are also there. As far as correlation analysis were concerned, when we assess the association of different variables with that of nerve conduction velocities and insulin resistance and other variable with that of the various parameters of heart rate variability, we found significant association with the nerve conduction velocities as well as with the insulin resistance. However, the same thing we could not find so much of association between different variables. We did not find in the blood pressure variability parameters in the case of systolic or mean or the diastolic blood pressure variabilities, although few parameters show association only with the few parameters of the nerve conduction velocities. Now coming to the baroreflex sensitivity parameter per se, here also we didn't find so much correlation as we found with the heart rate variability parameters. So it's still establishing the fact that yes, heart rate variability is better correlated with other functions in the recently diagnosed type 2 diabetes mellitus. So the major finding was that significant association of insulin resistance with heart rate variability parameter were found, however, not with the BPV and the baroreflex sensitivity parameters. So HOMA-IR was not found to be associated with any to these later parameters. And the Saito et al. Has already reported, and few studies are more where they have reported the association of insulin resistance with the HRV parameters. However, to the best of our knowledge and search, we didn't find any study where association of insulin resistance with the BPV, blood pressure variability, and baroreflex sensitivity has been carried out in the recently diagnosed type 2 diabetes mellitus. Although long-standing, there are few studies in the long-standing diabetes mellitus, and we didn't find any association with the insulin resistance with nerve conduction velocities. However, one study, Ko et al. Has already reported, but that is in the long-standing diabetic patients. In one study by Sigo et al., it is recently done in 2019, and in this study, they have did the nerve conduction velocities. They have studied the association of NCV with that of the BRS parameters, but in the pre-diabetic patient, they didn't find any association, any abnormality basically. And they, in the long-standing, after 5 years, they followed up, and there they find that okay, abnormality of BRS was there in the patients of diabetes mellitus. So this may be one of the reasons why we also didn't find the association of insulin resistance with the BPV and BRS parameters. So with further studies with different disease duration, although I have studied, my participants were recently diagnosed, so with different disease duration, restricting the age limit or the gender things. So we can further very well, we can do for better understanding of, to better understand the pathophysiology behind the neuropathy in the diabetes mellitus. So we conclude that autonomic functions.
Last 1 minute.
Okay. We conclude that autonomic functions and peripheral nerve conduction velocities are correlated in the patients of recently diagnosed type 2 diabetes mellitus, and insulin resistance is found to be correlated with few parameters of autonomic functions, but not with the peripheral nerve conduction velocities. These are the references. Thank you, ma'am. Thank you, sir. Yes, ma'am. Yeah, ma'am. It was basically in collaboration with the Department of Internal Medicine, and we have set the criteria of the type of diabetic patients which have been diagnosed within the 1 year. So within the 1 year of their diagnosis of type 2 diabetes mellitus without any comorbidities, that means no hypertension and anything, and without any complication. Many patients present with that some tingling or some other thing. So without any complications, yes, ma'am. Okay, thank you, sir. Thank you, ma'am. Thank you, sir.
And we call Dr. Kavita. So next speaker will be Dr. Kavita, Professor Sri Ramachandra Medical College, Chennai, presenting on anti-neuropathic effect of 3,4-dihydroxyflavone involving potassium ATP channel, adenosine and GABA receptors against paclitaxel induced peripheral neuropathy in mice. Dr. Kavita, please start the presentation.
Yes, sir. Can you enable me for a screen share? I'm not able to share the screen, sir. Am I audible, sir?
You're audible.
The host displayed participants screen sharing, like that is coming, sir. Can you enable me to share my screen, sir?
Yeah, please. Can we make her a host? Check now. Can you share?
It's not coming, sir. It's not coming, sir.
Yeah, we are checking. Try now.
It's coming in the similar way only, sir.
We have made you a host.
Do we have any other offline contestant or participant here?
Are you, have you logged in on 2 devices?
One second, sir.
Dr. Kavita? Dr. Kavita, am I audible to you?
She is logged out.
Next speaker. We apologize for the technical delays. The next speaker, sir, kindly introduce the next speaker.
Next speaker will be Dr. Nadima Rafiq, Assistant Professor, Government Medical College, Baramulla. She'll be talking on effect of insulin in pregnancy outcomes and progression in women with gestational diabetes mellitus. Dr. Nadima Rafiq, you can start the session. Dr. Nadima Rafiq, can you hear us?
Dr. Nadima Rafiq.
Sir, excuse me, sir.
Yes, ma'am, you are audible to us.
Yeah, sir. I'm not enabled to share my screen. It's coming in again and again like that. Like host disabled participant screen sharing only, it's coming, sir. Yes, sir.
We are checking, ma'am.
Yeah.
Try now.
Yes, sir. So, seen, sir? My screen is able to see, sir?
Yes, ma'am.
Is it moving, sir?
Ma'am, try changing the slides.
Yeah, is it moving, sir?
No, ma'am.
Oh. I don't know what is the.
Ma'am, you can disconnect from the PowerPoint and then maybe start again. Just the slide part.
Okay, sir. So now it's moving, sir?
Ma'am, the slides are not visible yet.
Oh.
Yes, ma'am.
It's not moving, sir?
It's moving, ma'am. Ma'am, you can
But
start the
not.
presentation.
Yeah, sir.
Ma'am,
It's like.
Yes,
Okay,
ma'am.
sir. Sorry for the disturbances, sir. So my title is Anti-Neuropathic Effect of 3-4-Dihydroxyflavone involving ATP-sensitive potassium channel adenosine GABA-A receptor against paclitaxel-induced peripheral neuropathy in mice. Chemotherapy-induced peripheral neuropathy is the most common adverse effects of the first-line anti-cancer drugs like taxanes, platinum analogs, vinca alkaloids, and proteasome inhibitors. Painful peripheral neuropathy is the most dose-limiting side effects of taxanes, affecting up to 97% of paclitaxel-treated patients. It has a huge impact on the quality of life for the cancer patients, and its treatment adherence remains highly changing till now. Various flavone derivatives have demonstrated the anti-nociceptive and anti-inflammatory effect. Previous studies have also demonstrated the potential usefulness of few flavone derivatives in chemotherapy-induced peripheral neuropathy. Earlier investigations with 3-4-dihydroxyflavone in various doses against paclitaxel-induced peripheral neuropathy in mice has demonstrated the anti-neuropathic effect significantly in dose-dependent manner. The present study was intended to evaluate the possible mechanisms involved in anti-neuropathic effect of 3-4-DHF against paclitaxel-induced peripheral neuropathy in mice. So, objective of my studies is am I audible?
Yes, please, you're audible.
Yeah. The aim and objective of my study is to investigate the possible neuronal mechanism in amelioration of paclitaxel-induced peripheral neuropathy by 3-4-dihydroxyflavone involving ATP-sensitive potassium channels, adenosine receptors, and GABA-A receptors by administering suitable interactive drugs. Materials and methods: I have chosen Swiss albino mice weighing 20 to 25 grams of either sex, and it's been obtained from Mass Biotech Chengalpattu. It's a registered breeders, and here the animal has been kept in a standard conditions as suggested by the guidelines of CPCSEA, and the experimental protocol was approved by IAAC, and the experiments been conducted. The drugs chemicals used in the studies, the test compound is 3-4-dihydroxyflavone that is being obtained from Research Organics, and the dose used here is 200 mg per kg subcutaneously. And paclitaxel is being used as a chemotherapeutic agent to induce the peripheral neuropathy in mice. Other interacting agents that's been used to investigate the mechanism of studies are bicucline, caffeine, and glibenclamide have been used, and all these drugs were prepared freshly on the day of experiment and administered either by subcutaneous or intraperitoneal route as given by the reference in a volume of 10 ml per kg of body weight. In the methodology, how we have induced the peripheral neuropathy. So we have randomizely divided the mice into several groups and been administered paclitaxel 10 mg per kg intraperitoneally on the first day. And we have kept a separate group of mice that is being treated with a vehicle. The manifestation of the peripheral neuropathy, such as mechanical allodynia, cold allodynia, thermal hyperalgesia, were assessed 24 hours later by employing Von Frey's anesthesiameter and acetone bulb test, hot water tail immersion test respectively. A dose of 3-4-DHF that elicited maximum response against the paclitaxel-induced neuropathic manifestation in my earlier study, and which was selected for investigating the mechanism involved in the anti-neuropathic effect. So after the initial assessment of the peripheral neuropathy manifestations, animal either received vehicle or interacting agents. The interacting drugs that's been used here are glibenclamide to investigate involvement of ATP-sensitive potassium channel, caffeine to investigate the adenosine involvement, and bicucline to assess the GABA effect. So 15 minutes later of administering the interacting agents or vehicle, the animals were treated with a vehicle or the test compound 3-4-DHF 200 mg per kg, and again subjected to the behavioral assessment test 30 minutes later. So this is the schematic diagram for the study design. So day 1, we have administered paclitaxel for all the groups of mice. And next day, after 24 hours, we assessed the neuropathic manifestations and assessed by mechanical allodynia, cold allodynia, and thermal hyperalgesia. So 15 minutes later, we have been administered interacting drug, either caffeine, bicucline, or glibenclamide. Then 30 minutes later, we administered the test dose, and 60 minutes we have been assessed whether there is a reversal of anti-nociceptive effect of this test compound. So these are the different groups we have been used. So group 1 is a vehicle plus vehicle, group 2 vehicle plus the test compound, 3 and 4 or 3 groups have been used along with the vehicle, and 3 interacting drugs have been administered along with the test compound. So this is a methodology we have been adopted to assess the mechanical allodynia with a Von Frey's anesthesiometer. This has been followed in the Takasi et al. References. Here the mouse was housed habituated for 10 minutes in transparent plastic boxes with a floor-made wire mesh. After adaptation, the anesthesiometer was applied 5 times perpendicularly against the plantar skin of the each hind paw with an interval of 30 seconds. So paw withdrawal scores was ranked 0, no response, 1, move away from stimulus, immediate flinching is a score 2. Some of the 10 values was considered as a paw withdrawal response score. So paw withdrawal response score was noted prior to the drug in treatment and 30 minutes after the administration of the test compound or the vehicle. Similarly, the second parameter what we have assessed is called allodynia by acetone spray test. Here, the mouse was housed habituated for 10 minutes in the transparent plastic boxes with a floor made of wire mesh. After adaptation, acetone bubble formed at the tip of the 1 ml syringe was applied to the plantar skin of each hind paw, and paw withdrawal response was observed 20 minutes with a stopwatch. The paw withdrawal responses was ranked as follows: 0, no response; 1, immediate withdrawal; 2, prolonged withdrawal; 3, licking or biting of the hind paw. The response was measured 3 times in each paw, alternately at an interval of 1 minute, and some of the 6 values were considered as a paw withdrawal response score. So it was noted before the treatment and 30 minutes after the administration of the test compound or the vehicle. So the third parameter is the thermal hyperalgesia. It's an hot water tail immersion. Here the mouse was restrained in the mouse holder, and the tail 1 centimeter from the base of the mouse was immersed in the hot water maintained for 8 plus or minus 0.5 degrees C. The time taken to flick the tail from the hot water was taken as a reaction time, and we kept the cutoff time for 20 seconds, and the reaction time was noted prior to the treatment and 30 minutes after the treatment or vehicle. So the statistical analysis for the mechanism of the studies, we have adopted 3-way ANOVA followed by post-hoc Dhanwantari multiple comparison was used with a software package of SigmaPlot version. So results expressed in mean plus or minus standard error, and also here probability values less than 0.05 was considered as a statistically significant. So what we have observed in the dose response analysis, so different doses of 3-4-dihydroxyflavone or gabapentin produced significantly reduction in paw withdrawal score from mechanical and cold allodynia, and also we are able to see the thermal hyperalgesia. There is an increase in the significant increase in the reaction for the trail withdrawal response from the hot water. And this is the observation what we have made with the 3 doses and compared with the gabapentin. Here you can see the maximum decrease in the paw withdrawal score with the mechanical allodynia and cold allodynia with the 3-4-200 milligram per kg, and maximum increase in the reaction time in thermal hyperalgesia. So we have chosen this 200 milligram per kg of 3-4-dihydroxyflavone as a selected dose for extending our mechanism studies. So we have been testing for this 3 channels involved, receptors involved in the mechanism of neuropathy. So glibenclamide, the effect pre-treatment on paw withdrawal and tail rest response of 3-4-dihydroxyflavone on paclitaxel induced peripheral neuropathy in mice. So we can see in the mechanical allodynia, so glibenclamide, so that we can see there is a decrease in the paw withdrawal score with the DHF. But when we give the interacting substance, glibenclamide. Yeah, yes, sir. Yeah. So I just only two slides, sir. I will finish it off. You can see that increased the reversal of the anti-nociceptive effect with the interacting drug glibenclamide. This shows the involvement of potassium ATP sensitive potassium channel, and caffeine also you can see the reversal of the anti-nociceptive with the cold mechanical allodynia and thermal hyperalgesia. Bicuculline, this involvement of GABA receptor is also could be demonstrated with the increased reversal of the response paw withdrawal score with the mechanical cold allodynia and thermal hyperalgesia. So thus the paclitaxel induced the neuropathic manifestations, and 3-4-flavone significantly reduced the paw withdrawal response with the mechanical and cold allodynia and increased flick response in thermal hyperplasia due to paclitaxel induced peripheral neuropathy. So pre-treatment with this interacting substance like glibenclamide, caffeine, ibiclocolin has demonstrated it's a significant reversal of this anti-neuropathic effect of a 3-4-dihydroxyflavo, indicating the involvement of ATP channels, adenosine in GABA receptors. So conclusions, it's been identified that the involvement of ATP sensitive potassium channel adenosine GABA receptor in anti-neuropathic effect of 3-4-dihydroxyflavo against a paclitaxel-induced peripheral neuropathy. And we've been progressed for the in silico study to corroborate this mechanism with the binding interactions of this compound in the above target. These are my references. Thank you very much, and sorry for the technical glitches.
And thanks, Dr. Kavita, for
Yes,
the
sir.
detailed presentation. But
Yes.
there are no questions from the judges' side. Thank you so much.
Okay, sir. Thank you, sir. Thank you very much, sir.
I request the contestants and the participants to please stick to the norms of the session. They must not exceed their time limit. 8 minutes are for speaking or presenting the session, and 2 minutes are allotted for the question round. Our judges, though very friendly people, but judges being judges, they would penalize you for the same. Thank you. I request the judges to introduce the next speaker. Ma'am, I'll introduce. If you Dr. Nadima, please proceed with your presentation.
Good morning. So is my screen there on the? Can you
Yes,
see my
ma'am.
screen?
Yes, ma'am. We can see your screen.
Okay,
Please.
thank you, sir. Good morning, chairperson, judges, colleagues, and my dear friends. Myself, Dr. Nadima from GMC Baramulla. I'm going to present the paper, the title of which is Effect of Insulin on Pregnancy Outcomes and Progression in Women with Gestational Diabetes Mellitus. Gestational diabetes mellitus is the diabetes which is diagnosed in the first or second trimester of pregnancy and is not pre-existing type 1 or type 2 diabetes mellitus. Gestational diabetes mellitus is the most common metabolic disorder in the pregnancy. The medical nutritional therapy associated with physical activity and glycemic monitoring are the first and the fundamental aspects of therapeutic approach. The goal of managing women with GDM is to reduce the adverse maternal and neonatal outcomes. Studies have shown that the strict glycemic control throughout pregnancy can effectively reduce adverse fetal-maternal outcomes. According to the American Diabetic Association, who recommends insulin for the treatment of GDM when the medical nutritional therapy and the lifestyle management fail to maintain the adequate glycemic target. Various studies show that there is an improved rate of macrosomia in the newborns of GDM women who are treated with insulin as compared to those women who are not treated. But in contrast, there are various studies who found that higher large gestational age and cesarean delivery rate in women with the GDM require insulin compared to those that were managed with diet control alone. So we, in our study, we hypothesized that the women with the GDM on insulin representing a severe form will have an increased risk of maternal and neonatal complication and rapid progression to postpartum diabetes. The aim and objective of our study was that we tried to study the clinical characteristics, perinatal outcomes, and the incidence of postpartum diabetes in women with GDM treated with and without insulin. It was a prospective cohort observational study of GDM patients. Total 178 patients with GDM were diagnosed after the first trimester. Subjects were divided into two groups, GDM with and without insulin. Study was done over a period of 2.5 years. Demographic, clinical variables, and fetal-maternal outcomes were recorded between the two groups. The postpartum glycemic status was determined at 1 and 6 months. First we tried to get out the first clinical diagnosis that we did was 75 OGTT was done, in which the diagnosis of GDM was made when any of the following plasma glucose values were met or exceeded, that is fasting blood glucose level 92 milligrams per deciliter, at 1 hour 180 milligram per deciliter, and at 2 hour 153 milligram per deciliter. The eligibility criteria included the diagnosis of GDM having the age of more than 18 years based on the American Diabetes Association, while those who were excluded who were having pre-GDM, GDM diagnosed in the first trimester, chronic systemic disease including essential hypertension, and all those diseases which were affecting the metabolism. The clinical parameters that we studied, the data regarding the age, height, weight, signs of insulin resistant and obstructive history were included, while as and various other factors were also included. Maternal outcome was assessed. Maternal outcome assessed where gestational hypertension, preeclampsia, preterm delivery, antepartum hemorrhage, postpartum hemorrhage, while as birth outcome were recorded by the route of delivery, fetal birth weight, small gestational age, large gestational age, NICU admission, hypoglycemia, spontaneous abortion, and stillbirth. Various biochemical parameters that we studied were CBC, KFT, self-monitoring blood glucose, and HbA1c were estimated, while as USG was done for the fetal well-being. Treatment and monitoring was done. Standard care lifestyle modification of diet and exercise were done. Metformin and or insulin was used. Insulin was recommended for those in which the fasting and or pre-meal or 2-hour postparental blood glucose reading were outside the range. That means more than 2 readings within 1 week, according to the American Diabetes Association. Women who were reluctant to use insulin or in which there was metformin failure or intolerance to metformin, in those cases we used the insulin. Women with GDM were followed on first 1 to 3 weeks basis. The post-glycemic status diagnosis was done, and the post-glycemic status was done by 75 OGTT at first month and the 6 months of postpartum, in which the fasting blood glucose was taken more than 126, and postparental 2-hour postparental was taken as more than 200 milligrams per deciliter. These are the various definitions which we used for the various terms. The statistical analysis was done by SPSS version 20. The results that we obtained were the total 236 hyperglycemic patients were found who were pregnant, and out of them we excluded certain, and those that we included were 54 patients which were on insulin and 124 patients which were not on insulin. This is the chart which represents the clinical presentation of the various the clinical characteristics of the two groups, the insulin group and the non-insulin group, which include the age, pre-pregnancy weight, and obesity and gestational age diagnosis. They were found to be statistically significant in insulin group. Similarly, the family history, previous history of GDM, and obesity in pregnancy, they were also found significant in insulin group. And similarly, if we see the laboratory diagnosis, in the laboratory diagnosis we saw that the fasting blood glucose and 1 hour post-load glucose, 2 hour post-load glucose, and even HbA1c were statistically significant in insulin group than that of the non-insulin group. This is the chart showing the maternal outcome in patients with GDM with and without insulin. When we adjusted the p-value, we found that the polyhydramnios and the cesarean section were significantly higher in the insulin group as compared to the non-insulin group. The p-value for age, BMI, obesity, gestational age at delivery, and glycemic control. This is the chart showing the neonatal outcome in the patients with GDM with and without insulin, in which we found that in neonatal outcome, large for gestational age and macrosomia, and this hypoglycemia was found to be statistically significant in insulin group, and the p-value
1 minute left.
And the p-value was adjusted for BMI, obesity, gestational age, and glycemic control. This is the chart showing the postpartum glycemic status of the two groups, both showing that after first month and 6 month, there was a higher 15.6% as compared to 3.8% in the first month, and in the 6 month, 26% as compared to 5% in this on the 6 months. These are the various parameters, which show the factors, the individual factors which were at higher risk, which we found in case of the insulin group. This is the chart which shows the multiple logistic regression analysis, when the various factors were compared, and these variables were predictive of the postpartum diabetes in insulin receiving GDM. They were insulin used in the previous GDM, gestational age at diagnosis, obesity in pregnancy, gestational age at insulin initiation, and HbA1c was found statistically significant. We conclude our study that there were 30% where GDM were with insulin, and 69% were without insulin. The women with GDM and insulin group were older, had a higher frequency of pre-pregnancy and maternal obesity, family history of diabetes, previous history of GDM, signs of insulin resistance, and diagnosis of GDM early in the pregnancy. The frequency of polyhydramnios and cesarean section was found to be higher in the insulin group, while as postpartum diabetes at 1 month and 6 months was significantly higher in the GDM with insulin than without insulin. And logistic regression, which showed the higher risk of GDM at the earlier trimester, need of insulin treatment, and requirement of insulin early in the pregnancy, higher dose of insulin, high fasting, and glycated hemoglobin significantly increased the risk of having postpartum diabetes in GDM women with the insulin. The key message to our study is that the GDM women who were treated with insulin have a higher baseline risk profile. Insulin did not prevent adverse maternal and neonatal outcome. GDM women with insulin are at rapid progression to postpartum diabetes. Women with GDM on insulin need early aggressive management of glycemia and delivery in an institutional setting where expertise and modern neonatal facilities exist. Thank you.
Congratulations for such an elaborate study, but I feel adding some physiological parameter to your study could have made it more acceptable to the physiology fraternity.
Ma'am, we have taken the baselines are all physiological parameters.
And height, weight.
Yes, they were taken as, but here in the presentation, I have not shown that. I have shown the significant ones. Rest we have taken the baseline, we have taken the height, weight, then the BMI, all those were taken. And the blood pressures were also measured.
Thanks, Dr. Nadima, for the presentation. Did you screen the patients, the pregnant ladies for obstructive sleep apnea?
No, sir, not for obstructive sleep apnea.
See, your results are showing that pregnant ladies who require insulin, they are high risk profile, and they are more prone to postpartum diabetes as well as complications during the birth.
Yes, sir.
But what we know now very clearly is that obstructive sleep apnea is highly prevalent in different trimesters of pregnancy, number one.
Mm-hmm.
Number two, untreated obstructive sleep apnea leads to insulin resistance.
Yes, sir.
And your findings of insulin not working very well and also complication rates being high, it may be a secondary indicator that you might be missing one very important parameter of undiagnosed obstructive sleep apnea leading to insulin resistance. Because what we know now further is, if we treat untreated obstructive sleep apnea during pregnancy, it improves the gestational diabetes mellitus outcomes. It improves fetal and pregnancy outcomes. It improves insulin resistance and decreases the requirement of insulin during pregnancy. So I personally feel there is a need to consider.
Yes, sir. Yes, you are right. For the further studies, we can add for the obstructive sleep apnea. Although we are continuing the study of metabolic syndrome in case of these pregnant ladies and seeing the outcome. So we can add in that study, we can add one of the parameters for this obstructive sleep apnea. Thank you so much for your suggestion, sir.
Thanks.
Thank you, sir.
We'll proceed with the next speaker. proceed with our next section for the day, symposium number 5. The title of the symposium being I extend my heartfelt congratulations to all the participants for the free paper presentation. Now I request Dean Sir to please felicitate our judges for the session. I request the judges to please be on stage. Dr. Tripatdeep Singh, we thank you. Dr. Bharti Bhandari. Audience, please give a loud applause.
I think it's connected. It is connected. It is connected. Okay, 1 second. इसमें जो है आपकी प्रेजेंटेशन ये भी आप ट्रांसफर कर दीजिए. अच्छा, मैंने
So now we begin with the next section, Symposium 5. The title of the symposium being Active Learning Strategies for CBME, Challenges and Solutions. The chairpersons for the session will be Dr. Farah Khali from UCMS New Delhi and Dr. Madhuri Tranikanti from AIMS Bibinagar. I request the chairpersons to please chair the session. Dr. Farah Khalik is working as Director Professor in Department of Physiology at University College of Medical Sciences, GDP Hospital, Delhi. She has been awarded Professor R.C. Shukla Oration Award for Best Research Work in Cardiovascular Physiology for the year 2012 and also won Silver Medal for Best Paper in 10th Annual Conference of UP Chapter of Obstetrics and Gynecology. Dr. Madhuri Tranikanti is Additional Professor in Department of Physiology at AIMS Bibinagar, Hyderabad. With more than 18 years of teaching and research experience, she has held various responsibilities for being Registrar at ESIC Medical College, Sarnath Nagar, an external member, Institutional Ethics Committee from Nizam's Institute of Medical Science at Hyderabad. She has vivid experience in cancer research, breast cancer, oral cancer. Also, she has earned many awards and grants to her name. I request the chairpersons to please introduce the speaker and begin with the session.
Good morning. First of all, I want to invite Dr. Himani Aluwalia, who's the first speaker of this symposium. She's Director Professor and Head of the Department of Physiology and Registrar at VMMC in Safdarjung Hospital. She has rich experience of 26 years in undergraduate and postgraduate teaching of physiology. She has immense contribution through her research work in areas of neurophysiology, pulmonary functions, medical education, and medical humanities. Dr. Himani, please.
Thank you, Dr. Farah and Dr. Madhuri. Nice to see colleagues and friends as a chairpersons, and a very happy and good morning to all the delegates and all the senior faculty members. The Dean sir is here. So I'll start my session. And there's a little correction which I want to make. I used to be the registrar. I was a former registrar. Now I don't hold that office, that post. That's fine. I just wanted to clear that. So today's session is on medical education, as all of you can see. And we are going to be having this session in three parts. I'll be talking about the introduction to active learning strategies, challenges and solutions. And followed by that, we will be discussing particular techniques which we try to implement in our institution by my faculty members, Dr. Mantri, who did flipped classrooms, and Dr. Shoman Manna, who did problem-based learning. So there will be specific sessions, while I'll be giving an overview that what is active learning. Now, it is very, very important in today's times. So my session is going to be on active learning, and I have kind of planned it, what we expect out of students. Before we go on to understand about what is active learning, we should know what we expect out of students, what is expected from the student of today. Secondly, what the students expect out of the teachers. We are always expecting, you know, हमारे बच्चे ऐसा करें, हमारे students ऐसा करें, हमारे बच्चे ऐसे behave करें, ऐसे clinical procedures करें. आवाज ज्यादा जोर से आ रही है? Okay. So what the students, they expect, we expect a lot from the students, but what do the students expect from us? And after that, in that background, I'll be discussing about what is active learning, what is the relevance of active learning, followed by challenges of active learning, and finally, the advice for educators, for all the medical educationists. Now, going on to the first part, we all know about this beautiful cover page of the document prepared by National Medical Commission. And we know about that the competency-based medical education, which was launched in 2019, it is kind of the most controversial and the most talked about curriculum change, which has been introduced by the erstwhile MCI and now NMC. So CBME has got certain goals. They want to produce Indian medical graduates, as we know, who should have requisite knowledge, skills, attitudes, values, and responsiveness, so that he or she may function appropriately and effectively as a doctor of first contact of the community, while being globally relevant. सर्वगुण संपन्न, सब कुछ होना चाहिए. 36 गुण से हमारे जो स्टूडेंट है वो तैयार करने हैं हमारे को. And what are the different roles? एक आदमी का क्या रोल हो सकता है, एक डॉक्टर का क्या रोल हो सकता है? He should be a good clinician, should be a good leader and member of the healthcare team and system. Good communicator. He should know how to communicate with his peers, with the patients, of course, जो हमारा पहला first and foremost objective है. And in community, how should they communicate? He should be a lifelong learner. मैं आज इतनी बड़ी senior हो गई, मतलब 50 plus हो गई, लेकिन lifelong learner बनाना है, हमें वो attitude रखना है students में. And a professional who is committed to excellence, is ethical, responsive, and accountable to patients, community, and to the medical profession. So ये हमारी expectations हैं. The new graduate medical education regulations attempts and intends to enable the learner to provide healthcare to the evolving needs of the nation and the world. And we all know it is a competency and skill-driven curriculum in which we want a holistic development of the student in all the domains: knowledge, skill, attitude, cognitive, psychomotor, and affective, as we call them technically. And the student has to be proactive partners in the learning progression. They should lean in and engage and develop professional competency, unlike the previous one, where the students were passive recipient of knowledge. हम आए, knowledge, हमने lecture सुनाया और हम चल दिए. उसके बाद हमने exam दे दिया उनको एग्जाम उन्होंने दे दिया, वो पास हो गए और वो आगे चले गए। तो अब ये सारा सीन चेंज हो गया। नाउ द स्टूडेंट्स आर द मेजर स्टेक, होते पहले भी थे, लेकिन बीइंग द स्टेक होल्डर्स उनका रोल ज्यादा अच्छे से डिफाइन किया गया है और रिस्पॉन्सिबिलिटी सीबीएमई में स्टूडेंट के ऊपर ज्यादा है। इट्स अ स्टूडेंट ड्रिवन और द लर्नर ड्रिवन प्रोग्राम। सो दिस इज व्हाट ऑल वी एक्सपेक्ट फ्रॉम आवर स्टूडेंट्स। सर्वगुण संपन्न हो जाए, अच्छे से पढ़ाई करें, एक्टिवली पढ़ाई करें, जो सेशन की एसेंस है, एक्टिव लर्निंग पे इंडल्ज करें। अब उन्हें इंडल्ज कौन करवाएगा एक्टिव लर्निंग में? टीचर्स कराएंगे। तो हम समझते हैं कि एक्टिव लर्निंग है क्या। सो गोइंग टू द पॉइंट नंबर 2, what the students expect from teachers. They expect that they should be treated as adult learners and we should go from pedagogy to andragogy. They are all 18 plus students, लेकिन हम उनसे बात करते हैं, बच्चे तुम ऐसा कर लो, बेटा तुम ऐसा कर लो। That's perfectly fine, वो हमारे जूनियर्स हैं। बट कहीं ना कहीं एक सबकॉन्शियस हमारे दिमाग में ये स्कूल वाला जो है ना एक सेटिंग है, अभी भी धीरे धीरे चेंज होगा कि दे आर एडल्ट लर्नर्स, दे आर इंटेलिजेंट, दे आर टेक सेवी, and we have to evolve and adapt according to their needs. We have to make our lessons interesting. The students expects out of us that the lesson should be interesting, because the lectures, we all know the backbenchers, they always doze off. So I'll make sure my backbenchers are not dozing off. As a teacher, I'll try to make my session as interesting as possible. So the teacher should keep the young energetic minds engaged, and that is a major challenge for all of us, to make them see the relevance of what is being taught and how to use it in real case scenarios and situations. I want to bring in a very important point here. In today's world, the student says, I know everything, everything is available on the click of the mouse, everything is available on the internet. PDF की books आप देखो, PDF देखो books की, मेरे पास ये होंगी नहीं तो, oh sorry, actually I have a, I think that's a good thing. Yeah. So the thing is, मेरे पास ही कम से नहीं तो 100-200 तो PDF होंगी, इजीली अवेलेबल है आजकल सब कुछ, कोई बुक चाहो डाउनलोड कर लो। तो हमारा यहाँ पे हम लोग जो बैठे हुए हैं मेडिकल एजुकेशनिस्ट, हमारा क्या रोल है? हमारा रोल ये है, जो मैं हमेशा से कहती हूँ, कि बहुत सारा सामान पड़ा हुआ है पढ़ने के लिए, बहुत सारा मटेरियल पड़ा हुआ है, लेकिन एक जो टीचर होता है उसका मेन काम होता है टू स्टिमुलेट द माइंड सो दैट द स्टूडेंट गोज बैक, he refers to a few textbooks and find out whatever queries or whatever points were raised in the class or in the learning session. So it is the importance of the teacher can never and ever go away from our system or from any system worldwide, because एक teacher ही होता है जो young minds को ignite करता है, उनको stimulate करता है, they make them see the beauty of the concepts. So that is very, very important. So we have to understand our importance, and the students expect that the emphasis of training to be on higher order thinking. It should not be, ये जरूरी है बेटा ब्लड प्रेशर का नॉर्मल वैल्यू क्या होता है, बहुत जरूरी है जानना, उसके बगैर पेशेंट नहीं ट्रीट कर पाओगे। लेकिन ब्लड प्रेशर कैसे रेगुलेट होता है, कौन कौन से सेंटर्स इन्वॉल्व होते हैं, कैसे इंटरैक्ट करते हैं, तो वी हैव टू, हम पढ़ाते हैं उनको, ऐसा नहीं है। एंड प्लीज एक चीज मैं और यहाँ पे क्लियर करना चाहूंगी टू ऑल माई कोलीग्स, it is nothing something which new anything new which I am telling you, or it's a rocket science. We all have been doing it. We all have been doing it. It's just a matter of making it more structured, making it more, you can say, well planned. So that is a thing. And educational professionals, they need to know how to navigate and harness technology advancements and changes so that they and their students can thrive. आप सबको पता है आजकल virtual लर्निंग का जमाना है, वेयरेबल टेक्नोलॉजी, आप गॉगल्स पहन लीजिए, आप पूरा ऑपरेट कर सकते हैं, आप पूरी की पूरी मेजर सर्जरीज ऑपरेट कर सकते हैं। आप गॉगल्स पहन लीजिए, आप यू कैन एक्चुअली गो इनटू अ लैब एंड यू कैन वर्चुअली यू कैन गो इनटू अ लैब। सो वी हैव टू कीप आवरसेल्व्स वेल वर्स्ड विद दैट, सो दैट कि मेरा स्टूडेंट मुझे आकर ये बोले कि मैम देखिए ये एक मोड ऑफ वर्चुअल मोड अवेलेबल है, तो मेरे को उसके बारे में पहले से पता होना चाहिए, सो दैट माय स्टूडेंट कैन आइडेंटिफाई, देयर कैन बी अ बॉन्ड कि यस माय टीचर इज well aware and well versed about for whatever is going on in the world. So we have to keep up with the latest advances, learnings, and we have to understand shifting demographics, politics, and technology, different situations with different cultures. May we have to, as teachers, adapt to the need of the student and ultimately make a difference in the student's life. तो हमारी भी एक्सपेक्टेशन हो गई और टीचर की भी एक्सपेक्टेशन हो गई। नाउ लेट्स सी व्हाट इज एक्टिव लर्निंग। यहाँ पे एक्टिव लर्निंग कहाँ पे फिट बैठती है? Again, I'll be breaking up the main topic of active learning in what are the principles of learning. Broadly, I won't be going into too much of details. I know we have time crunch, so I'll be discussing about the Maxim 1 and Maxim 2 in very brief, and how active learning encompasses the learning principles. Thirdly, what are active learning techniques and activities? What is the role of student in active learning? And what is the role of teachers in active learning? And what are the uses and benefits of active learning? So first, going on to the principles of learning. Now, it's been 17वीं और 16वीं शताब्दी के अंदर कुछ principles of learning define किए गए थे. बहुत सारे French scientists थे, मैंने जानबूझ के उनका नाम नहीं डाला क्योंकि मैं information overload नहीं करना चाहती. But basic क्या था, उन्होंने 16 principles define किए थे. अगर आप परेशान न हो, मैं आपको 16 principles के बारे में नहीं बताऊंगी. These 16 principles were divided into two broad groups, Maxim 1 and Maxim 2, that is two umbrellas. Maxim 1 was about collecting information, knowing the facts, knowing what is where, how it is. एक nerve है तो उसकी कितनी branches हैं, artery है तो कितनी branches हैं, so factual knowledge. And the Maxim 2 was based on the spine of this basic knowledge, that once you have acquired the basic knowledge, how do you apply to the real world scenario? कहाँ पे मैं उसको use कर सकती हूँ? So these two are the basic, the principles, 16 principles, which have been divided in two umbrellas, and active learning takes off from there. That's why I said in the beginning only, this is nothing new. It is 200 or 300 years old. The only thing is we have to go back to our roots, press and refresh the memory button, and bring out new things and innovations in the background of the old things. So the first maxim is think it through, and the second maxim is make and use associations, use examples where one particular technique, one particular logic can be used in various situations. So, and the maxim 2 is very, very important, as it is the essence of active learning, as it focuses on techniques for organizing, storing, and retrieving information to be used in real life. So I'm not going to go through these. It's going to take a lot of time. We are on time crunch. So coming to the hitting the stone on the head, how active learning encompasses, draws, and takes off from the above principles. So active learning strategies or active learning stimulates, involves, and immerses the learner to gain knowledge and makes the learner understand the relevance or why a particular activity is being done, why a particular thing is being taught, why a particular exercise is being, we are putting in so many hours. हम पहले lecture करवा रहे हैं, फिर उसके बाद small group discussion करा रहे हैं, फिर हम patient दिखा रहे हैं, इस सब की relevance क्या है? So that is what the active learning encompasses from the old age principles of learning. And the main idea is that we learn best when we can see the usefulness of what we learn and connect it to the real world. So this, as I told you, some of the few French scientists, educationists, and this idea was developed by the philosopher Jean-Jacques Rousseau way back in the 18th century, 1712, and it influenced numerous educators in the early century, such as John Dewey and Maria Montessori. As you can see the Montessori, does it ring the bell? Montessori is the way of teaching in certain Montessori schools. So everything is, education for youngsters, education at the higher level, the principles are the same. So what is active learning? Active learning comprises a wide range of activities that are defined as any instructional method that engages student in the learning process, requires students to do meaningful learning activities and think about what they are doing. Reflection. Why am I doing this? What is the need of this? And as you know, in CBME, reflections make a very important part of CBME. Going back to the point 2, What are active learning activities? Activities that engage students, again, I'm repeating, in the learning process as opposed to sitting passively in the lecture theater and listening. And I will also make my lecture or my presentation interactive after a while so that my audience, they remain involved with me and with my team. So Monira Morris, PhD, she's assistant teaching professor and faculty director of Northeastern's higher education programs. And she says that active learning gives students a chance to develop higher order critical thinking and analysis skills. Going back to your revised basic workshop, the Miller's pyramid. The base is the knowledge. Above that is understanding. The level 3, 4, and 5 is higher order thinking, critical thinking, analysis, creating something new, synthesizing. So we want to teach our students in a manner. पहले दो तो बड़े अच्छे से चल रहे थे पहले वाले में हमारे सिस्टम में. अब हम ये चाहते हैं, थोड़े बहुत ऊपर वाले भी चल रहे थे, लेकिन अब हम ये चाहते हैं कि हमारा जो मेजर पार्ट है टीचिंग का, थ्रस्ट हमारा ऊपर के 3 लेवल्स पे होना चाहिए. एक बात मैं और कहना चाहूंगी, विद ऑल ड्यू रिस्पेक्ट, मैंने यहाँ पे मुनीरा मॉरिस का नाम लिया, अमेरिकन है, लेकिन ऐसा नहीं है कि हमारे मेडिकल एजुकेशनिस्ट काम नहीं कर रहे हैं, लेकिन शुरुआत थोड़ी इन लोगों ने पहले कर दी, इसलिए इनको थोड़ा सा क्रेडिट देना बनता है. बाकी हमारे देश में भी बहुत मेडिकल कॉलेजेस में बहुत काम है in active learning. So active learning activities, they can be utilized. It is not a very different, these techniques are not very different. They can be utilized in different settings and contexts. आप क्लासरूम में कर सकते हो, आप गार्डन में कर सकते हो, आप ऑनलाइन मोड में घर में बच्चे को बिठा के कर सकते हो, अपने ग्रुप ऑफ स्टूडेंट्स को हॉस्पिटल में कर सकते हो, प्राइमरी हेल्थ सेंटर में कर सकते हो. एडकॉम मॉड्यूल में तो है ही कि हम करके दिखाना है, उनको रोल प्ले करना है, एंड इट कैन बी टेलर्ड टू स्पेसिफिक ऑडियंस ग्रुप. देन एंड इट इज नॉट दैट कि एक्टिव लर्निंग करवाने के लिए आपको बहुत टाइम चाहिए, 2-3 घंटे, उसको प्रिपेयर करने के लिए आपको जरूर टाइम चाहिए. डॉक्टर मनप्रीत और डॉक्टर शोमन आपको बताएंगे, लेकिन आप चाहें तो 1 या 2 मिनट का सेशन भी तैयार करके अपने बच्चों को एक्टिव लर्निंग करा सकते हैं. देखिए मैंने बोला ना, बच्चों को, अपने स्टूडेंट्स को 1-2 मिनट के अंदर भी आप एक्टिव लर्निंग करवा सकते हैं, और चाहे तो 30 to 40 मिनट्स की एक्टिविटी करवा सकते हैं. So the educators can pique students' interest in a topic, foster a sense of camaraderie between students. Why do I say so? Because one of the active learning techniques, as I'll be showing you, is about peer collaboration. You collaborate with your peers, you discuss maybe in a pair or in a group, you have 3 pairs, think, pair, share, or in a group, and you kind of collaborate with them and enhances students' understanding of the subject matter. That is what we want. So what are, I think I went back, I'm so sorry on that. So what are the active learning techniques? It is basically the active learning techniques are based on experiential learning. The student experiences a particular technique, right? If I'm doing examination, physical examination, the student himself, I demonstrate to the student. But जैसे पहले मैं demonstrate करती थी, अब now the onus is on me to make the student do. ठीक है? Then case-based learning, you give a clinical case and then you tell the students to work about it. The details will be given by Dr. Manpreet. I'm not going into that. Flipped classrooms. Again, Dr. Manpreet will be telling you about that. Discussions on problem solving, case studies, role plays, movies, books, and other methods. Project-based learning, peer problem solving. As I told you, it involves one of the very important strategies is peer collaboration. उसके अंदर एक बड़ी मजेदार सी है जिक्सॉ मेथड ऑफ टीचिंग, जिसमें आप जिक्सॉ पजल्स मेथड ऑफ टीचिंग होता है. हम डिटेल में नहीं जाएंगे क्योंकि दिस इज जस्ट एन ओवरव्यू. एंड ऑफ कोर्स कुछ कोविड का धन्यवाद करना चाहिए और कुछ नए जमाने का. टेक्नोलॉजी एनहांस्ड active learning media, which includes audience response. We can have online audience response, we can have podcasts, we can have vodcasts, and as I told you, we have virtual patient simulations, and we have online games. Gamification. So these are all different types of active learning techniques. In fact, when I search the internet, there are more than 250 active learning techniques. लेकिन वो सारी की सारी मेडिसिन के लिए नहीं बनाई गई है, कुछ इंजीनियरिंग के लिए बनाई गई है, कुछ और चीजों के लिए बनाई है, कुछ ह्यूमैनिटी के स्टूडेंट्स के लिए बनाई गई है. तो एज जैसे मैंने बोला था ना, what is expected out of the teachers, the advice for the medical educations, we have to see what suits us the best, and we have to pick those techniques from that long list of more than 250 techniques. So I'm ending my session soon. So what is the, I think I clicked on the wrong one. Just a minute. Okay, so what is the role of students in active learning? As I mentioned in the very beginning, the responsibility is of the learner. The students have to take a proactive part in the learning cycle. They have to be engaged actively. They have to self-monitor their growth, their knowledge graph, their timelines, their milestones, their academic milestones. मैंने इतना सीख लिया कि नहीं सीख लिया? आज जैसे आपको पता है SLOs होते हैं. SLOs की एक सबसे बड़ी इंपॉर्टेंट बात होती है कि they're time bound. हमें उन्हें एक पर्टिकुलर पीरियड में अचीव करना होता है. So self-monitoring, self-directed learning, again CBME kind of lays a lot of stress on it. Working with peers and collaborate, responding to feedback. If I tell something to my student कि आपने ये चीज ऐसे नहीं करी, आपको ऐसे करनी चाहिए थी, ये टेक्निक आपको, ये सूचर आपको ऐसे नहीं लगाना चाहिए था मैनेक्विन पे, ये सही तरीका ये है, तो feedback. Adapting to new learning challenges, failing forwards. What is failing forward? Can anybody tell me in the audience? Failing forward. Failing forward is that you learn from your mistakes. You fail, you go back, you repeat. Kind of, you can say, a way of formative assessment. Again, a concept which has been introduced by CBME. So the student commits a mistake. As a facilitator, as a teacher, as a mentor, it is our duty not to label him, तू तो नालायक है, तू तो कर ही नहीं सकता. नहीं, उसको 2 बार कराइए, 3 बार कराइए. The ultimate aim is that he has to learn from his mistakes. Then they are responsible for their own learning. So in active learning, the 80% of the responsibility is of the student, that how he achieves his academic milestones. So this is just a diagram to show. Then going back to what are the role of the teachers in active learning? So sorry for this. I clicked twice. I'm about to finish my presentation. Just give me. Okay, I think, yeah. As I said earlier, mere repetition of, चाहे हम कितना भी मीडिया ले आए, चाहे हम कितना भी डिजिटलाइजेशन ले आए, चाहे हम कितनी भी नई नई टेक्निक्स ले आए, अल्टीमेटली टीचर की जो रिस्पॉन्सिबिलिटी है, रोल, सबसे पहले तो रोल, टीचर का जो रोल है, इट कैन नेवर बी, वी कैन नॉट अंडरमाइन इट. हम हमेशा रेलेवेंट रहेंगे in our field of education, and it is our duty to emphasize the relevant high yield tasks and correlate concepts to clinical application. Our duty is to make them see what is important, what is clinically important, what is clinically relevant. And we have to follow the basic cycle of setting objectives, teaching them and assessing them. कि जो हम पढ़ा रहे हैं वो वाकई उन्होंने समझा है कि नहीं समझा. Basic चीजें वही रहेंगी. Accentuating authentic performances, frequent feedbacks, faculty review of learning performance data in a systematic manner to improve learning and delivery. Blueprinting is very important part of it. Going back, revisiting your lectures, revisiting your teaching sessions. Where did we go wrong? What we could have done better? So that is the role of the teacher in active learning. So to give them a very good structured educational content which is of use to them, and it is not merely transferring कि मैंने कुछ knowledge बोली और उन्होंने सुन ली. So I think there's something wrong. Just a minute. So the uses and benefits of active learning, I think it's not getting clicked. I don't know what's wrong. Just a minute. Let me go straight to the. Okay, let's go to the challenges directly. Let's not. Now that is what technology can have, it can have slight lapses. जैसे अभी हो गया इंटरनेट कनेक्शन नहीं हुआ, मेरी पावर पॉइंट में वो हो गया, तो ये मुझे भी सीखना है, मुझे अपने स्टूडेंट्स को भी सीखना है कि संभाल लेना है चीजों को, चाहे वो आप क्लिनिकल केस कर रहे हो, कोई सर्जरी कर रहे हो, कोई माइनर सर्जिकल प्रोसीजर कर रहे हो, अगर बेटा कुछ ऊपर नीचे हो जाए तो संभालना आना चाहिए. It starts from the very basic this thing. So as a teacher also I should not get jittery, कि अरे मेरे तो पावर पॉइंट ऊपर नीचे हो गए, क्या होगा, डजंट मैटर. सो व्हाट आर द चैलेंजेस फॉर द टीचर्स? मोटिवेशन, ब्रेनस्टॉर्मिंग. मोटिवेशन बहुत चाहिए इसके लिए, एक्टिव लर्निंग टेक्निक्स के लिए, क्योंकि हमारे माइंड सेट्स बड़े फिक्स आइडियाज हैं हमारे. हम जितने भी, अब देखिए हमारी गलती नहीं है कि वी आर ऑल 50+ और इस टाइम पे CBME इंट्रोड्यूस किया गया. अभी हमारी जो यंग फैकल्टी है, दे आर स्टिल वेरी वेरी अडेप्टेबल, दे आर स्टिल वेरी ओपन माइंडेड. Some of us may be having some fixed ideas कि नहीं रहे, सब बेकार चीज है. उधर NMC कहता है कि टीचर्स का नंबर कम कर दो, स्टूडेंट्स का नंबर बढ़ा दो, और उधर कहते हैं कि एक्टिव लर्निंग टीचिंग होनी चाहिए. सो आवर चैलेंजेस आर इमेंस, रिक्वायर्स लॉट ऑफ टाइम. 15 मिनट के सेशन के लिए आपको 15 घंटे लगाने पड़ेंगे, ये मैथ मान के चलती हूँ. एफर्ट, ब्लूप्रिंटिंग बहुत जरूरी है. हम जो भी पढ़ा रहे हैं, हम जो भी असेस कर रहे हैं, उसकी ब्लूप्रिंटिंग इज वेरी वेरी इंपॉर्टेंट. Reservations and mental blocks I have told you, and there is lack of realization. This last point is very favorite of mine. The lack of realization that not only it is important that learning for students is made interesting, but for teachers also it should be something to look forward to and not a routine, monotonous and conditioned activity. मैंने पिछले साल सीरियस लिया था, इस साल भी सीरियस लेती हूँ, खत्म करती हूँ. कुछ नया करने की जरूरत नहीं है, कोई नया सिस्टम पढ़ने की जरूरत नहीं है. I mean, these are all, we are all humans and we have our limitations. Up students के challenges, there is definitely a gap, subtle and maybe not so subtle gap between the teachers and the students. The teacher, the student learner profile is different. 170 बच्चों के ग्रुप में, मेरे यहाँ 170 बच्चे हैं, आपके यहाँ 250 होंगे, कहीं पे 350 बच्चे हैं. सारे बच्चों का लेवल ऑफ लर्निंग और अंडरस्टैंडिंग सेम नहीं हो सकता है. तो कहीं ना कहीं मेरे ऊपर ये रिस्पॉन्सिबिलिटी भी है कि जो जल्दी सीख गए उन पे तो ध्यान देना ही चलता ही रहता है, लेकिन जो बच्चे नहीं सीख पाए उनको उस लेवल तक लेकर आना है जो उनके लिए मस्ट नो या मस्ट डू एरियाज. तो स्टूडेंट लर्नर प्रोफाइल इज डिफरेंट फ्रॉम ईच अदर एट इंडिविजुअल लेवल. इवन पिछले वाला बैच इज डिफरेंट फ्रॉम द करंट बैच. ठीक है, 5 साल में तो कहते हैं जनरेशन गैप आ गया. इंटर्न्स कहते हैं हमारे जमाने में ऐसा होता था फर्स्ट ईयर वालों, तो हम लोग तो एंशियंट है अगर देखा जाए तो. एंड द न्यू एज लर्नर हैज इन्यूमरेबल डिस्ट्रैक्शंस एंड डिस्ट्रैक्शंस हमारे लिए भी हैं. बच्चों को नहीं करना चाहिए, स्टूडेंट्स को नहीं करना चाहिए. डिस्ट्रैक्शंस हमारे साथ भी बहुत सारे हैं. एंड जो मैंने आपको पहले बताया था, क्लिक ऑफ द माउस, द नो ऑल एंड एवरीथिंग इज अवेलेबल ऑन द नेट एटीट्यूड ऑफ द स्टूडेंट्स. वी ऑल नो, वी आर ऑल पेरेंट्स, आवर चिल्ड्रन, आई मीन आवर, हमारे जो बच्चे होते हैं आप हमें, यू डोंट टेल अस, वी नो एवरीथिंग. सो दीज स्टूडेंट्स आर नो डिफरेंट. सो दीज आर द challenges from the students' point of view, and challenges of the system. The system is exam oriented. Finishing, madam, finishing. So advice for educators is, जितने भी मेथड्स हैं वो सारे के सारे नहीं यूज करने हैं. हमें यूज करना है जो हमारे लिए अप्रोप्रिएट है, हमारे एक पर्टिकुलर टॉपिक के लिए अप्रोप्रिएट है. एंड वी हैव टू बी इन सिंक विद ईच अदर. I mean, the students and the teachers have to be syncing each other. And without further this thing, I end my session here. And as Maurice says, students have a real thirst for learning. There is higher engagement with active learning than if we just give a lecture. I find that students want to absorb more and follow up. They reach out to me to have a dialogue, to enrich their understanding of what they are learning. Only thing is, we should know where we have to strike the match, where we have to ignite them. Thank you so much. I'm sorry if I kind of overshot a few minutes. And now I'll ask Dr. Shomin Manna, chairperson will be introducing him. Thank you so much.
Thank you, Dr. Himani. It was a wonderful presentation. I just want to add one more thing about, in your list of interactive methods of teaching. We introduced trigger films last year, and we taught ethics by means of trigger films, which were very small clips of 4 to 5 minutes. And it had a wonderful response. All the students were so interactive, and we had a very good response of that. So that also.
But as I told you, we are all doing it in one form or the other.
Yeah.
You're absolutely right. We are not anywhere from Morris.
Thank you so much, Dr. Himani. That was a wonderful, very nice session. Just one basic, coming back to the root problem, how do we ensure that the student is learning what we expect him to learn through this stimulation that you were talking about? So it's really, we stimulate all the time, but how do we ensure that the outcomes are
Can I answer that? Ma'am, that's what I'll be taking in the last session, the use of digital and the knowledge of computer and digital media. How we can use that to keep them engaged. उनको पता होगा किसी भी टाइम पे अभी एक क्वेश्चन आएगा मेंटीमीटर के ऊपर, उसका जवाब देना पड़ेगा. And depending upon कितने responses सही और कितने गलत है, मैं बता सकती हूँ कितने लोग ठीक से सुन रहे थे और कितने लोग नहीं सुन रहे थे. And if you go into the depth of the software, वो नाम भी मांग लेता है. तो आपको पता है ये अच्छा राजेश तूने गलत जवाब दिया, मालिनी तूने गलत जवाब दिया, सविता तूने सही जवाब दिया. So that's what I mean. There are more means to do that.
Thank you very much. So the next speaker for our session will be Dr. Saumen Manna. He is an associate professor in the Department of Physiology at BMMC and Safdarjung Hospital. He has conducted various research projects on amphibian and mammalian physiology in nerve conduction and pulmonary function tests. His special areas of interest are molecular and cell biology. Over to you, Dr. Manna.
Thank you so much, ma'am. Thank you for the introduction. So very good morning to all of you. So talk of my today's topic is case-based learning, our experience regarding its implementation, challenges and solution. So as you have learned in the first session that there are many methods of active learning strategies, but for medical student, we used to implement 3 major active learning strategies. And these 3 major active learning strategies, which we prefer to introduce for medical students, particularly for first year MBBS medical students, is problem-based learning, case-based learning, and flipped classroom. Now, these all 3 methods, they are structurally different from one another, but there is one thing common to all these 3 methods, and that is presence of a clinical case or a clinical problem. So we will give a clinical case or a clinical problem to each and every students for all of these cases, like for in case of PBL also, in case of CBL also, or in case of flipped classroom also. But as I told that all these 3 methods are structurally different from one another. So in my talk, I'm going to concentrate mainly on this CBL topic. But before going to CBL, I will give a brief introduction about the problem-based learning to differentiate between these 2 methods. And in the next page, in the next talk, my colleague will discuss about the flipped classroom part. So first, we are coming to the problem-based learning. So in case of problem-based learning, as the name suggested, that you are supposed to give a problem to the student. Okay, so the problem may be a clinical case, or the problem may be a clinical oriented real type scenario. So what the students are supposed to do? First of all, you remember the problem-based learning session is conducted on multiple days. You require multiple sessions for conducting the problem-based learning or PBL. So in the first session, you give a case, clinical case or a clinical problem to each and every student in the class, and you divide the whole class into multiple small groups, because this is a part of the active learning strategy. So the group, the student has to be divided into multiple groups. So after dividing in the group, when you present the case, when you give this clinical case to student, what the students are supposed to do? First of all, the student has to identify what are the problem lying in the clinical case and what are the questions arising in their mind to solve these clinical cases. And they also have to take an approach that how to solve these questions which are arising in their brain, which they do not know. So that is the biggest challenge for the student, that you are giving some case and they are searching their brain that whether they know the answer of this clinical case by using their basic knowledges or not. If not, then they are collecting the questions that these are the questions that I have to answer. I have to find out the answer to get into the solution of this case. After that, after identifying the problems and how to go about this problem, their job is to divide the learning task into groups. Means which group is supposed to solve the answer of which questions. This task will be divided into multiple groups. After this division, the first day session is over. The student will disperse from the class and they will go for a self-directed learning or a private study where they can use their books, or they can go to the libraries, use the different study material, or simply they can use the online resources to search about the questions which they have collected in the classes. So basically it's a deep learning into a particular problem where the students are the active components, students are the driver. He is searching the problem and he is searching also the solution. And then after few days, you must have to give few days for them so that they can take proper preparation. After few days, when they reassemble in the group on the second session, they are supposed to share their learning, whatever they are learned from their searching, self-directed learning. And after sharing their knowledge, they basically integrate their knowledge and generate a hypothesis that this may be the possible solution of this case. After that, each student from our group is supposed to present the possible solution. When one student of a group is presenting the solution, the other group may intervene. They may give some additional information. They may contradict also. So this way, the students learn the whole topic. And at the end of the session, the facilitator or the teacher are supposed to take an evaluation on the topic so that he or she could understand that whether the students have learned the topic properly or not. So this is the basic steps by which PBL is conducted. But as we can see here, that in case of PBL, the facilitator or the teacher is a very much passive. He or she is not doing much apart from giving these clinical cases, and students are the driver here. Students are the active component here, right? So obviously there will be some advantage and disadvantage of this thing that students are active and facilitators are passive. There will be some advantage also, there will be some disadvantage also. If you look at the advantage, then you will find out that PBL is very, very advantageous for stimulating the curiosity of the students. You know, they become a lifelong learner. They will learn how to solve a clinical problem which they do not know, because in their lifetime, when they become an Indian medical graduate, the problem will arise in their lifetime when that they will find out that they do not know about this particular type of cases. And they have to search the literature. So they will understand that how to search the literature, okay, how to build a teamwork and how to solve a problem. But the disadvantage of this method is that because faculty is not taking any active part or active component, there is always some chances that students, whenever they are searching literature, they may go in the wrong direction. They may get some wrong information, particularly from the internet or something like that. And faculty are not supposed to correct this misinformation in real time. That is one of the major disadvantage of this problem-based learning. And second disadvantage, obviously, that you are not utilizing the faculty's expertise, and there is no method to assess whether the learning is uniform in the group or not. So now, after discussing this PBL, we want to understand that what is the difference with PBL and case-based learning, that is a CBL. Now, first of all, if I go for the definition of the CBL, the articles, the literature is saying that there is no consensus regarding the definition of the case-based learning. But this group, that is the Thist, Leit et al., in their paper in 2012, Systematic Review and Meta-Analysis, they define the CBL is a form of inquiry-based learning and fits on its continuum between structure and guided learning. They gave another definition to this. The goal of the CBL is to prepare the students for clinical practice through the use of authentic clinical cases. It links theory to practice through the application of knowledge to the case using inquiry-based learning method. So, as you can find out here, the definition is particularly related to the utility of the CBL rather than the structural aspect of the CBL. That means if I want to understand, is there any gold standard steps by which we can perform CBL? Answer to this question is no. But obviously, there are some critical steps which you must have to follow if you want to conduct an case-based learnings. And because there are no gold standard steps, there are some confusion between different groups. And if you search article, then you will find out that different groups are conducted CVL in a little different manner. But majorly the steps are same. And what are the steps in CVL? Again, the same thing. A clinical problem or a clinical case is given to students in groups. But in CVL, the major difference from PVL is that you have to give a pre-class material which is corrected particularly to this topic, and you must have to give this pre-corrected material at least 1 week before the session, so that the students are getting their proper time to prepare the material and come prepare for the actual session. Right. So this is one of the major steps that you must have to follow. And during preparation of this pre-corrected material, at least 2 to 3 faculties should be involved. Now, on the actual session, CVL is conducted in a single session. On the actual session, whenever you give a clinical case, now note down the difference with PVL. Now here, the student will first go through the problem in groups, but they are not supposed to ask the question, but facilitator or the faculty are supposed to ask the questions. So after presenting the case and after the students go through the case using their knowledge, basic knowledges, now the faculty are posting a question one after another, and students are supposed to brainstorm in group to find out what is the answer of this question. They can take help of their pre-corrected materials, or they can help of their books also in the class. At the end of this discussion, now the faculty will ask some of the groups randomly to discuss that what is the possible solution of these questions. Now here the faculty is taking an active component, active part. Whenever the students are doing a discussion in a wrong way, the faculty are supposed to correct them and guide them in a proper direction. So that is one of the biggest difference between PVL and CVL. In CVL, the faculty is taking an active part. Okay, so facilitator or faculty is taking an active part. And at the end of the session, so multiple questions will be given. And at the end of the session, the faculty are supposed to give some critical thinking exercise so that you can understand whether your student has learned the topic or not. And this evaluation part, you may or may not take the evaluation part. So this is an additional component. Some of the research group is not taking pre and post evaluation. Some of the research group is taking the evaluation. So this is additional, but feedback you must have to take, because whether they're liking the session or not, that is important. Now, if we go a little comparison between these 2-3 methods, I talked about PVL, I talked about CVL, FCR will be flipped classroom, will be talked by my fellow colleagues. But if we look at the difference, then you can easily understand that pre-class preparation is very low in case of PVL, it is medium in CVL, and it is very high in case of flipped classroom. Learning objectives. Students are supposed to find out what they want to learn, what they are supposed to learn, what they're supposed to read. But in case of CVL and FCR, it is provided to the student by faculty. In case of learning method, the first one, that is a PVL, is a self-directed learning. But in case of CVL and FCR, faculty and the students both take the component. In-class discussion, in case of PVL unstructured, you don't control the discussion in the student group. But in case of CVL and in case of FCR, you can find out here structure and highly structured. Role of faculty, it is a very limited guidance. As I told you, that this is passive, but it is active in case of CVL and FCR. And the number of sessions that is required for PVL is multiple, but in these two cases, single session is required. So following all the steps of case-based learning, we, in our department, conducted one case-based learning on a topic of hematology, that is a coagulation and its disorder. And it was conducted in the pre-COVID era, obviously. And we decided that this was the learning objectives for the topics, that coagulation, blood coagulation and its disorder. So I'm not going to read the learning objectives, but this is, we pre-decided with the help of 2-3 faculties in our department. Then after this, we
sorry to interrupt, Dr. Manna, just 2-3 minutes more.
Okay, so okay, I'll try to. So we then plan up that how we are going about the actual session. So we decided that we are going to divide the student into 13 groups, and then we'll present the case, and then we'll ask the question. and then we'll take some group like group number 1, 5, and 10, and we'll ask them the discussion. Then this way we'll continue the session, and at the end we'll take a feedback in the Google Forms, right? So this was the actual case scenario which we given to the students. Okay, so this is a typical case scenario of a hemophilia patient, but rather than giving the actual case, we prefer to give a doctor-patient conversation, and this was given to the student in a printed version on a A4 sheet. And after this case, the doctors what the examination finding, that was also given, and then we give this question to the student. So first question, when it is projected, we picked up some random group, that is group number 1, 5, and 10, and we asked them that what is the possible solution to this question. This way we continue all these 3 questions, and after this 3rd question, as you can find out here, what is the investigation you would like to do, then we ask the student that please turn on to the page number 2 and find out that this is the investigation which is already given to you, and now look at the investigations and find out what is the problem in this investigation, what is coming back abnormal. So further question is given, and each and every question is discussed with proper answer at the end of this session. Now our CBL is it's a part of many CBL which has been conducted all over the world. If you so this is the critical thinking exercise which I have given. Now our CBL is a part of multiple CBL which has been already conducted all over the world, and as you can find out the literature in 2016, it is said that most of the CBL in the healthcare sector has been published in North America, followed by Europe, and followed by Asian country, right? And if you look at the field of discipline, then most of the CBL has been conducted on medicines. Now within this medicine, when we search that is there any CBL conducted on the field of physiology, obviously it has been conducted, and some of the interesting physiology case-based learning I am giving here just to show you that what has already been done in physiology CBL. So this Day et al, they have conducted a CBL on polyuria and polydipsia, and the similar way they have given a case presentation followed by some questions, and in their experience they told that CBL should be best conducted with 2 experts, and the teaching format and the possible problems should have to be discussed before the actual session. And single large auditorium is essential for conducting a CBL because it should be a single hall, and the feedback from their session was very good. Second, the CBL was conducted on endocrine physiology, particularly the case was on Graves' disease, as you can find out the whole history. And according to this group, they commented that the major challenges to them was the change the mindset of the senior teacher. Whenever you want to introduce some new technique, the change of mindset of the senior teacher is one of the biggest challenges according to them. And also CBL require teamwork, and it require time, space, and infrastructure, and obviously facilities. Another CBL which is conducted on vascular physiology, as you can see here, the patient is presented with the clinical features of shocks, and some questions have been shown here. And at the end of the session, they also commented that the students perform better after the CBL session, even after 2 months after the exam. That means CBL not only enhancing their short-term memory, they are also enhancing their long-term memory also, and students are enjoying the CBL much more than that of the traditional lecture. And another CBL is conducted in the AIIMS Delhi by Surya Prakash et al. Here they presented a case on peptic ulcer disease, but rather than giving a printed version of the case, they give a video of the clinical scenario, and 2 experts, they enacted this video by patient-doctor relationship, patient-doctor interaction, and their discussion also goes like this question answer fashion. And at the end of the session, they also give a critical thinking exercise. As you can see here, the parietal cells. So the students are supposed to put this proposition into this fill in the blanks, and by this way you can assess that whether they're understanding the topic or not. According to them, the feedback was very, very good. So they take feedback based on these 4 questions, and each and every question the students are highly satisfied. So just to summarize, so to conduct the CBL, what the major challenges can appear and what may be the possible solution. The first major challenges that may appear is the case preparation. During preparation of the case, as I told earlier, that 2 faculty should be at least involved. The case should be aligned with the defined learning outcomes. Case should be authentic. It should involve common scenarios. It should have high educational value. It should stimulate interest, and you can use the voice or the quotation of the patient to make some drama. And the case should not be too easy because it can lead to boredom, or it should not be too challenging, because if it is too challenging, then the students may feel frustrated.
Dr. Manna?
Yes,
Can you
ma'am. Just
please-
1
yeah.
minute. 1 minute, just ma'am. So the next thing is the case presentation. Okay, you can present the case on classically on paper, or you can present the case on computer or the video, audio, as I told earlier. And this one is very specific. That is the 4th year medical students are preparing the case and discussing with the 1st year medical student. And the other problem like strategies, how to introduce the case, that is also important. That step-by-step introduction of the case is very, very important. And some practical challenges are there. This will be overlap with the next session also. So I'm not taking time here. So the last thing is that we are conducting CBL, whether this is effective for medical education at all or not. To assess this thing, generally this Kirkpatrick's models is used, where the first level is the reaction of the students, whether they're liking it or not. The second level is whether they're gaining some knowledge or not, whether they're learning or not. Then third level is after learning, whether they're changing their behavior during actual life scenario or not. That is the level 3. And level 4 is whether your target has been achieved or not. In case of CBL, if you look at level 1 is fully achieved. The students are highly satisfied. That is reported by most of the studies. Few studies although reported some drawback. But in case of level 2, as you can find out that it is very difficult to comment whether the students are gaining knowledge out of CBL or not. But majority of the studies found no difference between CBL group and the other control group. But as you can find out here, level 1 is successfully achieved. That means students are liking the session. So enjoyment or liking leads to increase in engagement and motivation for learning, which itself is desirable and positive effect of CBL. This is all from my side. Over to Dr. Manpreet. Thank you.
Thank you, Dr. Manna. Since we don't have much time, maybe 1 or 2 questions from the audience, if there are any.
What is difference between problem-based learning and problem solving?
The problem-based learning and problem solving, I have not seen these two things differently, but what I have seen is that problem-based learning, I told you already the steps, but problem solving may be done in a single session, which I understand in problem solving and problem-based learning. Because in problem-based learning, you are giving authority to the students. They are doing their self-directed learning and they're learning the topics by their own.
I think problem solving may we give small problems in between the class for
Yes.
students to solve.
Yes, in the same class,
that
we
they
can do
become
in the same
interactive and
session.
that. Yeah,
In the
that is
same
done.
session, we can do it.
Yes,
But in problem-based learning, you require multiple sessions for their self-directed study.
Just one question from my side.
Yes, ma'am.
You have projected in the table the differences between the 3 types of learning.
Right.
Now, when you look at the CBL and the flipped classroom, there's not much of a difference except that the pre-curation, the pre-preparation for the class is a higher level.
Yeah.
So what is the degree to which it differs and how do you ensure it happens?
Yes, ma'am. The FCR is very, very different from CBL. When my next speaker will speak, there are some other steps which we ensure that whether the student has read the pre-curated material or not. That is one of the important steps which we take into consideration. And the discussion is more organized in flip classroom also. So I think that Dr. Manpreet is going to cover up that thing. Thank you, ma'am.
Thank you so much, Dr. Manpreet. So we have our next speaker, Dr. Manpreet Kaur. She's an associate professor in VMMC and Safdarjung Hospital, New Delhi. She's a distinguished researcher and has several publications in the field of autonomic neuroscience and vascular physiology. She has actively participated in the SARC workshop and organized various national workshops on neurophysiology and practical physiology. So over to you, Dr. Kaur. Request again to stick to the time, about 10-12 minutes you have for the presentation.
Thank you so much for the introduction, ma'am. And I'll just try to stick on time because, you know, when you prepare, you feel like sharing it with your audience. So we'll start. So like we have already seen the 2 tiers of, what is active learning. And now we talked about CBL, and a very pertinent question ma'am asked, how does CBL differ from FCR? I'll try to cover that aspect during my talk. So to begin with, I'll just begin with the story. It will be a short break for us. But this is the story about a businessman and a lender. So the businessman owes a huge sum of money to this lender, which he is unable to pay. So the lender has a hidden agenda. He wants to marry the businessman's beautiful daughter. So what he does is he gives him an option which he cannot refuse. I'll have two pebbles. One is black and one is white. I'll put them in two bags, and your daughter gets to choose the pebble. If she chooses the white pebble, your loan is, completely foregone, and your daughter doesn't have to marry me as well. If she picks up the black pebble, your loan is again foregone, and your daughter doesn't have to marry me. So it's a win-win situation for you. Loan to dena hi nahi padega. Agar white pebble aaya, to she doesn't marry me. Black pebble aaya, to she marries me. Now the daughter is in a very bad situation. Ab wo sochti hai ki, I have to help out my father, but she's a girl with confidence and thinking out of the box abilities. So she decides, and she knows that the lender is a very evil person. So she, picks up one bag, and obviously the pebble is black because he had put black pebbles in both the bags. And she suddenly pretends that the pebble is drawn in the floor amongst many pebbles. And then she says, I'm so sorry, I just dropped the pebble. Can you just open the other bag? Whatever pebble was there in that bag, the opposite one must have fallen down. So the pebble in the other bag was also black. So obviously she, took the situation into her hand. She was able to critically analyze and think. So that is why we're talking about active learning over here. What we equip our students is with the ability to know that the pebble is black or the pebble is white. But what do you do when the pebble is black or the pebble is white? How do you handle the situation? So this is why critical learning skills are very, very important for medical education, because you have to deal with patients, you have to deal with a team of workers, you have to, be the person who operates the situation. So I'll talk about our experience with flipped classroom in today's, talk. So I'll just talk about our experience and try to stick on time as well. So, we'll be talking about what exactly is a flipped classroom, how does it differ from a traditional lecture, what are the benefits to flip. I'll share our experience at BMMC of implementing flip, what were the challenges we faced, and what are the probable solutions to it. So, like ma'am brought about it, we want an Indian medical graduate to be Sarv Gun Sampurn. So that as teachers, we have to become Sarv Gun Sampurn. That is the role of a teacher now. So now we have to use active learning strategies. And flipped classroom is one of the highly established techniques which has been used worldwide in medical education. There are colleges in US who've actually flipped the entire curriculum. So it's a very good thing which we can actually introduce in a blended manner in our curriculum as well. So flipped classroom, or the inverted or the reverse classroom as we call it, has got three components to it. One is the before class component, the intra-class component, and the last is the after-class component. Now, how does it differ from CBL? See, CBL, you're giving them a pre-class material which is not curated. Curated means it is a wider material and talking about a single case. When you give the material for a flipped classroom, it is highly based upon the specific learning objectives which you're trying to achieve, and mainly the lower domains of specific learning objectives. So the pre-class material is a very big difference between CBL and FCR. Second component of difference is in FCR, mandatory pre-class material preparation is required by the student. He will not be able to do anything during the class time if he has not read the pre-class material. You do not ensure such high level of compliance in CBL. Third thing, which is the difference between a CBL and FCR, is the after-class follow-up. You need to know that whether he has benefited from the FCR session by an after-class assignment or a higher level of problem-solving exercise or a project-based learning. You may use different paradigms, but the after-class follow-up is mandatory for his FCR session to be completed. So it's got three components to it. So then, what is flip? Flip provides you with flexible environment. The student gets a study material which he can, self-paced learning at his own convenience of time and place. It gives you a learning culture. Learning culture means that here you are giving him a curated material which has been very validated, and you've produced it very nicely, thinking about it, spent a lot of time preparing it. You are giving him to him, but now he has to read it, make sure that he's coming to the class prepared. So this is developing a learning culture in the students to come prepared to the class. Third is intentional content. Now, this is the burden on our shoulders. Now we have to prepare the entire module, which is extremely time consuming. After one flipped classroom, I decided it's enough for the curriculum for this year because it required so much of energy, active interactions and feedback, and realistically making it more better and better. So it's a intentional content the teachers have to work on and produce it. Last is being a professional educator, again, the same thing. Now we have to, take a higher responsibility of, getting into programming and, making it a foolproof program so that we achieve the learning objectives by the end of a flipped classroom. So how does it differ from a traditional lecture? Now, a few of our students might be very committed. They might read before a lecture, but it's a rare scene to see. Most of them are just dozing off in the lecture. So you could you give them an interactive video-based lecture and you put questions in between, quizzes in between, so that every step, he's finished this objective, okay, put a question. If he's done it correctly, then only he moves out to the next part. So there are a lot of ways to ensure that during a flipped video, he is actually learning what you expect him to learn. Then during the class time, normally, like here I am the sage on the stage. I'm, talking to so many audiences and it's a unidirectional talk. You're all listening to me. But during a flip session, it's team-based learning. The peers are learning from each other. You've made groups. They're actively, saying, no, this is not correct answer. They're actively participating. So it's a group-based learning. And the role of the teacher is only a facilitator, so that you know that they're talking about the topic and not talking about WhatsApp and, wasting the time there. So you're just a facilitator during the class time. And the students are the one who are actually, discussing and coming out with the solutions. During the after class time, a very few of our students will actually go back, revise what has been discussed in the lecture and probably go back and read the homework. But during the flipped classroom, you ensure by giving certain higher application exercises that they actually have to revise the lecture, submit the PBL results to you, and you know that your flipped classroom objective has been achieved by them. So now, most of our traditional lecture, classroom time is utilized in only factual knowledge. What is cardiac output? How do you measure cardiac output? So we are talking about the lower three domains. And in flip, I can easily give a, they are important. The lower three domains are important because you can only build the higher domains on the lower domains. So if they're not there, higher will never be there. So now what I do is I give them a video with certain quizzes in between, making it more engaging for the students. And therefore, the home-based learning takes care of the lower domains. And I utilize the class time for the higher domains of learning in a flipped classroom. That is why flipped classroom is being preferred these days. So what are the benefits of flip? Now they're the same as any active learning module that we've been talking about. Students are engaged, they are discussing with themselves, with their peers, they're more interested. With teachers, they have innovation, but with each other, they're more open to discuss. Even a silliest question they might have, they'll be able to discuss it with their peers and clear it there and then. So, peer-based learning happens during flipped classroom. And because of that, they're able to critically think during the class time, because now they're solving problems. They're not only remembering facts, they're trying to solve a problem working as a group. And that is why they develop the attitude of lifelong learner. Now, if I inculcate this culture of learning on your own and trying to think beyond, you will start developing it for everything in your life. So we are making them good at your Indian medical graduate goals that we have. At the same time, we give them the autonomy to read on their own, at the speed they want, at the time they want, because we've already given them the pre-video recorded video material. So it's a student-driven learning that is happening in a flipped classroom. So the question is, itna acha hai to kyun use nahi karte hain? Why don't they use it? Because of the large classroom size. Now, most medical colleges in our country have 180 plus student size, and flipped classroom becomes difficult. We'll discuss why it becomes difficult. So in our center, we started a study to establish the use of FCR as a learning module. And we prepared a pre-class, entire planning happened, what will happen when and everything. Then we prepared the study material, the application exercises, the assessment that we would be using. See, if the objectives we want to achieve are different, assessment has to evolve at the same time. It cannot be the same theoretical concepts we usually ask. So this planning was done through 3 validated experts. We had a Delphi's method of validation. Then we went back and took the feedback and really improved all the aspects as and when required. Then during the class time, we had an individual readiness assessment test. Now, this is basically a test to know whether the child has actually read the pre-class material or not. And then we had a team-based readiness assessment test, which is now they're working as a team to again solve similar problems and we see whether the based learning helps them or not. Then we have the summarization and clarification of doubts. See, after IRAT and PRAT, they were only taking care of the initial thing which we had given them as a pre-class material. So now we see that everybody is having a problem in some concept. So as a teacher, first 5 or 10 minutes of a flipped classroom is to correct the difficult concepts they are finding and any problems anyone has, we ask them, so that the doubt clearing session happens before we actually go into the exercises. And then we had the discussion of the critical thinking exercises. And post class, we had an assessment and we followed it up with the feedback also. So now the planning and preparation. Now this is the most difficult part of implementing a flipped classroom, I would say, because this requires a concerted effort by a team, not a single person. And you can't think of all the things which will happen unless you do it once. So it's a kind of a complex thing, and there were multiple steps through which. First thing was, where do we start? What topic we should use for flipped classroom? So we decided to use a topic which is relevant from the exam point of view, mostly asked in the exams, and requires active concept building where you have clinical scenarios involved. So we started with a topic like that. But at the end, when we took the feedback from both teachers and students, they felt that the topic was pretty long for a flipped classroom to be conducted. So next time, maybe smaller topics could be used for a flipped classroom module. Then building up the time logistics, which is a problem everywhere. In a conference or in a lecture, how do you maintain the time discipline? When to give the pre-class material, when to give pre-class assessment, what should be how long should be the class time, so that we actively discuss and present the problems to each other as well. So we found out that time management during the class time was a trouble there also, because they keep discussing, and when you ask them to come and present, they're still discussing. So that is the role of a facilitator, to maintain the time kinetics during that time. Then the study material, had to be made in objective with the specific learning objectives, taking care of each of them. So we have to make sure that study material was not very long, because if it was a 30-minute video, nobody wanted to see it. So first video was actually what I made was a 20-minute long video. Then the feedback from the subject experts was nobody's going to watch them. So, make them short or make them 2 short videos. So we made them into 2 short videos. And even students felt that the pre-class material could be better, because only 74% were actually satisfied with it. And even teachers felt there is still scope of improvement. So that is why we should look at data bank creation. Nothing can happen at a single stage. You do it once, you have a material, next time somebody else conducts the same classroom and, maybe gives the feedback, and with the constant feedback, the material will be developed. So I know now this flipped classroom module is ready and can be used throughout the curriculum whenever we want to. So then the assessment also was designed so that we, take care of all Bloom's taxonomies level, from the lower levels of remembering to the higher levels of actual application. And lastly, in terms of assessment, what we found was the pre-class assessment, the assessment score increased after the flipped classroom, which tells us probably the students now knew better about the topic. And specifically, the very interesting result was the poor performers, those who had very low scores in the pre-class assessment, actually had the maximal improvement after the FCR session. So I think as a teacher, that is a very positive feedback, because जो अच्छे बच्चे हैं वो तो खुद पढ़ भी लेते हैं. But what about those who are not paying attention? So it was able to cater to their needs also. Then students were less satisfied with the assessment that we gave them. It could be because nobody wants to be assessed. So probably it could be that reason, or probably we need to validate our assessment further. Even teachers more or less felt the assessment mode was good enough. With application exercises, we used a concept map, which Soman sir had shown. One of the concept maps was used. Higher order learning exercises were there, clinical based cases were there, and we included a video. Like ma'am said, hemophilic child's video, and we had an AdCom module on that. How would you deal with his problems? How would you give him, what kind of instructions you would like to give him? So that was also included. So this was the star of the event. I'll just try to. So this was the star of the event. Everybody liked the application exercises. So, this is the most interesting part of the flipped classroom, that the class time is enjoyed by both the teachers as well as the students. So this was the timeline for conduction, the steps that we followed. How did we go about it? So FCR was found to be very time consuming and involved higher workload. All teachers were really tired after the FCR module. So it was higher workload. So during the class time, I already discussed about IRAT, TRAT. We had interactive discussion, a highly fruitful session. And in post-class feedbacks of the students, like I mentioned, the preparatory material had a scope for improvement according to them. But if you look at this column, do I prefer flipped classroom over traditional lectures? Only 65% felt that we could flip. That means still people have an inertia to change, or maybe our flipped classroom was not that good, like we were expecting it to be. So positive feedback from students overall. Teachers were also optimistic. So these were some of the feedbacks which student gave us. I think I can skip through this slide. And in terms of assessment also, we've already discussed that. So now what are the challenges of flipping? So they can be divided into categories. The pedagogical challenges are student preparation before class. Like ma'am said, we are expecting them to prepare, but how do we know they are preparing? Now there are certain softwares which allow you to see the student engagement stats, that how long they were seeing your video, did they answer your puzzles in between? What was the answer to the puzzles? So there are softwares to do that. But I know it's a software-driven technology, so technology could be a limitation at both ends, for the teachers as well and for the students as well. Then you could have assessment. Pre-class assessment is another way of knowing that whether they have read your notes or not. And the IRAT that we used in a module is another way of ensuring that they've read the pre-class material and come to your class. But most important is to motivate the students. See, they are the users. They have to be convinced that we are using the teaching paradigm for their fruitfulness. So what I felt was giving them a session on why we are trying to flip. What is the advantages you might include, and what are the steps to it, and what is the time involvement we expect from you would be a good idea, because these are adult users that we're looking at. Then for helping them to solve, sometimes the students say, I had a question, but there was no teacher to answer in the pre-class material. So you could have an active WhatsApp group or a discussion board for that. So this we've already discussed, and people say that the effects of flipped classroom are not long lasting. So I would say that don't flip completely. Use different active learning technologies, but you could actually include some flipped classroom as well as one of the active methods. Implementation issues, most people do not have adequate staff. For time taken for this module, you'll require extra time commitment. So you should be having dedicated, I think, staff at every way. Teachers should get time to plan the curriculum as well. So the time allocation should be there, and technology support obviously is needed, because if you start doing every step on your own, you can do it, but it'll take so much of time that you'll end up not doing it. So then at the students level, they find it time consuming, but you have to motivate them and tell it's a self-regulation thing. Okay, and there are barriers at the level of the teachers as well, like we discussed. And technical barriers, obviously, these are all technology-driven techniques, so they have their own problems. And it could be other levels of problems which we have probable solutions to it. So what I want to tell basically is every problem has a solution. So in any active methods, you will face challenges, but we can cope with them. So with that, I'll end up my talk. Thank you so much for your patience.
Thank you very much, Dr. Kaur. That was a wonderful presentation on flipped classroom. But the one question that always, is on my mind is, how do we sustain this model for the entire year? Because you said, once I have done, I'm done with it. It's so difficult to sustain.
Once in the street, one topic, once in the street, the other topic, and start keep validating it, and you add more to your data bank.
Because again, there is a problem with the data bank, because it has to have newness, If students expect a lot of new things every time you go into the class. So otherwise it becomes monotonous. Yeah.
We can share it. If VMMC is prepared a FCR module on hemostasis, why does another college have to waste the same time? They can, make improvisation to it, but could use the same model. So, that could be a sharing of database as well. Thank you so much.
Is there any group size for the flip type?
See, ideally, the good thing about flipped classroom is it can be conducted in a large group size, but the group discussions that we want should be ideally having group size of around 8 to 10 students. So now it is advisable to have a size of 8 to 10. That's the maximum limit we can have. Thank you.
Is the IRAT and TRAT same?
No, one with the question the same, but it's always individually and then as a team.
One more question, Dr. Ms. Kaur. Can I ask? I'm Dr. Sabita from GMC Kathua, Professor of Physiology. Just one query. How much reading material we should give, which should cover the topic? 75%, the whole topic, pre-class material, which you are giving?
Well, ideally, it should just cover the lower domains of learning. That means till maybe the knowledge to understanding to reasoning domain. Right.
Okay.
So it should be, pre-class material cannot be long, otherwise the students won't read through them. It should be engaging. It should use active methods so that they actually end up understanding and reading at the same time, but not too long.
Okay, higher
Video
learning
is compulsory. Is video is compulsory or on written material?
No,
Huh?
I agree to it. You know, people have been giving pre-class written material, text resources, quizzes, any form of pre-class material can be given. But the research has shown that videos are the most preferred mode by the students. That is why most people, like to give videos.
And thank you so much, especially the shared part. The modules can be prepared and shared. That's very interesting. Databases can be prepared. Thank you so much.
Pre and post assessment is compulsory. Is it?
Yes.
Pre and post assessment?
See, post assessment could be in the form of a project, or it could be other application exercises. It need not be in the form of an assessment only, but post class session is necessary for a flipped classroom to be complete.
Thank you so much.
Thank you.
I think we have to conclude this session. I thank the organizers for the opportunity to chair this session.
Thank you. Thank you very much.
Thank you so much to all the speakers for igniting the spark with such an insightful session. May I kindly request the chairpersons to come on the stage to felicitate the speakers, please.
Thank you, sir. Thank you so much. So, actually, I also had a presentation on use of digital methods in active learning. So, since we are short on time, so what I'm going to do is, I request all the students who are sitting here, the young ones and the old ones, the junior ones and the senior ones, please take out your mobile phones and in your Chrome browser, please type menti.com. Just a minute. And meanwhile, I'll also log in.
What to type?
I'm just showing you, sir. Just a minute. So, internet is there. Yeah. Just a minute, sir. Just 2 minutes, and we'll be done with this exercise. Think. We'll just be doing one exercise because we have time crunch here. And okay. Okay, please go to this menti.com. Please type on your, I will specially request my senior faculty members, menti.com, and please type the code 38218305. 38218305. So has the quiz opened up? Perfectly fine. I can see one thumbs up going up. Very, very heartening to see. So please, you can answer. All of you can answer. I could have timed this quiz, but then, okay, I will go through it. So I have 6 responses here. There are more than 6 people sitting here. I expect some more responses. I hope there is no internet connectivity of the phones. Okay, the response has gone up to 13. Now going on to the next slide. I can see 2 responses have come in, now 4, now 6. You can see in the corner of my, on the, okay. So we have 7 yes and 10 no's. This is a simple quiz. There's one more quiz, to find out whether you people were listening properly, sincerely or not. Wonderful. So it's a very nice response, what we can see here. Okay. But only one response is there. Now see, as the responses are increasing, the difference of opinion is building up. And that's the end of my presentation. And now one more small quiz. Just a bit. So this is another quiz, another 3-4 questions. I request your patience and participation. Now you can type the code 11846019. And you can start answering. Advantages of flipped classroom. You can choose multiple options. Wonderful. 8 responses. Wonderful. Going on to the next question. Now, this is the question that challenges that how attentive my students were when the presentations were being made. Now, the thing is, in this question, there was no instruction of giving multiple answers. It was only one single response. Okay. And the one which I chose, the presenter chose the best response. It is my choice. Yes, of course, I can in the instructions make it amply clear. This is just to give you the feel of the thing. Another important controversial question. Flipped classroom is same as CBL. And if my audience are able to answer it correctly, it means Dr. Manpreet's session was kind of well accepted and understood. So Dr. Manpreet, what do you say? You are happy? I think we can give her a round of applause for making this effort. Again, the scales. Even our online audience could do this. I think they could have, yes. So this is the end of my quiz. Okay, there's one more. Yes, flipped classroom will be difficult to implement in my institution. Express your challenge in one word. You can use up to 3 responses. express the challenge you could face in your institution or you have faced in your institution in one word, and you can use 3 words. See, we are getting the responses. The word cloud is forming up. This question could have been a simple question. The neurotransmitter released at the neuromuscular junction is. So if all my students are able to answer acetylcholine, then I think I have achieved whatever I wanted to achieve as far as the learning level was concerned. Or if I get noradrenaline, or I get glutamine, or I get glycine, it means that some of the students maybe they missed out on the key point of the topic. So this is one way, and I think I had a few more softwares to show, but then if there is paucity of time, so that's it. Otherwise, this session was really going to be interesting. See, so this is the word cloud which is forming up, and different opinions. Okay. Okay, fine. So we are ending the session here now. That's it. Thank you so much for bearing with us, and sorry if we kind of crossed the time limit. That's it.
Sorry for the inconvenience. We would like to begin with the plenary lecture 5. The felicitation will be done after this session, so kindly bear with the inconvenience.
So we begin with our 5th plenary lecture, the title being Technology, Society and Future of Health. The chairpersons for the same will be Dr. Asha Gandhi from SGTU Gurgaon, Dr. Sunita Tiwari from KGMU Lucknow, Dr. Tadgata Chatterjee from ESIC Medical College Faridabad. All those who have to present the posters, please assemble outside in the poster presentation area.
Me, I can introduce myself. Okay. This is Professor Rakesh Bhatnagar. Originally, I am from JNU. I taught biotechnology over there for the last 30 years. Before moving to Banaras Hindu University as a Vice Chancellor, and currently I am Vice Chancellor of Amity University, Rajasthan in Jaipur. My area of research has been developing vaccines and diagnostics. Today I am going to share with you how we developed recombinant vaccine against anthrax from clone to clinical trials. May I know what is the level of audience over here so that they can understand? I will come down to the basics in case it is needed. They are research people, they are undergrads, they are MD students, or what? They're faculty. Good, no problem. Okay, then they will understand. Okay, so these are the two pictures I am showing. One on the left is my Department of Biotechnology in JNU. On the right, beautiful, eco-friendly campus of Amity University, Jaipur. The lake you are seeing, it's actually not the lake, it's the water treatment plant. Okay. What's that? Okay, all right, okay. Okay, anthrax is a disease of animals normally, but human beings contact this disease accidentally or by design sometimes. As it is shown over here, this is your, this is the pointer or what? Where is the pointer? Okay, it doesn't matter. Okay, here I am showing you the places in the whole world where anthrax is very common. All the blue regions are highly endemic. The green region, which is of course in India, is sporadic. What's going on here? I'm sorry. Okay, this is the situation in India. All the dark blue regions where we have more anthrax and quite often, you know, there is a sudden surge of infections. For example, in 2001, we had many of them, and gradually now it is at a level which is manageable. These are some of the states: Odisha, Jharkhand, West Bengal, Andhra Pradesh. We get quite often, you know, infections, and usually this is after the rainy season. We get a lot of infections. Recently, I am sure you would have seen this news in newspapers. In IIT Madras also, there were some cases of anthrax right on the campus. Because if somebody has seen IIT Bombay, IIT Madras, it's about 80% forest. And usually forest animals get this, and eventually it can be given it to the human beings also. To explain you what anthrax looks like, anthrax is usually of three kinds. One is cutaneous anthrax, which is the most common form of anthrax, and this is how it looks like. Usually, you know what happens, a spore of Bacillus anthracis gets inoculated in upper extremities of your body because of some cut or abrasion, and it turns into a little pinkish region and eventually turns into a vesicle and a scar, and it looks so terrible. But let me tell you, it's not that painful. It looks very painful, but it's not. The second kind of infection is gastrointestinal anthrax, which is usually if you have the meat which is contaminated by in animal infected with Bacillus anthracis, and if the meat is not fully cooked, you may have this infection. And spores are usually release toxin, and it gives little pain in your stomach. Okay, thank you. All right, the necrosis occurs, the sepsis occurs, and eventually, oh, sorry. All right. So this is gastrointestinal anthrax, and middle one is the, okay. So I have the next slide. Oh, sorry, it is brief. Okay. The most dangerous form of anthrax is inhalation anthrax. As the name indicates, if you inhale the spores of Bacillus anthracis, it can go to your lung. It can eventually go to the alveolar macrophages, and the toxin is released, and the person dies of toxin, not of the Bacillus anthracis, which is a gram-positive bacteria. It can easily be taken care by antibiotics treatment. This is how you know this bacteria looks like. It's a gram-positive bacteria. It grows in this kind of chain structure. Bacillus anthracis harbors two plasmids. One is PXO1 and another is PXO2. PXO1 encodes for protective antigen, lethal factor, edema factor. These are the three most important virulence factors. And PXO2 codes for polyglutamic acid capsule so that it can avoid phagosome, lysosome. It can survive because of its structure of polyglutamic acid capsule. Anthrax spores are highly stable. They can stay in the environment as long as 120 years. The main immunogen of all currently used vaccines are protective antigen. Sorry. All right. Okay. To understand my talk, you have to understand these three terms: protective antigen, edema factor, and lethal factor. All these three molecules are nearly of the same molecular weight, 80 to 90 kilodalton. Edema factor as well as lethal factor, all by themselves are not toxic. You can just take them and nothing will happen to you. However, once this protective antigen and edema factor mix together, it makes edema toxin. Edema factor is a cyclic MP synthesizing enzyme that is adenylate cyclase, which is calmodulin dependent. And remember, bacteria do not have calmodulin. Eukaryotes, including humans, they have this protein. So it makes a lot of cyclic AMP, which brings about many pathological effects of this infection. On the other hand, you don't have a collar mic? Okay. On the other hand, I have to, okay, I'll do it like this, okay? On the other hand, the lethal factor is a zinc-dependent metalloprotease, which can clip MAP kinase series of enzymes. Okay, thank you. Which can use, hello, is it okay? Okay. Which can clip MAP kinase series of enzymes, and this is the main cause of the lethality of humans as well as animals. Now let us look at how these molecules act. So what happens, protective antigen binds to the cell surface receptor. All our cells have these receptors for protective antigen. Once it binds, a protease sitting on the cell surface receptor clips this molecule from 83 kilodalton to 63 kilodalton to create a space for binding for lethal factor or edema factor. Both can bind. Once they bind, they go inside the cell by receptor-mediated endocytosis. And once they get into the endosomes, the protons pump in and the vesicle becomes acidic. Sorry, it's not working. Once it becomes acidic, that is prerequisite to eject out both the factors in the cytosol. It doesn't work. Sorry, doesn't matter. Okay, I'll go there. Once it goes inside the cytosol, it can, sorry, go back. Currently, you know, this Bacillus anthracis is classified as a weapon of mass death because it is very easy. I think anybody sitting in this audience can grow Bacillus anthracis and make the aerosols and spread it, and anybody who inhales the spores can die. So therefore, it is a biological weapon, okay, possible biological weapon, and that is why it is classified as a weapon of mass destruction, WMDs. Its destructive capability is equal to atom bomb. And you know, if you want to create an atom bomb, you need radioactive material, you need centrifuge, you need all kinds of things which are very difficult to get. But Bacillus anthracis, you can grow in the microbiology laboratory. Any undergraduate can learn and make it. And aerosolization is not very difficult. I think all these drugs these days we put in the nebulizer and you make aerosols. The same nebulizer can be used to make the aerosol. You spread it in the environment and anybody who inhales can be killed. So it's a very, very dangerous disease. There are diagnostic methods which are available. I am not going to get into that. In 2001, if you remember, in United States and Florida, one notorious mind who was working in my laboratory in United States, he decided to somehow increase the funding for anthrax research. And he loaded these envelopes with the anthrax spores and sent it to media persons and senators in Florida. And 13 people opened it, and out of them, 5 people died. Okay, so you can imagine how difficult this problem is. So the way forward is you can have a vaccine and you will be protected. But currently vaccines which are available are really, really bad. For example, for animals, we are using live stunt strain vaccine, which is the most popular veterinary vaccine. Russia is still using the veterinary vaccine for humans, okay? In UK as well as in US, what they do is they grow Bacillus anthracis in a fermenter and precipitate all the virulence factors, including protective antigen, lethal factor, and edema factor. And that crude precipitate is used as a vaccine. And you remember that lethal factor and edema factor, when they are joined together, they can kill the person. So it is, of course, the toxicity is residual, it's not too much, but still there have been 1 or 2 deaths by taking this vaccine. Next slide. Okay, sorry. All right, let's skip this slide. So what was our strategy? Our strategy was to make the vaccine recombinant, genetically engineered vaccine, so that it doesn't have lethal factor, it doesn't have edema factor, and it can be safely given to human beings. So what we did, we took out this plasmid, which I showed you earlier, PXO1, which has the information about protective antigen. So we just, PCR amplified the gene and put it in the expression vector and then put it in E. coli and try to check whether the expression takes place or not. And indeed it did. You see, it's being expressed nicely by following the successive steps of purification. We purified the protective antigen, which was genetically engineered. Then we wanted to see whether this genetically engineered vaccine is really behaving like a native vaccine or not. If you remember the cartoon I showed you, that protective antigen can bind to the cell surface receptors, all cell surface receptors. So we wanted to check. So what we did, we native protective antigen or recombinant protective antigen, radioiodinated them with iodine 125, and then tried to show it to the cell surface whether it can bind to the receptor or not. And indeed it did. It binds almost to the same extent, something like 80,000 counts per milligram protein it is binding. So it's the same. So that gave us some confidence it is doing the right job. Then if you again try to remember the cartoon I showed you, that cell surface receptor goes and clips the protective antigen molecule from 83 kilodalton to 63 kilodalton. So we wanted to check that, and indeed it does. Okay. Then we wanted to see whether this proteolytically cleaved protective antigen can bind to lethal factor or not. It does. So all this gave us the confidence. Then we wanted to check with the cell culture whether it can kill the cells or not, and whether you need native antigen or protective antigen or the recombinant antigen, and you put lethal factor, and it is able to kill to the same extent as native antigen. Both these curves are almost superimposable. Okay. So it gave us confidence we are making the right molecule. Then the next test we did in animal model. Okay. Mice is the most easy model. 5 spores of Bacillus anthracis can kill the mouse. Okay. But if you immunize the mouse 28 days before and give them booster, and then you try to challenge after 28 days, if it is vaccinated, it gives some kind of protection. You see over there, it gives about 66% protection if you use native antigen, the same kind of protection if you use recombinant antigen, which we have developed. So that gave us the confidence we wanted to test in guinea pig model, which is a better model. In guinea pig, we could get about 80% protection. And then finally, when we went to the rabbit and monkey model, and finally we could get 100% protection in monkey model, you see, so that it can be used for human beings. Another question was, when we were making this vaccine, we were making in the shake flask, and we were able to get only 20 milligram protein, which is not too much. So what we did, we took these cells to the bioreactors, optimized the conditions, and then finally could produce something like 1 million shots per liter. So it was near industrial scale production. We could do it in our lab so that we can transfer it to the technology to some biopharma company. So what we did, we transferred this technology to Panacea Biotech Limited, which is not far away from here. And scientists came from Panacea Biotech Limited to get trained in GNU how to make this vaccine. Then we helped Panacea Biotech to make 5 batches in their factory in a GMP facility, so that these batches can be given for toxicity studies. Those studies were done in Bangalore, and it was found to be non-toxic. And then they did immunogenicity studies, and eventually they went for phase 1 and phase 2 clinical trials, which have been conducted successfully. Sorry. So phase 1 and phase 2 trials have been completed, and there are several international and national patents because of that. If you have another 10 minutes, I can take you faster. If you take protective antigen, it's a good immunogen. But if you add little bit of lethal factor and little bit of edema factor, it becomes a better vaccine. But you cannot add it because it is toxic. Therefore, what we did a lot of mutations in lethal factor, edema factor, and protective antigen, so that they cannot combine and cause toxicity, but still they will be there in the body. So that's what we did. In protective antigen, these 4 amino acids, if you change them to alanine, it is becoming incapable of binding to protective antigen, to lethal factor and edema factor, and hence it makes non-toxic. Next slide. Domain 2, which is responsible for membrane insertion, if you change these 2 amino acids into alanine, it cannot insert in the membrane. Okay. Third, these 4 amino acids were involved in oligomerization, and if you change them to alanine, it cannot oligomerize, it cannot pierce through the membrane, and that's how it becomes non-toxic. Now we compared the sequence of lethal factor and edema factor, and we found that these 7 amino acids were exactly the same in the molecule, and we thought that perhaps this region is involved in binding to protective antigen. So what we did, we made again, changed each amino acid to alanine by side-directed mutagenesis, and find out that four amino acids, which are shown in the gray, this one, this one, this one, and this one. 4 amino acids were involved in binding to the protective antigen. If you change them, they cannot bind, and hence it becomes non-toxic. And similar 4 amino acids were found over here in edema factor and became non-toxic. We also tried to find out if we can use the same piece of antigen as a DNA vaccine. So what we did, we took protective antigen and put TPN lamp to direct the antigen to the right location in the cell so as to make the DNA vaccine, and it was found to be 88% protective. Next slide. Protective antigen is a huge molecule. Okay, it's 735 amino acids. All 735 amino acids may not be required to give the protective immunity. So we tried to find out of that which portion is really giving the protective immunity. And finally, we could come to these 50 amino acids in a row, which could give protective immunity to humans. We also tried to make this protective antigen in plants with a target eventually to make edible vaccine. Because, you know, infection is from the animals, and you cannot immunize all the animals of the country. So the easiest thing would be if this antigen can be expressed in some fodder crop, then it can be. So what the first attempt we did in tobacco, and then we went to tomato, and currently we are doing it in sorghum, which is a fodder crop which can be fed to the animals. And this kind of vaccine, which is made in plants, is also 100% protective. Then, you know, the question is, until this vaccine really goes to the people, what happens if somebody gets the anthrax? Okay, the current regime, which is suggested by WHO and CDC, that you can give ciprofloxacin for 60 days. Okay, but remember, it can only kill the bacteria. It cannot kill the toxin. But the real culprit is the toxin which kills human being. Okay, so what to do? So we have done some studies, and I'm going to share with you. For example, these are the 2 proteins in Bacillus anthracis. If these proteins bind to each other, the bacteria survives. If you somehow segregate them, do not allow them to bind, this is a toxic molecule. It kills bacteria. That means it commits suicide. So what we have done, we have found a molecule which can sit in between and try to ask anthrax-causing organism to commit suicide. Okay, so this is one thing, and we found what is this molecule? This is a ribonuclease. Okay, so if ribonuclease is going to act, RNA will not be there in the bacterium, and bacteria cannot survive. That's what we did. All right. Okay. Another thing what you can do is, if you do not allow protective antigen and lethal factor to interact, it cannot kill. Okay. So again, we try to find the molecules which will not allow these two molecules to interact. And this is one of the molecule which we found it can sit in between and will not allow it to interact. So this may become a future drug perhaps. And similarly, one more molecule we found which sits in between and it will not allow two molecules to interact. Okay. The most interesting thing which we are doing currently, I'm going to share with you. See, Bacillus anthracis infection, it occurs. The person may get infection. You can treat the bacteria by antibiotics, correct? But antibiotics can kill the bacteria, but not the toxin. So what to do next? See, what you can do is you can have the treatment with antibiotics, plus if you have antibody which can neutralize this toxin molecule, that will be the complete cure, correct? So in that direction we are working. So what we are doing at the moment, see, suppose let us say, if you try to remember, I found out the region which is common as far as binding of LF and EF is concerned with protective antigen. You remember there were 7 amino acids which were the same. So what we did, we took that region and raised antibodies against that. Because if that antibody can bind here or here, these two molecules will not be able to bind here and they can never kill the person. Okay. So what we did, this was the molecule. Okay. So we took this molecule and raised antibodies. I think it's a simple thing, raising monoclonal antibodies in mouse model. Okay. So we got 37 clones, and out of that there were 2 clones which could bind to both the antibody, both the molecules, lethal factor as well as edema factor. And then we tried to test whether they are binding or not. They were binding. Then we were trying to see whether they are able to, with this antibody, if we can treat the this footpad model, which is done by edema factor, it does. And finally, we could find out that if we use this antibody along with ciprofloxacin, we can get 100% cure. All right. So this is perhaps going to be the future treatment. But remember, this is mouse antibody. You cannot use for humans. You are not going to treat the mouse for anthrax. You have to treat humans. So therefore, what we are doing, I think these slides I can skip. Okay. So therefore, what we are doing, we are trying to humanize the antibodies. We are trying to humanize the antibodies by following 2 approaches. One, you take the antibody gene and try to clone only the portion which recognizes lethal factor or edema factor. So the whole antibody gene is human, so it will make a protein like human. Then you make a lot of mutations even in the recognition region and try to make it look like human antibody. Once this antibody is developed, I think the treatment will be very simple, that you get an anthrax patient, you start treating with the antibiotics and then treat with this antibody also. Antibiotics will kill the bacteria so that no more new bacteria will be produced to make these toxins. And this antibody will be able to neutralize the toxin, and therefore it will be, the person will be cured and one can walk free maybe in a couple of days from the hospital. And this is the eventual aim we are working on. So in summary, I have not taken more time. In summary, in summary, we have overexpressed the protective antigen gene, bioprocess optimized, recombinant PA was found to be biologically identical. Technology for producing this vaccine was transferred to the company. Phase 1 and phase 2 clinical trials have been conducted successfully. Non-toxic variants have been produced. The B cell epitope has been identified. The toxin antitoxin gene have been identified. And the most important thing is the antibody has been produced, which is being humanized these days. And I hope we are even in talk with a US company. They are very interested in taking it forward because US Army will be the biggest buyer of this, this antibody. And I would like to acknowledge, without the help of generous funding from DBT and World Bank and ICMR, CSR and DST, all this work in the last 20 years would not have been possible. And these are my collaborators, which helped me on different occasions. And this is the list of my something like 20 PhD students who worked basically on anthrax related projects. Unless they were working day and night, we would not have been successful. And therefore, I always tell in such meetings that they work and we only talk. Okay. This is my laboratory where all this work was done. Downstairs we have BSL-3 and upstairs we have a regular lab. So this is how it looks like inside. Thank you very much. I hope I haven't taken much time. Any questions in case?
Thank you so much, Dr. Bhatnagar, for such a, informative talk about that, which we never, as physiologists have come through. And you have very nicely explained about genetically engineered vaccine against anthrax from clone to clinical trials, how it can be given to human beings also. So I would like to ask the audience if they have any question regarding the topic.
Sir, congratulations, sir. That was wonderful work and very nice presentation. I'm Dr. Madhuri from AIIMS, Hyderabad. I just wanted to know, you said that the antibiotic has to be given for 60 days. So when we combine it with the antibody, is it still necessary to?
Then it will not be necessary. And in animal model, we have seen that even, if we do it for 2 days, that's good enough in mouse model. But I'm sure the full course for 5 days certainly will be given. Because why they give for so many days? Because the toxin is still working. And some cells are still producing new toxin. But once you are attacking it from 2 different places, then it will be very easy. I don't think you have to give it for 60 days. Okay, thank you.
So just one more thing,
Yeah,
sir.
please.
Is this anthrax bacillus, can it be deactivated with UVC radiation?
Let me tell
We have
you,
been
this is
trying it
very
on-
difficult to kill. Its spores are very stable.
Mhm.
Let's say mild acid, mild alkali, sun rays, do not kill them, okay? And therefore it can stay in the environment as long as 120 years. That's a reported thing. And people do not know, maybe it can stay further, okay?
Because we have worked on this COVID virus and
Yeah.
some other bacteria which were killed with about 3 to 5 minutes of exposure to UVC radiation.
Yeah.
So I was just
I
wondering
think
whether this can be done.
Some other time I'll be talking about, we are also working in a molecule which can be used as an disinfectant against COVID, as well as most probably, it's a very long dream, maybe it can be used as a drug also. And that molecule is so cheap that your disinfectant bottle may cost you maybe 100 rupees or 200 rupees. That costs you 1 rupee per liter. We are working on that. That's a separate project. Yeah.
Thank you, sir.
Thank
You for enlightening all of us regarding the very deadly disease anthrax as a bioweapon. And people are very happy to listen all the details. Now I thank once again.
Thank you
very
once
much.
Thank you for listening.
Thank you so much, sir, for this great session. May I kindly request you to stay on the stage? Can I please request our chairpersons, Dr. Asha Gandhi, ma'am, and Dr. M.D. Soni, sir, to kindly felicitate our speaker.
I'm sorry, I had to push my talk a little early. I have to reach somewhere at 2. Yes.
And sir, it was very, very informative.
Thank
Each and every step you explained so well.
That is why I was asking what is the audience. Otherwise, sometimes, I may talk more molecular biology and it may be difficult to understand, but I made it relatively. Sure, anytime.
May I now kindly request Dr. Dhanwantari, sir, to kindly come on the stage, felicitate our chairperson. Sir, to felicitate.
Thank you so much, sir. There has been a lot of intellectual discussion since morning. So ESIC fraternity believes learning by fun. So to break the monotony here, I would like to put up a question from the audience. And for that, I'll give 4 options as well. So any of you voluntarily can raise hands and please patiently listen to the question. The question is about Bollywood. And the question is as follows. In the movie Piku, Amitabh Bachchan suffers from condition. I know some of you might have been knowing. Sorry. I want to. Okay, since we have an intelligent audience, so I would like to shift the question to another one. So the next question is, even that is an easy one. There was a man called Hira Thakur. I know people are remembering Setmax channel, and who was illiterate. And his father is a big shot, egoistic man. His son fell in love with a girl who later became the district magistrate of that district. The girl's father visited her daughter when she was poor, and the girl in turn offers the father some dish. Please let me give the options. First option being kheer. Option 2 is khichdi. See, let me clearly tell you that kheer is the wrong answer. This brings me to the third option, meethi bhat. And fourth option is rasagulla. So are we clear with the? Anybody with kheer? Can anyone explain the significance of kheer in the movie? That movie is more famous for kheer. Yes, sir, please. Loud applause for the sir. Now we next move on to the next plenary lecture, the most awaited lecture of the session. The title being Confluence of Health Sciences, Considering the Current Pandemic and Preparedness for Future Pandemics. The chairpersons would be Dr. N.R. Biswas, Professor Pharmacology, and ex-executive director of IGMS Patna. And the next speaker being Dr. A.K. Jarial, Professor, Department of Physiology in AIIMS, New Delhi. The chairpersons, I request the chairpersons to please chair the session and introduce the speakers. Dr. Pramod Garg, Professor and Executive Director, THSTI, Faridabad.
Thank you very much. We are already late by 1 hour and 10 minutes. And Pramod is patiently waiting long time. And I was called in the morning that you have to chair session of Dr. Pramod Garg. So I immediately accepted. Dr. Monica phoned me. But something to say is precisely in three minutes, I'll tell about 3 sentences. I think none of anybody of this hall was present that time when this institute was started. And I'll give a brief story about this. The dean, Dr. Asim Das, came to me and asked a certificate when he was applying for dean here. At that time, I was working there as a Government of India advisor to Dharan. So I told, you write whatever you want and I'll sign it. I signed it and he got the job, and he still remembered that, sir, it is due to you I got this job. And from that time, more than 1 decade, I used to come here, even from the construction stage. And then when it started, I became the chairperson of the ethics committee, so I used to come and guide them. Second is, I was telling that Monica called me in the morning, because now I am at the verge of retirement from AIIMS next month. And Dr. Garg knows very well how much money we get during retirement, huge amount of money. So I'm putting some time how to invest that money. But in the morning, in the mobile, I got a message that the best investment is in academics, and that gives uncalculated money, uncalculated interest. So immediately I accepted the offer when Monica told me you have to chair. And the chair a person who is going to be the director. He is one of the 3rd shortlisted candidate of AIIMS director. So he has a chance of 33.33%. I am privileged to present in front of you the most dynamic, as I have seen when he was associate dean and some other research projects and other things. And this is a very important topics in this current Corona pandemic, what we have gone through for the last couple of years, and still it is not finished. From Corona variant now X variant, so we need to know how to prepare for this. And with these few words, I welcome Professor Garg to deliver the oration. Thank you.
Thank you, sir. Good afternoon, ladies and gentlemen. I'd like to thank Dr. Pandey for having given me this opportunity to talk about confluence of health sciences. How do we prepare for pandemics? And I think most appropriate topic given the current situation that we are still in, even after 2 years. So I'll just briefly touch upon what is confluence and what's the relevance for tackling pandemics. And I think the best example being SARS-CoV-2. And I'm not going to talk about in abstract terms that there should be a confluence. I'll just give you example how confluence actually can be there, and how do we ensure that confluence works for our benefit. So if you look at some of the statistics about COVID-19 in India, we have a population about 1.3 billion. Population density is 464 per square kilometer, and contrast that with United States of 36 per square kilometer. India is $3 trillion economy. United States, of course, is much higher. But if you look at the per capita income, India, it is about $2,000, South Africa, $5,000, in the United States, $63,000. Our health budget is 1.8% of GDP versus 17% of USA, and USA economy is about $19 trillion as of today. So of course, we are looking at recipe for disaster if and when, and most people predicted that there will be disaster in India. But if you look at other statistics, cases in India was 25,000 per million, United States 140,000 per million. COVID deaths in India are 336 per million compared with 2,200 per million in United States. These are published figures. So question is, how did India respond, and where in this issue of confluence of various health sciences come into play? So if you look at some of the responses, and we have all witnessed this during last 2 years, from a testing capacity of 1 lab to more than 3,000 labs across the country, we have indigenous antibody kits made by many institutions and taken by industry, and now for serosurveillance for all kinds of studies, this is being done in India. We have, of course, you all know about indigenous vaccine development, and I'll talk a little more in detail about that. We also have established what is called INSACOG and a hospital network, and I'll talk about that because ESI is a very integral part of that. And of course, the equity, the free vaccination that we had in this country. So give an example of my current institution, that is THSTI, where we have been involved in many aspects of COVID-19 activities, be it development of a clinical cohort of patients. And now we have multiple cohorts, and total size is 22,000 patients with COVID-19 have been included in various cohorts. We have been involved in vaccine development, therapeutics, and assay development, and I'll talk about that. We have established animal models of COVID-19. We have a large biorepository where more than 100,000 samples have been stored, and we have established very robust immunogenicity and cellular assays, which are involved in many vaccine development and therapeutics. So, as I said, I'm not going to talk in abstract terms. I'll give you real examples. So for vaccine development, if you look at the steps, what are the things that are required? If you go initially, you have to identify an antigen. You have to generate an antibody, make sure it binds to the antigen, make sure decipher the structure of that antibody. You have to show immunogenicity of that antigen in small animals. You have to also show in live or pseudovirus assays that your antibody generated by that antigen actually works. You have to then infect animals, small animals, and show in small animal challenge studies that your vaccine candidate is actually working. You have to then manufacture that product in a GLP facility, do large animal toxicity, and then conduct human studies. These are the steps required. And these are the domains or health sciences domains or medical sciences departments which are involved: virology, protein chemistry, immunology, veterinary sciences, medicinal chemistry, clinical sciences, clinical trialists through CRO. So multiple agencies, multiple departments, multiple domains are involved in all these activities. And we actually seen convergence of these in India. So at THSTI, for example, we are also developing a novel coronavirus vaccine, which is using conserved multiple epitopes. So you have seen the virus changing its shape very frequently, and you have now multiple variants coming up. So what is being done is that you identify what are the conserved regions in a virus, take those regions as epitopes and stitch them together to make an antigen which will produce a broadly neutralizing antibody. So this is the approach being taken there. And this has been now shown that it actually produces a very good antibody in animal models and in challenge studies as well. We have also these live virus neutralization assays developed, other assays developed in BSL-3 facilities where these vaccine candidates are being tested. Also developed these two major animal models. One is a hamster model, the other is a transgenic ACE2 mice model for COVID-19. These models were first time established at THSTI, and this has been used by a number of industries to test their therapeutics and vaccine candidates at THSTI. We have what is called an academic CRO by the name of Clinical Development Service Agency, which is actually conducted currently about 17 multi-center trials, including a large trial on TB vaccine in India, and to conduct, supervise, and monitor trials. And this is also going to be involved in one of our vaccine candidate later. So THSTI has been involved in various assays development and testing of these vaccines, including Sputnik 5, Zydus Cadila, Biological E, and these have now been, as you all know, have been given emergency use authorization. And I'm happy that Dr. Pandey has been involved in many of these clinical trials at ESI, and that is why this partnership between ESI and THSTI has really grown. I'm also happy to tell you that based on the multi-epitope vaccine candidate that I've just shown you, THSTI has now been given a large grant by an international organization called CEPI, Coalition for Epidemic Preparedness and Innovation. This is $12.5 million grant, and this is probably the largest grant that any institution has received. And this novel vaccine will be against pan-beta coronaviruses in partnership with Panacea Biotech. So in addition to developing vaccines and helping other vaccine manufacturers, we also looked at the vaccine effectiveness. So this is not just a basic biological institution. It has basic biology, translational research, and also clinical research. So at THSTI, we tested whether the currently available vaccines are effective against the variants which are emerging through our clinical studies, our immunological assays, and also neutralization assays. So we actually did a study, a test negative case control design, which is a WHO recommended design. We took a vaccinated cohort of Covishield patients, and during last Delta surge, we tested for vaccine effectiveness. And we realized that there were some reports that the vaccines which are there, they're not able to neutralize the Delta variant. But still the vaccines were effective, and wanted to see why. And that's why we tested for virus neutralization and also T-cell immune responses against various variants. So our clinical study actually showed that complete vaccination with Covishield was effective in 63% against the reported efficacy of 80% against Wuhan virus. And the single dose was also about 46%. The neutralization, we showed that it was significantly lower against the Delta variant. But more importantly, both CD4 and CD8 T-cell responses were preserved against all variants. If you see, here are the different variants, the Alpha, the Wuhan, the Delta, and so were the CD8 responses. And in summary, we found there was a 6-fold reduction in neutralization activity, but the cellular immune responses were maintained. And that is why clinically we showed that the vaccine is still effective in about 63% of patients, and also resulted in lowering the severity of disease by 80%. And this paper was published in Lancet Infectious Disease last year. So what I want to show you here, this long list of authors, this synergy and confluence that we are talking about. There are 34 authors on this paper from 5 institutions. So I can't claim that THSI did that or ESI did that. There are 5 institutions. Somebody did sequencing, somebody did neutralization assays, somebody did clinical studies, somebody worked on the vaccine. So multiple people came together. And I think this is because of the pandemic that everybody wanted to contribute something. And there was nothing, nobody asked about authorship. Nobody asked where I will be placed. Everybody just came together. And this was at the peak of the Delta surge, April and May. This paper we put out in late June and early July. So I think synergy can be there, provided there is a will to do things. And this is just a result of that. Another thing which India has done, and I'm sure all of you know about this INSACOG, which is Indian SARS-CoV-2 Genomic Consortium, being put up by DST, DBT, ICMR, and Government of India. This is a consortium of 38 laboratories, which is looking at and monitoring the genomic variations of SARS-CoV-2. And 3-pronged strategies there. One is regular ongoing surveillance in the community through sentinel sites. Second is international travelers. And third is event-based surveillance based on, suppose you have a sudden surge in one particular area, you go and collect the samples and do that. And there's a large network here. And I'm happy that THSTI again is a part of that. And we have a clinical site, ESI, which is linked with THSTI. So all the samples from Faridabad and other areas come to THSTI for genomic surveillance. And because of this effort, you know that Delta was first detected in India. And also very rapidly, we could recognize that Omicron has come to India. And we were actually the first lab in the country to culture Omicron virus, again, through the effort that we had placed earlier for Delta. And we showed, this is the paper published again in one of the Lancet journals, eBiomedicine, that there's a marked reduction in neutralization potential of vaccine plasma. So what is happening is you have multiple variants coming in. So what happens with these variants? How does it correlate with the clinical picture? So for linking the molecular epidemiology with clinical outcomes, we have now established a network of hospitals across the country. So this is a network of hospitals across the country. Each hospital is linked with a sequencing site. So for example, THSTI is linked with ESI hospital. So whatever patients come to ESI, their sample goes to THSTI and we sequence what variants you are seeing. And they will tell us what happens to the patient. It's a mild disease, a moderate disease, patient has died, patient survived, or whatever. And now over a period of time, prospectively, you are doing it to understand how variants are changing the clinical course of the disease. So for students also, I want to emphasize this, that you see, basic sciences and clinical sciences are all very important. I'm seeing many of the undergraduates here. Basic science subjects are extremely important. They're going to be with you for your life. I mean, it's not like physics, chemistry that you have done with your examination and you don't remember it. These are the subjects: anatomy, physiology, biochemistry, pharmacology, pathology. They are going to be with you all throughout your life. And these will form the basis of these studies, which ultimately benefit the, the humankind. So now we have more than 2,000 patients' clinical data and sequencing data, and basic and clinical scientists confluence is there through this. And again, THSTI is the coordinating center. We have established this network across the country, and this is being funded by DBT. So nutshell again, I've just shown you the various activities that we have done at THSTI. And for example, one of the things that we have also done is testing many Ayush products against COVID-19. Some of them did show some promise. So the question is, what are the reasons for India's success story against COVID-19? Some of the reasons I've listed: it could be prior coronavirus exposure, a similar virus exposure in the past, which has resulted in some immunity in our population with decreased risk of infection or severity of disease. There could be some genetic polymorphisms which reduce your out of proportion immune response to the infection, or there could be underreporting of the cases, as has been now highlighted in some of the articles. But to my mind, some of these articles are also biased. They show very high mortality. I mean, you can surely hide infection, but you can't hide deaths. I can't keep a dead person in my home. It has to be somewhere. So even if you say there is a 5-fold, underreporting, still we have done better. So there are reasons for that, not just, underreporting. So other factors. One of the important factors to my mind is the leadership and political will. They really invested heavily into COVID-19 challenge. Equity, free vaccination for everybody, rapid escalation of testing, rapid, resources were put in making masks, in making all kinds of, PPE kits, antibody kits, RT-PCR. One of the companies on campus in THSTI produced viral transport medium, sold it for, I think, many crores of rupees. So this was done, everything was done indigenously, so that we were not dependent on any foreign sources. People's participation, again, is very important. I think whether it was a call for anything, everybody came together, everybody, regardless of the status in the society. So people's participation, and nobody questioned. When it was vaccination, everybody agreed. There was some vaccine hesitancy, but everybody, I think, participated. And I think the whole credit goes to the people of this country who did this. And then reliance on science. I've shown you an example of one institution, but there are so many institutions across the country which actually invested heavily in science. And that is why we have been able to do all this and really manage the whole thing very well, except for that period of about 2-3 months Last year, I think in entire 2-year period, we have done reasonably well. For future challenges, as was the topic, I'm happy that now we have set the pipeline. New variant come in, for example, Omicron came, we were ready. A new virus comes in, we are ready, because the only thing which changes will be the antigen. Your pipeline is set. Genomic surveillance, hospital network, antigen detection, assays development, and vaccine manufacturing. The pipeline has been set in motion, and I think this kind of tested the resilience of this country and across the world. So I think we are ready for any such future challenges. And of course, another thing was Digital India. Both Arogya Setu app and COVID were so very helpful, and everybody in the world recognized that. So many countries are using these apps, ultimately recognize India's software power. So I think to tackle challenges, science, society, and polity have to get together. I mean, it can't be just one in isolation. And this is what the current pandemic has shown us. For time immemorial, human ingenuity and resolve have beaten all odds. And I think this was the case this time also. And that is why we are who we are and where we are. Thank you for your kind attention. Happy to take questions.
Thank you, sir, for justifying the title that we had for the conference. When we began this particular titling, we were looking at, of course, the COVID pandemic and how we all came together. Then we looked at dictionary, which word is the integration, and finally we took at the word confluence, because confluence is a mix of everything in sequential all manners. And it was also a pleasure listening to you, because more or less all countrymen are aware that we all came together, but you showed how. Because feelings are there. The way you've shown that the networks have been, pipelines have been created, gives a sense of relief, to put it that way, to all of us, that we are in safe hands as far as the viruses are concerned. Sir, if I may
please
query, the basic sciences, the pre-para, everywhere were already existing, and they work in a sequential manner. Like you correctly said, the pandemic made it into a simultaneous manner. Whether this particular thing that has happened will stay only for the viruses, or there are so many other diseases that we have in our country where things are still occurring in sequential manner, how would you guide us in that manner?
I'm very optimistic. By nature also, I'm optimistic. And I think what everybody has realized is that your efforts will actually pay off. So whether it's a virus today, it's a bacteria tomorrow, it's a resistant bacteria tomorrow, it's a tuberculosis tomorrow, everybody is now geared up. And I can tell you example of in my institution, for example, in THSTA now, they're working on tuberculosis. So they were only working on lab strains and everything. They're testing many new molecules, about 7-8 molecules are there. And I said, no, come on, this won't work. So now they're getting at least 7-8 clinical isolate MDR strains, and they're saying, no, sir, we will go whole hog and just make sure that at least one molecule goes further. So one molecule is at a stage where it can actually go for phase 1 trials. So we are doing some large tox studies and other things. So what has happened during this period is people have realized the potential, and that actually you can deliver, not just on paper, you've actually delivered. So that is the reason. I think it will definitely help other diseases also. So again, I think it will depend on how do you take it. So my sense is that once you have tasted success of something, you are going to do it again and again. I mean, we never had this kind of success. Now we have tasted success. We have actually shown to the world.
Exactly. Yeah.
Absolutely. There's no doubt about that. No doubt about that. This is what. Absolutely.
Now, everything depends on leadership. Now we have a very pragmatic and very dynamic at the helm of the affairs. I am talking about Prime Minister, and he made everyone come together, scientist, politician, bureaucrat, and made it successful. Any other pertinent question? We have a few minutes related to this topic before we conclude.
If not, I want to tell who has made the slides. I don't know. There is a mistake here. INSACOG, there are 11 lab, and it is not AIMS Patna. When you made that, it is IGMS Patna. It is everywhere this type of mistake, because we do the job and they get the credit.
I'll tell them.
Similar thing happened. There is no transplant facility in AIMS Patna, but in Noto sites, it shows that in Patna. We have started from the corneal transplant, kidney transplant, now liver transplant, and going to do heart transplant. And in the media, it shows AIMS Patna. Sorry. Okay, thank you. Yeah. Yeah. Thank you very much for your good effort, and we can conclude. Okay.
Yes, we request Dr. H.M. I request the chairpersons to please felicitate the speaker, Dr. Pramod Garg. Dr. Deepak KK, Dr. AK Pandey, to please be on the stage. On stage, we can see the real confluence. I request Dr. H.N. Malik to please felicitate the chairpersons now. The next session being Apicon-induced hypoglycemia. I request the audience to not indulge in hyperphagia so that we can save ourselves from narcolepsy. So, postprandial hypotension. I thank sir for even updating me in the anchoring skills. Thank you so much. Some announcement.
Minutes, please. There was a session before, so we would like to felicitate our speakers for that session in the morning, which was very insightful. So can I please request the chairpersons, Dr. Asha Gandhi ma'am, and ma'am, please can you come on the stage to felicitate the speakers, please. And Dr. Madhuri Taranikanti ma'am, please, as well. Can we have the speakers? Can we please have Dr. Himani Ahluwalia ma'am on the stage?
Can we please have Dr. M.D. Soni, sir, as well to felicitate the chairpersons? Can I now request Dr. Manpreet Kaur, ma'am, to kindly come on the stage? And Dr. Soman Manna, sir, as well, please. Request Dr. Asha Gandhi ma'am and Dr. M. Soni, sir, Dr. Dhanwantari ma'am, please. Thank you so much. And now we can proceed for the lunch break. And we would love to have you all back again shortly after the food, which is at the academic cafeteria downstairs, ground floor. Announcement, please. There's a general body meeting in this hall, which is Dhanwantari Hall, at 4:30 p.m. of APPI members.
आपने मेरा लाइव ही एकदम स्विच ऑफ कर दिया वो थे आपका पावर लाइव कर रहा है और ये दो भाई को मैं कल से
Okay, which one is it? It's Isha, no?
Yeah, you want the main video?
Yeah.
Save soil, yeah, savesoil.org. It's in this also, and in the YouTube also the video is there. Save soil, okay. Yeah.
So this
The main video, the core video will be, sorry, it should be in the beginning only. Save soil, just where to click.
okay, I'll just check once again. Check it again.
Yeah, this was the one. This is the core video. Now next.
Yeah, this one.
Yeah. Let me check a minute. ये वाला ही है.
About Sadhguru.
It's not about Sadhguru. Just. No. Let me check. I'll forward you the link also.
This one?
Yeah.
This one?
Could you just.
I can, because the volume guy just gone out, but I can play it for you.
I think this is the one.
Yeah. Yeah, we can raise the volume.
No, I don't think so. This could be. This is one of the video, but not the core one. So not the core one, which is the one I have forwarded.
You forwarded me the link, right?
Yeah, I forwarded you the link.
One second, let me just.
Should I go to YouTube and check it?
Yeah, if you can.
Okay. You have the WhatsApp number also?
Yeah.
Is that possible?
You can take my WhatsApp number. Okay.
But it's not coming right now.
Okay.
You just try from your Gmail only. That is the only option. Yeah, the earth under you is dying.
The earth under you is drying. That is the name, right? One second.
Not drying, dying.
Dying, okay.
In YouTube, it happens, the advertisement come, that is wrong thing.
Oh,
we
yeah,
don't-
yeah,
है ना?
yeah, yeah,
That
yeah,
is
yeah.
why the link.
Very true. I'll just, download it. Yeah. Yeah, sure. When is your symposium, ma'am? 2:10. It's a free paper presentation. Okay. I hope so. I mean, okay, one second. Hello, sir. Sir, I'm just handling this Save the Soil. I have to take care of some videos, sir. Sir, I'm just handling this Save the Soil, sir. They are playing a video. I'm just trying to get the link for that. Lunch, I will come later, sir. Once I... Okay, sir. If you're waiting, I will come, sir. Yes, sir. I was actually involved in this both. I didn't come for lunch and dinner, sir. I will come now. Yes, sir. I will come down. No, 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 no. I finish your work.
Then
I
your
will go.
Gmail is better option. Otherwise, the advertisement will come in the YouTube. So you have to go to your Gmail only. Or if you want, if Bluetooth is added, then I can just share the link there also.
One second. Okay, I'll just. So that is easy. I will go. Uja, right? Okay, I have to put it here. हाँ बोलो सलीम. आ गया. ठीक है, मैं आता हूँ. ठीक है. ओके, आता हूँ. ठीक है, आता हूँ मैं.
May I just take the call?
Yeah, sure. This is your PPT. Okay. So on the main screen over here, I can show the position so that you won't get confused. Here it is. Okay. Now, so I will just So let me find your main website though. Earth is dying now, right?
Have you copied it?
Yeah, sure. Yeah, sure.
Thank you so much.
Right now.
Sadhguru. Sadhguru.
Yeah, but this is on YouTube, so we want. What is the thing you said? The website?
SaveSoil.org.
Save Soil.
Yes.
This is the one.
Yeah.
Huh? This is the website. This one. This one, huh?
Yes.
So, correct?
Right.
But this is also kind of linked to YouTube.
Yes.
But I just hope they don't play an ad.
No, they won't play. No, from here, I don't think so.
Okay, so
Yeah,
I will.
this is the one.
No? So I will just
Download it.
Yeah, we may not download it because we don't have the thing to download it.
Okay.
So we'll have to play it online, ma'am. So I mean, yeah. So I'll do one thing, ma'am. I will just save this
on the desktop.
I'll save this as a bookmark, so that what will happen is that when I come here next, I know this is the page. I'll just keep this page open.
Okay.
And when your thing will start,
yeah,
that time we'll play this. Okay, ma'am?
Okay. Thank you.
Okay. Thank you. Take care. Yeah.
No issues.
Yeah, you can just sit down, be comfortable. If you want to have tea, you can have some cup of tea. And just go to that. Madam, we try to start the session on time, but that's what we get. Okay. Yeah, you can please go ahead. Yeah. Yes, sir. Symposium is going to start. 2:30.
Yes, it's 2:30.
2:30. And which hall did you are you?
I don't remember exactly.
Let me-
Integrative.
One second, sir. I will just have a look at the timetable.
Sure, sure.
So that which hall integrated. Oh, sir, but your lecture is tomorrow, sir. Dr.
Has
Birthday,
it
right?
been- No, no, no. Dr. Vivek Sharma.
Vivek Sharma. 1 second. This is
Integrative health.
integrative health. 1 second. Today is
15th.
health augmentation with
Yes, yes,
yoga.
yes,
Okay, this is,
yes,
yeah,
yes,
this is Vivek Sharma. Yes,
Yes,
exactly.
yes.
So I hope this session starts on time, sir.
Okay,
That is
no
all we
problem.
can hope. Okay, just bear
Otherwise,
with
I
us,
have to
sir.
just make a paper presentation also here. So I'll just finish that, try to talk to Pravina. Poster, physical poster.
Physical poster. We'll inform the judges. Because when the symposium is going on, do not disturb.
Right now, if somebody is there, because I just got a call 5 minutes back.
Okay, sir.
That judges are here only.
Okay, so you can, I'll just transfer
Ah.
the slide, sir.
This
is
one,
it?
this one, first one.
First one, huh? So in a place where it is visible over here,
Mhm.
you can,
Sure, sure.
that once
I'll
you
just put
click
the
on it.
name itself so that, it
Yes.
becomes easier.
Yes, Dr. Shilpi, go ahead.
हाँ वो चले जाएंगे शायद. Yesterday he was saying. Bandhu from LHMC. Will it be in this hall only?
Dhanwantari, yes.
This one, na? Okay, I'll just. Thank you.
Okay, so your pen drive you taken?
No.
I don't think so, because then in the end, क्या होगा कि see, if Dr. S.B. Deshpande is not there, you have to show some finesse there. Because what will happen is that you will not know who this person is, and I do not know this person. So what you have to do is that in that case, you become difficult. So you can just say these are like eminent faculty members and
उसको तुम यहाँ से जाओ, दरवाजा तुम ठीक से बंद नहीं करते।
अरे कर रहा हूँ, दवाई ले।
लेकिन बाहर तो नहीं जाते। अरे पीडिया में कुछ कह रहे हैं, मानसी नहीं है, मानसी GR3 जो है उसका कुछ कांड हुआ है ब्लॉक का। वो कुछ आई थी, पी के आई थी, ये ब्लॉग से खाली भी करवा लिया, अनमैरिड होकर रह रही, तो देखते वो कांड भी हुआ है। ब्लॉग में ये लोग रह रहे थे, पता पता तो था, लेकिन कुछ कांड वांड कर दिया उन्होंने। पता तो सभी को ये जब ब्लॉग लिया है वो मैरिड छोड़ना है, लेकिन कुछ कांड करा उसमें। मैरिड रह सकते हैं वहाँ पे, हाँ मैरिड वाले रह सकते हैं वहाँ पे, मैरिड वाले ही रह सकते हैं। तो ये ऑप्शन में तो 2-3 महीने में उससे 1-2 दिन पहले वो सूरत ईद नहीं है NSCC में, उसका बर्थडे था, तो हम लोग गए थे, पता नहीं क्या हुआ, हमें तो किसी ने रोका नहीं, हम तो आगे वापस हो गए थे, बस ये था, हम लेट आए थे। लेकिन मेन अभी जो चल रहा है वो मानसी का कांड चल रहा है। मानसी थी एक, मानसी और दूसरी बार कांड हुआ उसका। पहली बार भी हुआ था, पहली बार उसके कोई और पकड़ा गया था उसके रूम में। मानसी कौन है? मानसी है, मानसी J3 पीडिया की है। SR है जो टैटू बना है जिसके यहाँ पे, टैटू नहीं बना, टैटू नहीं बना। एक और पकड़ी है ना पीडिया में, चश्मा लगाती है मोटा सा फुल फ्रेम सा, वो अलग हो गई। एक और है SR नहीं, J3 है अभी, J3 है। पीडिया में एक और केस हुआ है ना जिसके यहाँ वो टैटू बना हुआ है, आपने शायद देखा होगा, नाम में कोई याद नहीं आ रहा। वो पीडिया वो उस समय याद थी, तो पीडिया पर आगे भी थी, अब से मैंने जो सुना है वो सुनी है। और एक पानी भी है, बुखार है, बाहर माने एक दिन के प्रसाद ने चेकिंग करवा दी। हाँ वही है ब्लॉक पे जो चेकिंग करवा दी थी, वही तो है, वो ऐसा नहीं है वही है ना, वो JR कहाँ है? JR3 है वो फिर नाम में कंफ्यूज करूंगा, लेकिन अभी तो JR3 की वजह से हुआ है। वही हो सकती है पीडिया में, और कोई नहीं है। बहुत कांड है, उसको तो घर वालों को बुला लिया था, ये तो सुना था, वो कोई और पकड़ा गया था, ये तो घर वालों को बुला लिया था, उसका पति बहुत सीधा है, स्मार्ट भी है, सीधा है, शादी भी थी, वो शादी नहीं है, मैरिड है, जो भी वाली मानसी, तो वो दूसरी कोई और होगी, उसको मैरिड होने के बाद कुछ होता है। उसने तो जिस लौंडे को पकड़ी है, वो इंस्टाग्राम पे फोटो है कि माय टाइप ऑफ पीपल, बहुत जल्दी है वो तो। देखो कब तक का चलेगा ये रिक्वायरमेंट, ये चलेगा नहीं चलेगा, 1 महीना तो मान के चलो। डिपेंड करता है कि आप लोग में से कोई लड़की वड़की की जगह आराम से लाला से अच्छे से मक्खन मार के बात करे, लाला नहीं सुनना बात कर, लड़कियों को पेड़ जाता है, वो थोड़ा टाइम में था ना, क्या बोलेंगे, क्या बाहर जाने दे सर, वो बता दीजिए। ये जो उन्होंने लेटर निकाला ना, विद रिस्पेक्ट जो रेफरेंस नंबर दिया वो 2018 का है, 2018 में इन्होंने कोई नोटिस निकाला था, वो फिर इन्होंने दोबारा से, वो एक्सीडेंट हुआ था 2018 में, एक तो पुलिस कांड हुआ था 2018 में, तो और तो वाला जो बंदा था उसने क्या करा था कि मतलब पुलिस से झगड़ा हुआ था। अच्छा, और एक तो एक्सीडेंट हुआ है उसमें ऑप्था उसके NSCC की J2 की 500 में हुआ था, मॉल से आ रहे थे, एक तो मर गई, इसमें NSCC की J2 जो थी वो मर गई। हाँ, और एक सर्जरी जो थी वो कॉमन में रही 6 महीने 2 महीने, और एक पैथोलॉजी की भी थी, तो हमारी तरफ की उसका नाम क्या है, श्रीवंशन, वो थी, और एक ऑप्था का JR था, 4 लोग थे, बच्चे को काटो, बच्चे को रखा है, तो ये ब्लॉक में पकड़ी थे, बाहर से क्या मतलब है, बाहर से पी के आई होगी, तो उन्होंने देखा होगा एंट्री हुई है उसकी, आई है किसी का, पी के आई होगी, लेट आई होगी, मतलब लेट आके फिर ब्लॉक पे कुछ कांड करा होगा। सुनने में तो यही आ रहा है भाई, सब लोग सर्जरी वाले भी वही मानसिक वगैरह हैं, लड़कियों से बोला जा रहा है मिलके कुछ कांड करा होगा जो सबके लग गए, सब लोग जा रहे थे, हम लोग स्ट्रीक बना रखी थी, पीते थे, सब बंद हो गया। अब डेली वाले आ रहे थे, डेली ऑल्टरनेट पे जा ही रहा था, तो उन्होंने बड़े आदत भी नहीं हो गया था अचानक से कॉलेज में। हेलो, वीकेंड में चिल है, अगर मान लो कोई गार्ड हो भी रहा है वो मान जाता है, 50-100 ले लेता है।
I welcome all the dignitaries, the distinguished chairpersons, the speakers, delegates, and last but not the least, the audience for the afternoon session of EPICON 2022. We are going to have a symposium driven health augmentation with yoga-based
सबको पता है भाई मेडिकल कॉलेज में हर हॉस्टल में
As
जल्दी है,
chairpersons, we have
शायद ही कोई हॉस्टल
Dr.
बचा होगा
K.P.
जिसको नहीं
Gupta
जल्दी
and
होगी।
Dr. Rajiv Bandi.
पकड़ने
I request them both.
जाने में जो आता है, जब हमारा सेकंड ईयर रिजल्ट आया था, पूरा बैच ने पी थी, जो पीती नहीं थी वो संभाल रहे थे,
Dr. K.K.
बस
Deepak
फिर भी
is
कांड क्या हुआ,
the
गार्ड आ
Chief
गया किसी ने,
Executive
मुझे
of
जल्दी हुई,
AIMS. He is the dean of examination in AIMS, New Delhi. He has also received a doctorate in science degree for yoga. Dr. Rajiv Bandhu is director professor at Department of Physiology, Lady Harding Medical College. He has been associated with Lady Harding Medical College, Dr. Rajendra Prasad Government Medical College, Tanda, as well as University College of Medical Sciences and Delhi Hospital. He has undertaken major research projects, and he has also served as subject expert in UPSC. Not limiting himself, he has done multiple courses, including National Sleep Medicine
भाई
course
मेल
for
जो
sleep
होती है
education,
पूरे कैंपस में घूमती है
1-year
तो
advanced
मेल है
postgraduate diploma in clinical research. He has also done a course in biostatistics and a course in diabetes. I request the eminent chairpersons to please conduct the session. A big round of applause for both of them.
Thank you, organizers. We have afternoon symposium, the very important symposium, number 7, health augmentation with yoga-based lifestyle intervention, and a very apt and important topic for medical sciences. And the concept is beautifully written, and I request my co-chair to read out the concept before we go ahead.
Thank you, sir. And the concept of this symposium is that mind-body medicine enhances physiological components of health and wellness, and yoga-based interventions complement modern medicine by achieving better health outcomes. So in this, we are going to discuss the role of meditation and evidence-based molecular mechanisms in the health augmentation along with the lifestyle modification. And so they are supposed to foster the brain plasticity and preventing and managing any array of diseases, including the obesity.
So very beautiful concept, and with that we set the ball rolling. We have 4 speakers in this. So after Dr. Rasma Yadav, Dr. Deepti Magan, Kumar Savottam, Piyush Sharma, and Dr. Vivek Sharma. So with this galaxy of speakers, we begin with the introductory, the first talk by Dr. Rasma Yadav, who is a very dear colleague of ours in Department of Physiology. He is a professor in charge of Integral Health and Wellness Clinic. I must say that he is the person who started the wellness word included in the integral and given a wide scope of this kind of research in physiology. And he's also an editor of International Journal of Clinical and Experimental Physiology. His key area of interest include yoga-based lifestyle intervention, obesity, endometriosis, and technically cover genomics and proteomics besides newer areas and immune markers. Dr. Yadav has mentored over 50 thesis projects and has numerous publications in the field of mind-body medicine and mind-body and meditation. And I'm proud of him, and I'm very much impressed by his work in molecular of stress findings in yoga, for which he is well known in the world. Whether you see the citation for this, so we can give a clap for Dr. Yadav. And with that, we give a floor. Dr. Yadav, please.
Good afternoon, and thank you very much, sir, Professor K.K. Deepak, for the kind words, as well as the co-chair, Professor Rajiv Bandhu. Today, this symposium number 7 of this Epicon 2021-22, we are going to cover health augmentation with yoga-based lifestyle intervention. And as Professor Deepak has already told, we are 4 speakers. I will try to cover briefly the past, present, and future of mind-body medicine. So let's begin with the health definitions. Initially, the definition of the health included or primarily focused on the anatomic, physiological, and psychological integrity. but they also focused on stress. And the WHO 1948 definition, this everybody knows, a state of complete physical, mental, social well-being, and not merely the absence of diseases and infirmity. This is, everybody knows the WHO definition given in 1948. And later on in 1980s, in 1984-86, the WHO has partly modified this definition, and they have said health is a resource for everyday life, not the objective of living. It is a positive concept emphasizing social and personal resources as well as physical capacities. So overall, the definitions of health focuses on stress, lifestyle, integrated concept, prevention, and wellness. And that is what my focus area of research is, the yoga-based lifestyles, which include the stress, the lifestyle, integrated concept, prevention, and wellness. The yoga and the existence of yoga is thousands years ago, almost 5,000 years. And one of the pioneer persons who has documented this, or who has written Yoga Sutra, Maharshi Patanjali, everybody knows that. He has written 195, 196 Sutra. And primarily, he has defined the Ashtanga Yoga, Yam, Niyam, Asan, Pranayam, Pratyahar, Dharana, Dhyan, Samadhi. The yoga gurus from our own country, Swami Vivekanand, B.K.S. Iyengar, and in today's word, Swami Ramdev. The philosophy of yoga, as per Sri Aurobindo, yoga is a methodized effort towards self-perfection. In short, yoga is a lifestyle. And as per the mother of Sri Aurobindo Ashram, lifestyle is only by correcting your ways of living that you can hope to secure good health. So now coming to All India Institute of Medical Sciences, New Delhi. Now my rest of the talk will focus on the scientific research, what we have done in yoga, obesity, stress, and inflammation. The milestones at AIIMS, Professor B.K. Anand, he is the pioneer as far as the yoga research is concerned at AIIMS, New Delhi. And this is one of the highly cited papers published in 1961, where he has shown the EEG scalp recording of a yogi. Another important milestones at AIIMS regarding yoga and research, Professor Ramesh L. Bijlani. He established Integral Health Clinic in Feb 2000, a facility for evidence-based mind medicine and meditation integration. And this facility, after 21 years, as Professor Deepak has said, has been renamed as Integral Health and Wellness Clinic in Feb 2021. Now, I will begin with the beginning of life. So, is the yoga or yoga-based intervention may be useful for the mothers, the postpartum mothers? So, this is one of the recent studies, the yoga and postpartum mothers' milk output. And here what we have done, the audio-assisted relaxation technique on stress, anxiety, and milk output amongst postpartum mothers of hospitalized neonates. 74 postpartum mothers whose neonates were born preterm, 26 to 36 weeks of gestation, and admitted to our level 3 NICU at AIIMS. And total 57 mothers agreed, divided into, randomly assigned into 2 groups. An audio-assisted relaxation technique of 30-minute duration was used here. And overall, the conclusion of the study, use of relaxation technique resulted in reducing maternal stress and anxiety, as well as improving the milk output. This is one of the highly cited, or one of the most cited papers of our group. Citations is 412. And primarily, Professor Bijlani has shown in this that the fasting blood sugar and lipid profile can be efficiently managed by yoga. This is another very highly cited paper from our AIIMS. Professor Manchanda as well as Professor Bijlani has done this work. And the retardation of coronary atherosclerosis with yoga-based lifestyle intervention. And overall, the results of this study was significantly more lesions regressed, 20% versus 2%, and less lesions progressed in the yoga group. Another very highly cited paper, citations is 199. And this work we did published in 2012, and where we have shown that yoga is very effective to modify stress and inflammation in the form of cortisol or in the form of beta endorphin. As well as this paper was published in 2005, and where we have shown that yoga-based lifestyle intervention can efficiently reduce the MDA level or lipid peroxidation. This is another recent paper where we have tried to evaluate the exercise versus diet. Which one is more effective to manage obesity? And this paper is published in Translational Behavioral Medicine as comparative efficacy of a 12-week yoga-based lifestyle intervention and dietary intervention on adipokines inflammation and oxidative stress in adults with metabolic syndrome. And this is another paper actually, where we have tried to, again, the role of yoga in metabolic syndrome. And this was published in 2020. And definitely the darker bars, than the lighter bars, those represent the yoga-based lifestyle intervention. The lighter bars are basically dietary intervention. You know, Framingham Heart study is one of the longest longitudinal studies. It started in 1945, and almost third or fourth generations of the participants have been included in this study. And they have tried to tell the risk score for the heart as well as estimated 10-year CHD risk life. And again, what we observed here, that yoga-based lifestyle intervention is effective for this. Thus, the same as correlation. This is another study where with Professor Deepak we have done this, and here yoga-based cardiac rehabilitation on heart rate variability, RCT in post-MI patients. And this was again 12-week yoga-based live cardiac rehabilitation program on heart rate variability in 80 patients post-MI. And yoga group received 13 hospital-based structured yoga sessions. And finally, the conclusion was this yoga-based cardiac rehabilitation program had additive effects in shifting sympathovagal balance towards parasympathetic predominance while increasing overall HRV in optimally medicated post-MI patients. This we have tried to show the effect of this yoga-based lifestyle intervention in diabetes, including this. Here we have the parameters HOMA-IR, the insulin resistance, IL-6, and vitamin D. Then we tried to understand the mechanism, how the meditation influences our brain. And for that, we have done this PET study, and we have tried to understand the brain plasticity and neurophysiological correlates of meditation. The study participants were definitely those participants who were doing yoga at least since last 5 years at the time of inclusion. So those long-term meditators were the study participants, and here brain mapping was done during meditation using this PET. And what we observed, basically the differential activities at the right brain versus left brain, mid-frontal gyrus, superior frontal gyrus, inferior frontal gyrus, the area number 44, the caudate nucleus, the lentiform nucleus, and parieto-temporal cortex. These are some of the pictures of that PET study. It is already published in 2019, so you can have the details of this. So primarily the
on comparison of the force of
right caudate nucleus, the lentiform nucleus,
applying
and
post-prank
Broca's area, especially the right Broca's area, were
found that group
observed
1 and group 2
hyperactive.
and group 1 and group 4
During the
were
meditation, you can say
each other.
the PET, the recording was done after
Assessing
the meditation
correlation
was
between
completed.
the muscle
But you know, the PET,
parameters
the
and muscle strength
once you give the
parameters
radionuclide,
exposed,
we have the window period of approximately
observed
1 hour.
that
So we can
there
use
was a
that to
strong
take the PET
correlation
images.
between hand grip strength, maximum force of hand
This is
grip
another
strength,
way to
and
understand
maximum
the
force of
mechanism,
hand
how the
and
yoga
the BH9 scores.
acts. So this we have done at the genetic level,
Similarly, on
and
comparing the
Piyush will tell
correlation between
in detail
assessing the
in his
correlation
part,
between
in
the
his
endurance
lecture.
time of hand grip strength
So here
and
the relative fold changes T and F
force of
alpha.
plantar flexion.
Within and
We
between
found
the groups,
though the force of
darker
plantar, the
bars are
endurance
basically
time of force
standard
of
of
plantar
care
flexion and
in
BHK9
obese
score had a
persons
strong
or
correlation.
participants,
Had
and lighter
significant
bars
correlation,
are the
but
yoga
no
group.
such correlation was found between the hand grip strength,
Another
endurance time,
interleukin
and
6,
the
these are, you
BHK9
know, the
scores.
inflammatory markers. So
Now,
relative
before
fold
coming to
changes
conclusion,
within
I
and
would like to
between the
summarize the
groups.
results that we obtained.
And again, the
Muscle strength
it is
parameters
fold changes
significantly
which are
differ
being
in the
shown here
different severity groups
at
based
baseline,
on their
at 2
BHK9
weeks,
scores.
at 4 weeks, at
Maximum
8
force
weeks,
of hand
and
grip
12
strength and
weeks.
force of plantar flexion
Again, telomere and telomerase, you know,
significant
for
correlation with
the
severity of depression.
younger friends, the
Endurance time of
telomere
force
and
of plantar
telomerase
flexion
are the
shows significant correlation
important
with
for
severity of
aging.
depression.
Your aging can be defined up to
With these
certain
results, we
extent,
came to conclusion that
or it's a, you
muscle
can say,
strength
aging
parameters
biomarkers,
show
the
correlation with
telomeres
symptoms
and
of depression,
telomerase. So we have
which is
tried
in
to
sync with
observe,
previous
can
studies
this
that has been
yoga-based
done
intervention
in different age
modify the
and
telomeres
amongst
and telomerase? And this is
which has
one
been
of
done
the
previously, showing
examples
a
which was
strong
published
correlation
recently in
between the
2022.
symptoms of depression
The
and the muscle
red
strength
color is
parameters.
basically yoga-based
In fact,
lifestyle
in some
intervention. The
studies, it has been seen
relative
that there
fold
is a
changes
bidirectional
telomere
association.
length. So after
And with
yoga-based
improvement in the
intervention,
muscle strength,
the
it was
relative
seen
fold
that
change has
there is
increased,
improvement in their performance
as well
also.
as
So
the
we
blue
can also
color is
conclude that
standard of care.
improved physical activity and
The same
muscle
thing for
strength might
H-TERT.
help in
H-TERT
improving
is
symptoms of
basically a
depression. Hand grip strength
again,
and
here
force
we
of
have
plantar
observed the
flexion
relative
being
fold
very
changes
objective and very
between
easy
the two
to
groups,
perform in
the yoga
laboratory
group
or
and the
in
standard
OPD
of care group.
settings can serve as
And
a
this
proxy marker
H-TERT is
of
basically
mental
a
health.
marker or a
Though
biological
to come to this conclusion with more
way
certainty,
for this
we
telomerase. So ultimately,
our
telomere,
study is
telomerase, the
not powered
balancing
enough to come to
H-TERT.
this
So
conclusion
usually what we have
with more
observed after
certainty.
yoga-based intervention, the H-TERT
It
level
can be a future prospect
increases.
for us to assess.
So perhaps
We can
that affects the aging.
plan or design
You know,
studies
aging is
which
basically
might
two types. One is your calendar age, second is your biological age.
plan or
So
design
calendar age,
studies which
every
might,
year you increase by 1 year. With your birthday, every birthday, you are 1 year older. Whereas the biological age may be different. It depends on many factors, including this H-TERT, telomeres, telomerase. We have also tried to observe the effects of yoga-based intervention in ophthalmic sciences, and especially we have focused here the effect of yoga or efficacy of yoga in the glaucoma. Like this first paper is effect of THRATEC, which is yogic exercises on intraocular pressure in glaucoma, which was published, which is actually recently published, 2022. Another is the mindfulness-based stress reduction on intraocular pressure in patients with ocular hypertension. Another important is beneficial effects of mindfulness-based stress reduction on optic disc perfusion in primary open-angle glaucoma. So these are some of the research works which we have done at AIIMS New Delhi in relation to the yoga and different conditions. So coming to present to future. This is scientometric analysis, the yoga research publications from 2007 to 2016. And it says the total publications, as far as the yoga research is concerned, 3966, and that is basically Scopus database. The top 5 countries which have shared the most of the papers in this 3966 paper, as expected, USA 38%, but we, India, is second number with 19% contributions in the field of yoga research. UK has 6%, Canada has 5%, Australia has 4%, and most interestingly, the China has around 1%. And the top 10 global organizations during this period, between this 2007 and 2016, top 10 global organization in yoga research list includes NIMHANS Bangalore and AIIMS New Delhi. And the best journal, the Journal of Alternative and Complementary Medicine, the most productive journal in global yoga research during this period. 2007 to 2016. Definitely today, this is 2022, much of the pictures might have changed, and because I expect the future is bright, so perhaps we may be the first in coming years. This is my last slide. The healthy human and advancement of medicine. Medical science has made such tremendous progress that there is hardly a healthy human left. And Huxley was actually a person who used to write a lot. And these are the statement which he actually, because he died in 1960s. So almost 50 years back, he has given this statement, but even today, this statement is more true. Anyways, thank you very much.
Thank you, Professor Yadav, for very lucid, wonderful talk and very nice journey. The way you have shown, depicted, it's wonderful. And to see also went for the futuristic, and I'm optimistic with you that it should be topping the list. US is doing a lot of research, but India can help beat it considering the number of people. And I think wish you good luck. And any question, or we can take up question at the end. Yes, we can take up two questions. Please.
Some insight which you can understand.
Yes. Yes. Actually, yogic exercises are the part or the inbuilt feature of yoga or yoga. Yoga or yoga includes the yogic exercises. In simpler terms, yogic exercise, you can say physical exercises, but those are definitely much beyond the physical exercises. That's why usually it is said as yogic exercises. But yogic exercises are part of yoga and yoga. Yoga and yoga, as per the Patanjali, as I told you, there are 8 steps, which includes the asanas, which are yogic exercises, the pranayam, which is breathing exercises, dhyan, which is meditation. And before that, actually, the first yam and niyam, the first 2 steps, those are the most important steps. That is actually the lifestyle. The yam niyam, the yam niyam is the actually lifestyle. We say lifestyle, what is lifestyle? Lifestyle. So that is actually included in the yam and niyam. Yam niyam followed by asan, pranayam, pratyahar, dharana, dhyan, samadhi. So all this is part, and the exercises, yogic exercises, which simply you can say, usually the US people say it physical exercises, but we in India, at least I prefer to say it yogic exercises, because it is different than the physical exercises. Yes. Yes.
Yeah.
Yes, please.
One more question.
Thank you, Dr. Yadav. It was a very lucid presentation. There was one very interesting study that you showed on brain mapping, and it was a PET scan that was done on the patient and brain mapping. So I wanted to know the sample size and what was the inclusion criteria in that study.
Okay. So inclusion criteria were those persons who were doing the long-term long-term meditators. Long-term meditator means they were in the field of, or they are continuously doing yoga at least since last 5 years at the time of inclusion of them. So at least 5 years means long-term meditators. That was the most important, and definitely apparently healthy persons. No other diseases, apparently healthy. That's why I'm using maybe, but expected to be apparently healthy person.
Thank you. Thank you. I think we keep the questions for towards end. We can take up since we have 4 speakers. Thank you, Professor Yadav. I think we switch to the next speaker. Thank you so much. We can give a clap for Dr. Yadav.
Our next speaker is Dr. Deepti Magan. She is an assistant professor in physiology at AIIMS Bathinda. Her areas of expertise are psychoneuroimmunology, positron emission tomography, yoga, meditation, EEG, cognition, stress, and immune biomarkers. She is the editorial member of Clinical Research Journal and Journal of Physiology and Healthcare Medicine. She is also an active reviewer of multiple national and international journals. Her most recent work is a randomized controlled trial on the effect of yoga-based lifestyle intervention and dietary intervention on cognition and obesity. So may I invite Dr. Deepti Magan now?
Yes. May I request the chairpersons to allow me to present this, because Deepti is, because of some personal reasons, she is not able to join.
Okay, go ahead, please.
Thank you very
Very
much.
nice. I appreciate that gesture. Sometimes the speakers do not come in, but you are
Yes.
filling the case.
The
Thank you.
slides and the work
Thank you.
has been, all this has been made by Deepti herself, but today because of some personal reasons, she is not able to join even online. So
welcome to do that.
I will do that. Thank you, sir. So this part is basically from Deepti. I am just simply speaking. So psychoneuroimmunology of meditation. And the psychoneuroimmunology is basically also known as the psychoendoneuroimmunology or psychoneuroendoimmunology. And that is a study basically interaction between psychological processes and the nervous and immune system of the human body. And PNI basically takes an interdisciplinary or multidisciplinary approach. The term the psychoneuroimmunology was coined by Robert Eder as well as Nicholas Cohen in 1975. And meditation is one of the important tools to tackle this PNI. Basically the interaction between brain, mind, and environment, body, the stress, all that comes under psychoneuroimmunology. How this psychoneuroimmunology can be evaluated, can be quantified, what at least we have done at AIMS. So, there are at least three important aspects: psycho, neuro, and immuno. We have tried to evaluate this using this meditation and quality of life, like SUBI, the subjective well-being inventory, state and trait anxiety inventory, STI, NEO-FF personality inventory, as well as the meditation and brain activity. I was just telling the PET study, FDG PET, as well as the EEG, and some immune markers, stress and immune markers like plasma cortisol, beta endorphins, TNF alpha, as well as IL-6. And all this, the connector is usually, it appears to be prefrontal cortex. A few words about the meditation. Meditation is a condition in which the individual eliminates environmental stimuli from awareness to avoid interference in the attention process, producing a state of relaxation. And there are various ways of doing meditation, but basic things common to all types of meditation are: number one, minimal efferent output. That's why usually at the time of meditation, it is said that you sit at a comfortable position. So minimal efferent output. Then sensory attenuation. That's why usually it is said, sit quietly with eyes closed. So sensory attenuation and targeted non-analytical thinking. So this, for our study, we have tried to divide we have tried to divide the phases of the meditation in different phases. And here we have used the Preksha meditation. Initial phase of meditation, that is for efferent attenuation. As you progress, the middle phase of meditation, that is sensory attenuation. And finally, advanced phase of meditation, that is targeted non-analytical thinking. And for this, how the meditation influences, or what is the mechanism of action at the brain level. For this, we have proposed this model, the neural mechanism of meditation. Phase one, that is the beginning of efferent, at the efferent, minimum efferent. The phase one most probably happens at the prefrontal cortex, using all this, especially the right Broca's area. Then phase two, all this anterior cingulate gyrus, finally the thalamus, posterior superior parietal lobe. In phase three, usually superior temporal lobe, the thalamus, the right inferior parietal lobe, parieto-temporal confluence, the confluence of health sciences is, and this is the phase three. And definitely the maintenance of depth of meditation, the arcuate nucleus is affected, influenced, this beta endorphins, the right lentiform nucleus, the right caudate nucleus. So overall, this is our hypothesis, this is our model. Most probably to understand the neural mechanism of meditation. And overall, the psychoneuroimmunology connections, what I have just told you, the functional unit 1 is basically prefrontal cortex. Then functional unit 2 is right inferior parietal lobe. Functional unit 3 is temporoparietal junction. And functional unit 4 is maintenance of depth of meditation, that is right lentiform nucleus, as well as the beta endorphins. And definitely the parasympathetic nervous system, the vagus, overall the ACTH is influenced, as well as the cortisol. And some cytokines links the acetylcholines, the NFK beta, activation of STAT3, some other cytokine transcriptions, as well as the inflammatory markers. So this is, in short, we have tried to make is easier the psychoneuroimmunological connections as far as the yoga meditation is concerned. So our research studies, participants and observations, as I told you, regular and long-term meditations, the participants, that was the primary inclusion criteria, one of the primary inclusion criteria, more than 5 years, improvement in the level of anxiety, well-being, and overall personality. This we have done, as I showed you earlier. The relative stable personality, again, we have published one paper discussing this personality differences among the meditators and the non-meditators. The power of positive thinking, the further increasing the ability to fight against infectious diseases, and better quality of life, improved self-rated health. And what we have observed by our observations, activation of well-defined prefrontal cortex areas, which is important to initiate the synchronizing activity, neural correlates right hemisphere, which confirm the advanced state of meditation. And precisely, right Broca's area was hyperactive during meditation, attention task in right-handed study subjects. All of our study subjects were right-handed. This is also published and you can go through this. So overall, the clinical implications of this evidence-based framework with psychoneuroimmune connections associated with long-term and regular practicing Preksha meditation, which can control the attentional processes, effective for attention-related tasks. So health augmentation with lifestyle modification fosters brain plasticity to overcome various neuropsychiatric diseases, especially like the kids who are hyperactive. Perhaps may be useful, this one. The prospects, future research may be carried out to explore that meditation might activate this right Broca's area, which can be explored clinically for attention, speech, and language therapy in patients who have lesions in their left Broca's area. For example, you know, the Broca's area for our younger generation, the Broca's area is the motor speech area. I am speaking, I am using my Broca's area. That is motor speech area is activated during speech and language tasks in the left dominant, so this side, in 90% right-handed persons and about 70% left-handed persons. So these findings are notable as it unveils the functionality of, because what we observed during meditation, the right Broca's area, or at least so-called right Broca's area, because if you see the Broca's area, actually it is present on the left side. So is there the right Broca's area is actually present? That is first question. Or something like that area is on the right side, that what we have observed is hyperactive in speech and language tasks. So this can be explored for any clinical functionality in patients with Broca's aphasia. You know, they are unable to express, and basically motor aphasia. And that problem is here. So can we use the right side, the Broca's area? This is just one, maybe future studies may tell. So using meditation as a possible treatment. So thank you very much. Yes. Yes. Thank you, sir.
has done a PhD in molecular physiology at Orange Medical Sciences, and is currently working as an ICMR senior research fellow with us. He has undertaken several studies in the field of yoga-based lifestyle intervention and has got several research articles to his credit. His most recent work is an RCP on how yoga-based lifestyle intervention might positively modify cellular aging. To talk about yoga and obesity, molecular connect. Over to Dr. Kirtan.
Thank you, sir. Good afternoon, Chairperson, professors, and other colleague members. My name is Dr. Piyush Sharma, and the topic of my discussion is yoga and obesity in reference to molecular connections. Actually, this part was the associated with my PhD thesis, one of the part of PhD thesis. So our research area, before the research area, I will cover this presentation under the following headings. First, I will give a brief introduction about the obesity. Second, how obesity is associated with oxidative stress and inflammation. What is the relationship between the obesity and cellular aging? And finally, the impact of yoga on aging in obesity. So our research area is based on obesity, which we all know that it's a medical condition in which excess body fat has accumulated to such an extent that it adversely affects on our health, leading to short life expectancy, as well as increase other health problems also. Obesity is also defined as a condition of increased oxidative stress. That means increase in levels of reactive oxygen species, that's the free radicals, as well as increase in mitochondrial dysfunction and decrease in the level of antioxidant markers. It can also increase in the inflammation cytokine markers like TNF-alpha, IL-6, and others also. So we can say that obesity leads to upregulation of genes related to oxidative stress and inflammation. In our study, we were trying our best to associate with, to evaluate the impact of yoga on obesity in reference to the cellular aging. As aging per se, we were selected two markers, actually three markers. First one is the telomere length, second one is the serum telomerase level, and third one is the HTERT gene, which basically encodes the telomerase enzyme. HTERT is human telomerase reverse transcriptase gene. And for new UG students, if I simply define the telomere sequence or telomeres, telomeres are basically the hexameric repetitive sequence that actually protects the chromosome ends and contribute in the genomic stability. And previous studies have shown that telomeres progressively shorten throughout the life. And there is a simple observation: when we compare an lean individual or the obese individual, obese people tend to appear more aged. That means they have shorter telomere length as well as reduced level of telomerase enzyme. So obesity is associated with the cellular aging, and previous studies like Mosen et al. In 2013, they have shown that obese people have shorter telomere length as well as they have reduced telomerase activity. So we can say that obesity definitely affects the cellular health as well as the aging process. In our study, we can see that obesity is associated with high level of NF-kappa B, that's the oxidative stress marker, as well as high level of inflammatory markers like TNF-alpha and IL-6, and low levels of cellular aging markers, that is the reduced level of telomere length as well as telomerase level, and low expression of HTERT gene. So our research question is that whether yoga-based lifestyle intervention can positively modify the cellular aging in obese individuals by managing the levels of oxidative stress marker as well as the aging markers. For that, we have designed a study which is a parallel two-arm randomized control trial in which we have randomized the subjects into two groups, that is the standard of care group and other one is the yoga group. And we have analyzed all the biochemical parameters related to cellular aging, oxidative stress, inflammation at 4 time points. That is at the baseline, at the end of 2 weeks, 4 weeks, and 12 weeks, followed by data analysis. In our study, we have included these subjects like male and female of age 18 to 45 years or BMI more than equal to 25 to less than equal to 35 kilogram per meter square. Males should have more than 90 centimeter of waist circumference and females more than 80 centimeter. We have excluded the subjects or individuals from our study which were previously enrolled in a weight reduction program from last 3 months, diabetic patients, pregnant women, or the individuals which are unable to perform a regular physical activity program or previously reported chronic inflammatory and renal hepatic disorders. So in our study, we have allocated the subjects into 2 groups. First one is the SOC or standard of care groups, in which each participant got the individualized diet plan, as well as they were also recommended to do the physical activities according to the WHO guidelines 2012. Another group, that is the yoga-based lifestyle intervention group. In this group, each individual has to undergo the yoga session, which includes the classic components of Patanjali Yoga, asanas, pranayama, dhyana, that lasted for approximately of 60 minutes of duration. So the primary outcomes of our study are telomere length and telomerase activity. And for the biochemical investigation, we have isolated 10 ml of blood and distributed into 2 equal parts. First part was used for PBMC, that's peripheral blood mononuclear cells separation, followed by nucleic acid extraction. From nucleic acid, RNA was used for gene expression profiling and DNA was used for telomere length estimation. Another part of blood was used for serum separation, that was used for quantification of telomerase using ELISA technique. So in result section, first we were compared the effects of 2 types of intervention on aging markers like telomere length and telomerase level. In this graph, we have compared the 2 types of intervention on telomere length. Here you can see that x-axis shows the different time points and y-axis shows the relative fold change in telomere length. Here we can clearly see that at 2-week time point, there was a significantly higher value of telomere length in yoga group. And if we compare from the baseline within group analysis, yoga group also shows the significant improvement in telomere length at 2-week, 4-week, and 12 weeks time point. In this graph, x-axis shows the different time points and y-axis shows the serum telomerase level in international units per ml. And here we can see that if we compare from the baseline, telomerase level was significantly improved in yoga group at 2 weeks time point. So in our study, which was published in Feb 2022, we have reported that between 2 groups, between the yoga and the standard of care groups, telomere length was significantly increased at 2-week time points. Similar observation was seen for telomerase level at 2-week time point from the baseline. Yoga-based lifestyle intervention group shows significantly improvement in the serum telomerase level. Next part of the result is to compare the 2 types of intervention on the RNA transcript level of genes related to oxidative stress, inflammation, and aging, like TNF-alpha, interleukin-6, nuclear factor kappa B, and H-G. Here we can see that in these 2 graphs, graph A shows the relative fold change in oxidative stress marker, that is NF-kappa B, and x-axis shows the different time points. Here, relative fold change of NF-kappa B shows the decreasing trend, but it was not statistically significant. But in graph B, here we can see that at 12 weeks time point, there was a statistically significant down regulation of inflammatory gene TNF-alpha in yoga group. Here, the inflammatory gene, that is interleukin-6, shows the down regulation that was not statistically significant, but it was show the decreasing trend at 2 weeks in yoga group. Graph D, that basically shows the relative fold change of telomerase encoding gene, that is the H-Turt gene. And here we can see that at 2-week time point, there was a significantly increase in the mRNA fold change of H-Turt gene that basically encodes the telomerase enzyme. So this was a possible mechanism which were described in our recent publication, that obesity is characterized by the excess level of adipose tissue, which can lead to the increased level of inflammation as well as increased level of oxidative stress. And these two factors might be the contributing factor of the accelerated cellular aging in obese individuals. And previously, we have seen that yoga-based lifestyle intervention positively modify the inflammation and oxidative stress, which were reported in these previous studies. So our research output is that yoga-based lifestyle intervention might be positively balancing the level of increased inflammation as well as increased oxidative stress. By balancing these levels of these two markers, yoga might slow down the accelerated aging in obese individuals. These are the other studies that shows the impact of yoga intervention on aging. Like first study done by Krishna et al. In 2015, they have shown that yoga mediators have longer telomere length as compared to the control individuals. And the other study, Rao et al. In 2015, they have shown that 3-week intense mind-body therapy shows 45% one-fold increase and 27% two-fold increase in the telomerase activity. That may lead to increased longevity and better quality of life. So in concluding part, aging has forever been an area of interest, especially for those who are overweight or obese. And our data suggests that internal cellular physiology can be changed by yoga-based intervention by modifying the variables like oxidative stress and inflammation. And these factors might be the contributing factors of the accelerated aging in obese individuals. Thank you.
Thank you, Piyush, for wonderful talk on this aging and very important for the society. So we can take any question, please.
Thank you, Dr. Piyush. That was a nice presentation.
Welcome.
Did you also take into consideration the BMI and the waist hip ratio after, along with measure correlated with the
Yes,
TRT?
yes, ma'am.
Okay. So there was a decrease in the.
Yes, ma'am.
Because obesity itself is an inflammatory condition.
Yes,
so
ma'am.
it,
There was a significant decrease in the body mass index as well as weight in yoga group as well as in standard of care group.
telomerase activity.
Yes, ma'am.
Thank you.
Thank you. I think we can move forward to the next speaker. Thank you so much, Piyush.
Thank you, Dr. Piyush. Now, may I introduce Dr. Vivek Sharma? He is professor and head Department of Physiology as well as faculty in charge academics at AIMS Rajkot. He has keen interest and undergone advanced trainings in biostatistics and physiology lab techniques, especially in the field of neurophysiology and yoga. Dr. Sharma is a certified yoga and heartfulness meditation trainer, providing free sessions at national and international level to various communities and groups. He is recipient of Best National Teachers Award in Physiology in 2020 and prestigious Professor R.C. Shukla Oration Award for Best Cardiovascular Research in 2018. He is currently being invited by Gujarat government to take online yoga sessions for medical students, healthcare professionals, and paramedical staff, and as a soft skills trainer in faculty development programs and for medical students. So, Dr. Vivek, please. So, Dr. Vivek, we have only 25 minutes. I think we have to finish.
हाँ आपको मार रहेंगे ऑनलाइन रहेंगे
So
So good afternoon to everyone. Good afternoon to the chairpersons and all the ones who have been over here. So as sir has said that we have to put it up in 10 minutes. So I'll just come straight to the point rather than just putting out. All other speakers have already talked about many research works we have done, and like what Dr. Dubey also talked about. So I'll just try to just highlight a few of the points where when we talk about yoga, we talk about the research components where we are taking small components of each and we are studying. So my one of the fields of interest is that how there as an integration yoga works. When we take the pranayama, when we take the asanas and all and meditation, do they have a combined or synergistic effect, or they have different mechanisms? So I'll just leave to all these slides and I'll straight away come to what I feel that, that whatever the things we are saying over here today is that we are having lots of the stress. And if we come to the psychosocial parameters where we would like to study or to go for the component that we would like to study is the impact of the yoga, the various components of yoga, how they just try to do, how they try to help us mitigate. And that is why it is finding this as a mind-body medicine approach in various clinics. So ultimately, all the negativity that leads to increase in the limbic system working, increase in the emotions, then, like we are having increase in the steroids level, suppressing the immunity and decreasing the creativity, foggy thinking, and feeling of being stuck up. And this can go when it goes to the pathological state. It can also relate into the into the NCDs or the non-communicable disorders. And as we have gone through or witnessed through the pandemic of COVID-19, we also wanted to study whether this yogic-based lifestyle intervention is of some help to the patients. So why we are studying, why we are having yoga over here after so many studies have there. Dr. Yadav also talked, thousands and thousands of studies are there. It is simply because now when we are witnessing that all the yoga people who are practicing yam, niyam, asan, dhyan, pranayam, and all the 8 steps when we were doing, it was generally found that they were healthier than the rest of the population. Since they were healthier than the rest of the population, so the medical field also got interested into it. If that is so, why not to incorporate it as a lifestyle management and as well as an adjuvant in various lifestyle or various other disorders? So multiple studies, I'll just refer to a few of them more. That what ultimately it does is that if we look into the collective or the integrative approach, we can go either from the bottom up or we can go from the top down approach. And if we go from the approach, this was one of the famous studies done by Davidson et al., in which they found out that a person who is going for the regular meditation practice for thousands of hours or so, they were able to find out that when they hooked up the subjects, they were able to find out that the default mode network activity was reduced. Simultaneously, there was an increase in the synchronization of the brain circuits. And so they concluded that each and every thought process that we are having it, we have so many of the thoughts that we are going through, that all of them, they lead ultimately to the increase in the synchronized flow from the top to the down. And ultimately, it leads to the decrease in the inflammation and to the oxidative stress parameters, and also the parasympathetic dominance that we see, that is primarily from the top-down system. We also did the study and we took the trained meditators, and in this we took that the people who were meditating for more than 5 years or so documented, and we wanted to study their parameters. We did their QEEG, and along with that we also look for the subclinical inflammation. That means none of them was having any disease, so they were apparently healthy subjects. And we try to study what the impact of the heartfulness meditation did. Many of the subjects were the doctors also, and they were the regular practitioners. And our findings mainly corroborate with what other speakers have also told, that there was definitely a decrease in the inflammation. There was an increase in the QEEG parameters that we did. And also when we took their cognitive parameters, we were able to find out that even the cognition improved primarily via the top-down approach also. So this is one thing which I would like to, I have not gone into the details of the data sharing here. So if this was the coherence of the brain signals coming from various areas, we found that during the act of meditation, while we recorded QEEG, we found that the coherence also increased. And this coherence remained even afterwards, after when we asked the subject to come after 1 hour or so, and we again try to do, it was more than the baseline, suggesting that there is an increase, that all these activities have a residual impact. It is not only for during the act of the meditation, the impact builds up, and these circuits can also be made as the permanent changes in the brain. So ultimately, if we go for the yoga therapy, if any of these things, we usually go for, these are the 4 components. If scientifically, if we look into it, that there is schedule rectification, that means there is reactivity of the circadian rhythm. Then the breathing rectification, that is through the pranayamic activities. Then we have the diet rectification, that is the lifestyle, in which the diet also plays an important role. And then we have the practices. So practices are just a component of the yogic lifestyle. And if you want to see the integration, we need to take all these components into the activities, then only we can proceed further. So if we go from the yogic point of view, they say that we are composed of 5 koshas, and out of that, the mental or the psychological component, as we say, that is only the outer. We are having from inside to outside. If we go Annamaya or the gross body, Annamaya kosh, that is the physical body. Then we go to the Pranamaya or to the Manomaya kosh, and then to the Anandmaya kosh and Vigyanmaya kosh. So ultimately, what yoga sciences say, if there is a disturbance in the Manomaya kosh, that leads to a disturbance that percolates down from inside to the outside. So the root cause is somewhere inside. We need to take care of the root cause, and it is to be done through the yogic lifestyle rather than only through one particular form of the activity, or through the pranayama, yogasana, or any form of the meditative activities. So this will lead to the physical disease symptoms when it percolates to the outermost, that is the Annamaya kosh. So coming to the Manomaya, when there is a disturbance in the Manomaya kosh, it disturbs the Vigyanmaya, and then the failure to take the right decisions at right time leads to the psychological stress, and that leads to the chronic disorders. So I'll just come to the components, which are the mechanisms that these yogasanas, pranayama, the breathing regulation and meditation, how they are different, or how they are the same as any other physical activities. I'll just come to the yogasanas first. So are they same as any physical activity? Are they actually as a part of any other activity as we are doing it? So let's try to see a little bit of that. So if we take any yogasana, it is always first we go for loosening exercises. Thereafter, we go for the yogasanas. And if we take any of these activities, the posture is always assumed slow, gentle, and graceful movement. And usually we take a stretch of 10 seconds or so. If there are advanced yogis, we go for say 30 seconds, maximum 1 minute or so. So there is an isometric contraction. But the important thing is that every contraction or every asana will be followed by a period of relaxation. That is how precisely our heart works. That there is a systole, there is always a diastole. The diastole is always more than the systole. So when we are taking these yogasanas, if we take, there are so many thousands of asanas are prescribed, but if we see the chronology of all of them, we will always see that they are always slow, gentle, and the pose is always followed by a counter pose. And as well as it is always, the yogasana is not a physical activity. For example, if I'm going for a bicycle riding, or I'm going for any of the gym exercises, what my mind is thinking has nothing to do with my body. It may or may not be so. Even if I'm running or I'm going for a marathon, it may not be. So the attitude of the intention of relaxation and the focused attention on the task where the movement of the body is occurring is also a very important component of the physical activity. So in other exercises, another important thing that we can see is that the joint impact and the impact on one particular joint is totally different. If I'm going for the joint capsule, if I'm working on the bicycles or in any other forms, what we find out is that it will be loading some particular areas and the others will not be. However, when we go for the set of the asanas, as it is prescribed in the Fit India movement or in the common yoga protocol that has been given by the Ayush Ministry, what do we find out? That these asanas are synchronized in such a manner that every pose is followed by a counter pose, and nearly all the activities without any cardiovascular loading are used via primarily the bottom-up mechanisms. So all these asanas, they can be performed over a period of 20 minutes or so, and they can be compounded with various other forms of the activities. So coming to breath or pranayama, we did another study in which we took 90 subjects and we randomized them into the 3 adult groups, and we divided them into primarily 2 forms of the pranayamas, fast breathing and the slow breathing practices. Because there is a general thing that fast breathing exercises is something like if a person is going for a sprint or going for the pranayama or going for the marathon activities. So we wanted to see whether the mimicking effect is same or not. So our conclusion during these studies was that we could find that after 12 weeks of the practice, we found that there was parasympathetic resetting. The parasympathetic dominance was seen in both the groups, primarily because the mechanisms were a little bit different, but the increase in the vagal activity was improved in both of them. When we try to see the heart rate variability also, along with that, we also did the beat to beat pressure variability also. We found that the pranayama of either the slow or of the fast type, they were able to do the parasympathetic dominance. So when we combine the yogasana exercises with the pranayama exercises, again in a form that is suitable to the candidate or to the participant, we are able to increase the impact of increase in the parasympathetic dominance. Coming to the meditation, nobody knows how many thoughts we think, but usually what people say is that 50 to 60,000 thoughts per day. But most important thing is that most of them are negative in connotation, and we have no control over it. That is the primary thinking process in us. But the difference between any human physiology and perhaps in any other animal physiology is that we have a choice to think a thought and keep it in the memory, in the memory, and we can even do the calculations over that. We can keep the thought within our conscious mind, and we can keep working on that. Perhaps no other animal can do it for a long period of time and cannot project it into the future or into the past as well. So this is the thing which makes us capable of doing the meditative activities. And if this is the thought process that we are having, 50 to 60,000 thoughts or so, sir, I'll just finish it in 5 minutes or so. So if we are having this type of the thought process, and if we combine it to the meditative activities, this is what it looks like. Once we start doing it, that is via the top-down approach. What it does is that it is going to help us, as we also found in our study also, that it is capable of working through the prefrontal cortex, then from there to the subclinical. So I'll just straight away see what I feel that is the mechanism is, that through the epigenetic mechanisms, the executive homeostatic network, which is composed primarily of the prefrontal cortex, insular cortex. And what we see is that if we do any meditative activities, it will start from above, and it will also lead to the calming down of the default mode network activity, reflecting on to the each and every cell of the trillions of the cells of the body via the improved vagal tone, the ANS resetting, and causing increase in the telomere length and the increase in the telomerase activity. And ultimately, this leads to a decrease in the inflammation and also an increase in the immunity of the person. So I'll just skip all this and I'll straight away come to where I feel that. So we also did, we have just submitted one study in which we wanted to see that what will be the impact of meditation and slow pranayama, and also compared it with the standard yoga protocol on the autonomic function and stress in the healthcare workers due to the COVID-19 pandemic and correlation with the inflammatory and the oxidative stress markers. This is the study, the DST study, which we have just submitted 2 days back only. Still the data analysis is going on. So our observations were that even the need of the thing is that maybe that yogic asanas or yogic practices may not be suitable for each and every person, although they have a synergistic impact. So we wanted to study, is this combination, since I am interested in this meditative activity of heartfulness, whether when we combine it with the simplest of the activities that we can give it to the healthcare workers. I was given the choice of doing it on the nurses, So we found that when we did this standard yoga protocol was there, and we compared it with the impact of the meditation combined with the simple 5 rounds of the Anulom Vilom Pranayama, the result was that we were able to find that there was a reduction in the inflammation and as well as the inflammatory parameters, the psychological parameters. We tried to study the DAS scale and as the PSA scale. Along with that, we also did the heart rate variability and various other things. So we found that the parameters, and also we did the telomerase levels also. We could not do telomere because of the lack of the funds. So that primarily we would like to do in the future. So our findings were quite interesting to the extent that we found out that there was an improvement, but improvement was definitely more in the group where they were combining all 3 different types of the practices. But from the baseline, we have definitely found the improvement. To nutshell, what I would like to suggest here is that the mind-body interaction via the mechanisms, via the yogic exercises, they go from the peripheral, that is from the periphery, but with a focused attention when we work on anything, what we find out is that there is an increase in the afferent activity in the vagus, and then it leads to increase in the synchronization in the brain in the prefrontal cortex. And via the other activities, the pranayama also causes increase in the afferent activity through the vagus, and then it goes up to the brain, and there is synchronized outflow leading to improvement in the EEG and leading to the subcortical structure improvement. For example, the hypothalamo-pituitary axis suppression to decrease in the inflammation and to the oxidative stress. To summarize, the scientific studies support the evidence that these practices can be used to improve the health of the people. We can also devise various techniques which can be suited to the specific population. Thank you very much.
Very extensive work, Professor Sharma, and very nice work which you're doing. We wish you good luck for doing most of the work, and maybe telomere facility you should develop by now. And I think we should.
So we have submitted the project. Let's hope so.
I'm hopeful. Hopefully it will come. Thank you.
Thank you. Sir.
So we, positive of time, we go to the next speaker. Thank you, sir. We go to the next speaker, and next speaker is Dr. Kumar Savottam, who will be connected online. He's again one of the brilliant students for AIMS, now currently working as IMS BHU. His present area of interest includes obesity and cardiovascular diseases. He comes from the lineage of Dr. Rajkumar Yadav, again doing wonderful work. So over to Dr. Kumar Savottam. He's going to speak on recent updates in obesity and lifestyle intervention research. Thank you.
Thank you for the encouraging words, sir. Good afternoon to all dignitaries. So topic for today's symposium presentation is obesity and lifestyle intervention. I'll be talking about the recent work which we have been doing. So if you see, obesity is characterized as abnormal or excessive fat accumulation that may impair health, and its prevalence has been on rise. If you see the worldwide and India, everywhere we have increase in obesity cases. In worldwide, it is reaching around 40%, and India, it is also more than 1/4 of the population is overweight. Now, obesity prevalence is seen more in the urban population as compared to the rural population. Like the epidemic of obesity, the understanding of physiology of adipocyte is also expanding at the same rate in recent years. The earliest recognized function of adipocyte has been the energy storage in the form of triglycerides. An important function of adipocyte has been based on nutritional cues and hormonal cues to maintain homeostasis between lipolysis and lipogenesis. Adipocyte released lipoprotein lipases. They cause breakdown of the circulating triglycerides into free fatty acid, which is taken up by the adipocyte. Insulin-mediated glucose entry inside the adipocyte. They also provide the glycerols chains, and finally triglyceride synthesis for the storage of energy happens inside the adipocytes, primarily in the fed states when the energy surplus condition is there. In cases of energy deprivation states like fasting, or when there is more demand like exercise, there is stimulation of hormone sensitive lipases, adipocyte triglyceride lipases, which break down these triglyceride into the fatty acids which are released into circulation. These released fatty acids, they are taken up by the muscles for beta oxidation and by the liver for gluconeogenesis. What happens in case of insulin resistant states, both in case of fed and fasting, in cases of energy surplus and energy deprivation state, there is more increase in the free fatty acid release inside the circulation. So they get taken up by the liver and muscles, and there is deposition of lipid in these tissues, leading to the insulin resistance of these tissues also. Another function, important function, which has been recognized in recent years as adipose tissue working as an endocrine organ. Many peptides, lipids, nucleic acid factors, and other mediators are released from adipocytes. The notable hormones are leptin, adiponectin, and resistin. So when lean adipocyte is converting into obese adipocyte, there is increased deposition of triglycerides, so that intracellular organelles are pushed to the periphery of the blood vessels in vicinity, causing hypoxia, local hypoxia. It creates a cellular stress, primarily endoplasmic reticulum stress, leading to misfolded and unfolded proteins. And this is also associated with disruption of the extracellular matrix and remodeling of this. These cues invite deposition of immune cells, and also the phenotypic change in the macrophages which are present there from pro-inflammatory to the pro-inflammatory states. So here we generated a model where we propose that in metabolically unhealthy obesity, the adipocyte expands primarily by hypertrophy, which may lead to endoplasmic reticulum stress, leading to formation of unfolded and misfolded proteins. The misfolded protein response leads to activation of various transcription factors. One of the notable ones is nuclear factor kappa beta, which is a prime regulator for transcription of majority of cytokines, inflammatory cytokines like interleukin 6. So hypertrophic adipocyte creates an inflammatory milieu, and it is associated with decrease in adiponectin. Adiponectin is an adipocytokine which is depressing the gluconeogenesis, increasing beta oxidation of fatty acids, and improving the insulin signaling. But what happens when there is expansion of adipocyte, when there is increase in the adipocyte mass, there is paradoxical decrease in adiponectin level. Decrease in adiponectin level is associated with increase in endothelium 1, which is associated with endothelial injuries. So based on this model, we hypothesize that if we could reduce the obesity, we could cause the decrease in the fat mass, we will be able to reverse these changes which are happening. So our study was a single arm interventional study, a standardized program at AIIMS New Delhi, where yoga-based lifestyle intervention is given for 10 days. This yoga-based lifestyle intervention did not only had yoga posture, asanas, and pranayams, it also had individualized advices, psychological advices, and dietary advices by the experts, dietitians. And the parameters were recorded in the pre and post design, non-randomized single interventional international study, where the parameters which were recorded were height, weight, BMI, waist circumference, pulse rate, blood pressure, resting energy expenditure, fasting blood glucose, lipid profile. Plasma interleukin 6 was taken as a marker of inflammation, plasma adiponectin as a marker of insulin signaling as well as adipose tissue stores, and plasma endothelin 1 was taken as a marker of endothelial function. So the first observation we had was there was correlation of modifiable cardiometabolic risk factors with adiponectin, interleukin 6, and endothelin 1. So here we got that fasting blood sugar was correlating with interleukin 6, going in the line that when there is disruption of the insulin signaling, there is increase in the vascular inflammation. While the adiponectin was negatively correlating with the lipid profile markers like LDL cholesterol and ratio of LDL and HDL. Systolic blood pressure, diastolic blood pressure and pulse rate was correlating with endothelin 1. When we analyze pre and post, we found that there was significant decrease in body weight, BMI, LDL cholesterol, LDL HDL ratio, fasting blood sugar, as well as adiponectin and interleukin 6 after 10 days of yoga-based lifestyle intervention. So adiponectin was increased, positively modified, interleukin 6 was decreased. Although adiponectin is said to be decreasing the endothelin 1, but here we got in numerical decrease, could not get the significant difference in endothelin 1 levels. So after that, we fit in the same model that when there is weight reduction, there is associated decrease in inflammatory markers like interleukin 6, associated increase in adiponectin, decrease LDL cholesterol, and improvement in the insulin sensitivity. So after that, another study where our team was trying to see the effect of yoga-based lifestyle intervention in apparently healthy obese subjects, obese diabetic subject, type 2 diabetes mellitus subjects, patients, and normal weight type 2 diabetes mellitus patients in terms of improvement in ankle brachial pressure index, insulin resistance, and markers of anthropometry. So first we conducted a survey to determine age and gender wise comparison of obesity indices in subjects which are locally visiting the health camps, the patient bystanders, and volunteers coming to the program. And we found that deposition of fat has typical age and gender wise distribution. In males, 18 to 29 years were significantly different than other groups. Their fat percentage and waist circumference was lesser as compared to other groups, while in females, distribution lasted for 20 to 39 years of age group. Females of all age group had higher fat percentage as compared to the males of corresponding age group, while waist circumference of males were higher as compared to females. Out of these groups, we selected by application of inclusion and exclusion criteria for as apparently healthy obese subjects. And we were first to report that in apparently healthy obese subjects, there is correlation of ankle brachial pressure index and indices of adiposity. We first measured ankle brachial pressure index, which is a ratio of systolic blood pressure, measured the ankle to the brachial artery, and its sensitivity increases if it is recorded by using vascular Doppler ultrasound. It is an indicator of atherosclerosis at vascular sites, other than being a non-invasive diagnosis for lower extremity peripheral arterial diseases. So for this, we used VersaLab software, and we used 8 megahertz ultrasound, vascular ultrasound Doppler transducer. The patient was made to lie supine, and pressures were measured at brachial artery and at ankle, either at the dorsalis pedis artery or posterior tibial artery.
Kumar Savottam, can you come quickly to the conclusions?
So I'm coming, sir.
Out of time. Yeah.
Yes, sir.
Thank you.
So here we found that we recorded ABPI by 3 methods, and we found that ABPI low method had positive correlation, negative correlation with BMI, and positive correlation with the hip circumference. The one problem with the ankle brachial index recording is some patients are of occult obstruction. So resting condition, if you record, there is the ratio will be normal, more than 0.9. But when exercise, they are performing the exercise, the obstruction becomes prominent. So we want a standardized exercise, so the maximum voluntary contraction of each muscle be recorded in the plantar flexion and dorsiflexion, and we kept 30% of the load for the exercise, so that there is no arterial compression at that load, and person was performing exercise for 5 minutes, and then we recorded ankle brachial pressure index. So it added in the diagnosis of peripheral arterial disease in healthy obese subjects. For the subjects which are recruited for diabetes, before undergoing yoga-based lifestyle intervention, we also recorded the personality traits in both obese, normal weight type 2 diabetes mellitus patients and apparently healthy obese subjects who are not suffering from diabetes. And interestingly, the neuroticism, which is a negative personality factor, was higher in case of diabetes patients, irrespective of their obesity status, and openness to experience was lesser as compared with the apparently healthy controls. So I would like to sum up with this. The yoga-based lifestyle program is an ongoing trial here, where we are assessing the pre and post design and comparison with 3 different groups, which is obese diabetic, non-obese diabetic, and apparently healthy obese. And I'm thankful to the agencies and institutions which have helped me to perform these studies. Thank you once again.
Thank you, Kumar. A very nice presentation, and very much impressed with your innovation. And I must say that you should go for filing the patent and must finish everything in one and a half year. You can do it. So I think wish you all the best. Thank you. We can take up one suggestion if at all, otherwise we are running short of time.
Yes.
Thank you. Thank you, everybody. Thank you. It was a wonderful symposium from Dr. Rajkumar Yadav onward, and all these young guys who will take the yoga forward. Thank you once again. Thank you, Dr. Sharma.
I thank all the speakers for the wonderful session and for as an enlightening session for the scientific basis of both yoga and meditation. I request both the chairpersons to please come on the stage for felicitating the speakers. Hello, hello. I would request the chairpersons to please felicitate Dr. Rajkumar Yadav. I would now request the chairpersons to felicitate Dr. Rajkumar Yadav on behalf of Dr. Deepti Magan. अच्छा ठीक है ठीक है ठीक है and we would like to felicitate sir only on behalf of Dr. Kumar Sarvottam. I would now request Dr. Asha Gandhi to please come on stage for felicitating Dr. Nahi, sir. Dr. K.K. Deepak, please, ma'am. I would now request Dr. D.K. Dubey to please come on stage for felicitating Dr. Rajiv Bandhu.
Yes, I have got. Yes. Congratulations. Wish you very much. Sir.
I thank all the speakers, the chairpersons, and the delegates and the audience for participating in the event. Now we move on to our next event, the plenary lecture 6, the topic of which is Are co-infections modulating COVID-19 disease severity and clinical outcomes, a genomics-based insight. The chairpersons for this session would be Dr. Vivek Sharma and Dr. D.K. Dubey. I would request them to please come forward and take their seats. Dr. Vivek Sharma is Dean Academics and Professor and Head of Department of Physiology, AIIMS Rajkot, Gujarat. And Dr. D.K. Dubey is HOD Physiology at JIMS Noida. I would request them to please conduct the session. The speaker for this session would be Dr. Rajesh Pandey, who will be introduced by the chairpersons.
Hello. So very good evening to all. So in this plenary lecture 6, the title is Are Co-infections Modulating COVID-19 Disease Severity and Clinical Outcomes, a genomics-based insights. We have a wonderful speaker, Dr. Rajesh Pandey. Dr. Rajesh Pandey is the principal scientist at Institute of Genomics and Integrative Biology, CSIR, handling the integrative genomics of host and pathogens lab at Institute. He is PhD in Genome Sciences, Genomics at Institute of Genomics and Integrative Biology. Formerly, he was a research scientist at MRC Howell Institute, and his area of expertise and interest includes integrative genomics of host pathogen, application of next generation sequencing, that is NGS technologies for high throughput, cost-effective genetic assays, functional genomics, especially RNA biology in general and non-coding RNA in particular, and disease models, inclusive of organoids for understanding the disease mechanism. To his credit, he has published more than 134 research papers and has more than 1,327 citations. I welcome Dr. Rajesh Pandey and I hand it over to you now, sir.
Thank you, sir. I think it's an honor to be here and speaking to a group of clinicians par excellence. And I'm slightly misfit in a way that I'm a PhD and that also in genomic sciences. And genomics as a discipline has been quite useful. And if I may say so, in last 2.5 years, roughly, genomic surveillance has something which has brought genomics close to public conversation when we talk about in terms of different variants, different SARS-CoV-2, Delta, Omicron, everything. And genomic surveillance has been helpful to understand, detect, and discover. So what I will be presenting here is slightly different on that perspective. And what would be different, or what is different that I would be talking about? So if we go back, rejig the memory a little bit, and we find before variants came into picture, and even after the variants, that all the individuals who are infected by the virus do not end up in hospital. Many of us are asymptomatic. A subset of us are symptomatic. Of the subset who is symptomatic, some are mild, moderate, some are severe, and some are unfortunate deaths as well. So we wanted to understand what are the factors or what may be the modulators which may be playing a key role in driving this differential disease severity, leading to differential clinical outcome. So one of the factors which we are working in the lab is whether co-presence or co-infection of other microbes or potential pathogens within the patient can be a modulator. So before I go dig deeper into some of the research findings from the lab, slightly introducing to what we do in the lab. As you mentioned during introduction, we work on integrative genomics of host and pathogen. Many a times pathogen belongs with a little bit of a negative connotation. So we have acronymed as INGEN HOPE. So we are trying to work towards genomics based understanding so that we can have markers for better prognosis and stratification of patients who can be prioritized for medical attention and medical care for a better disease outcome. So some of the factors which we work on are understanding the pathogen's genome. So in a genome of say SARS-CoV-2, which is 30,000 base pairs approximately, what is the information which is encoded there? When we look it from, it's like a Google map. When we look it from the top, what is the makeup of a SARS-CoV-2 genome? And now, as we know, there are different SARS-CoV-2 genomes which are there in India and globe as well. So trying to understand from a snapshot, and that's what the role of genomics is, that if I look it from the top, can I find houses which has yellow tops or red tops or a green tops, and then try to understand that whether a yellow one is more dangerous than the red one or vice versa. If I understand the pathogen, then looking at the patient who have been infected with this pathogen, try to see how different host is responding. So within our lab, we look at differential host response in terms of transcriptional host response. And when I say transcriptional host response, it includes genes. It includes genes which do not code for proteins, which are non-coding RNA. Then we look at the single cell level as well, that if we look at the transcription or translation within a single cell, what is the cellular heterogeneity within the patient subtypes, and whether those cellular heterogeneity have a role in modulating disease severity and clinical phenotype. And as a personal interest, I think, and that has been emphasized a lot during COVID times, is we need to democratize genomics. By this, I mean that today, if we have to look around us and see how many labs or how many institutes or how many places can do RT-PCR, we find a loads. But how many places which can do sequencing, we have a lower number. How many places can infer from that sequencing data, that's an even lower number. So we need to understand that sequencing, there is a growing emphasis on sequencing, but still there is a lot of scope to understand genomics, because sequencing is a static information. It is ATGC, depending on the pathogen or a genome we are studying, it is an arrangement or it is a sequence which gets generated. But what is the information coded there? How do we infer that? What do we understand? How do we understand? So combining all this together comes under the umbrella of genomics. So we need to have a bigger pool of researchers, bigger pool of people who integrate the requirement, understanding a pathogen, understanding a host response, sequence them to understand it, and then analyze it for inference based on. So integrating all of three together, in my opinion, would come under the umbrella of genomics. And we have to develop toolkits, if I can say so, wherein we can take genomics to places where it is required. So just to preface the whole talk, we know the challenger a lot. And this data is slightly older now, because if we look into GIS-8, where globally people submit the SARS-CoV-2 genome sequences, we have sequenced tens and thousands and lakhs of SARS-CoV-2 genomes. But at the same time, we haven't understood that much the challenge or the person or the individual or the host who is challenged. So we have known a lot about challenger, but we need to know more about the host which has been challenged. So in that case, we found a very, very handful of studies wherein the host response have been studied in greater detail. So towards this, we have made an effort towards understanding a lot of those modulators and some of the aspects which we have done in the lab, which has convinced us that there is a role of modulators. So these are some of the summary slides of different works which we have published during COVID times, which are in now excess of 35 different research articles. So one of the research themes which we have understood is what happens during vaccination breakthroughs. So we have seen, or when vaccination started, at least the assumption was that we will not be having infection. But then soon after we realized that there are infections. But the good part was that we had milder symptoms, but that was never the bargain to start off with. So when we started to see breakthrough infections, the idea was to we started to think that, okay, what may be the modulators of that, or what can we understand from those vaccination breakthroughs. So through clinical partnerships, understanding the pathogen genome, understanding the mutational differences between the vaccinated and the non-vaccinated, we try to understand that what can be the information. And we found that within the vaccination breakthroughs, there are definitive set of mutations within the SARS-CoV-2 genome which are important. Another study part which we have done in the lab is understanding the host response. So this is just a snapshot which I am presenting for different work from the lab, which are either published or which are being under revision and review in different journals. So this one is an clinical and translational medicine, where we have looked into the host response. So we studied 125 hospital admitted patients who had differential disease severity, mild, moderate, severe, and mortality. And we try to understand how they are responding differently and in what context we are able to understand the differential disease severity. The third component which we are understanding is in terms of non-coding RNA. So we all know that, okay, this gene or this cytokine or this interleukin will do this. But when we look at the whole bucket of transcription in a human context, only 2% we know that those are protein coding. So what happens, the other component of it? As we know that the most efficient, energy efficient system is a cell. So if a cell doesn't need to utilize the one it is transcribing, then why do transcribe? So we wanted to understand what is the component of the transcriptome or the host response which is not coding for the protein. So we have understood a great detail about non-coding RNAs and their modulatory role in immune response, not directly always, but indirectly through interactions with the protein coding genes and miRNAs and proteins networks which it can modulate. And because we have a hierarchy of data wherein we have clinical data, we have pathogen genome data, we have host response data, we have non-coding RNA data, and we have single cell data. So we have tried to integrate it all together through the strength of artificial intelligence and machine learning to see whether we can identify factors which can be used for prognosis or diagnosis for patient stratification. And last but not the least, before moving to the topic for the day, is understanding the role of cellular heterogeneity. So this is a study based on looking at the single cell level, that within a cell what's happening. Because when we do host response at a cumulative level, we are actually putting everything together. But here it is trying to go the best granular possible and see that within a single cell, what all is happening. So coming to the topic of the day, when we decided to work on this, we put an effort in the lab to first put all the factors together which may be governing the co-infection itself. So we found that if we primarily look into the co-infections, it can be through co-presence of bacteria, fungi, and other viruses, in addition to SARS-CoV-2, which we are studying. On top of it, when we go, they may be living very happily with each other. They may not be living happily with each other. They may say, oh, I don't care about you, whether you are there or not. In some cases, it may say, I don't like you. You don't need to be here because you are competing with my resource requirement. So what kind of a relationship it is having, whether it is having a symbiotic relationship or it is not having so friendly interaction with them. And then if you go a layer above it, that may lead to resource and space limitation, or look intergenome or intragenome interactions. So if we combine all of this together, the regulation within the co-infection itself can have a genome context, a metagenome context, a epigenome context, and other contexts which are present, which I have named it here. So to understand it, we started with the first phase of this study in May, June 2020, in partnership with Max Hospital. And we started with a set of 100 patients who were admitted in Max. And we decided, because when we talked to the clinicians, we found the data which showed that some of the patients who come to the hospital are simply are symptomatic without having any discomfort in terms of shortness of breath or respiratory distress, whereas a subset of patients had shortness of breath when they came to the hospital. Subsequently, they were tested by RT-PCR, and if found positive, they were admitted, whereas a subset of patients came to hospital with respiratory distress, so they had to be admitted immediately. And within the patients who came to hospital with shortness of breath, there was a subset of patients who required respiratory support later on, whereas a subset of patients did not require. So we decided to understand what's happening within this small subset of patients. So this slide may be slightly busy, but not the important message is that we sequenced everything what was present in that nasopharyngeal RNA. So we sequenced everything. So we found that in addition to SARS-CoV-2 genome, what are the other co-presence of other potential microbes, which includes bacteria, fungi, and viruses. And again, looking into the clinical data, we found that the patient cohort which we were studying, they had diversity of symptoms, which a differential proportion had fever, sore throat, cough, or other comorbidities. So that also helped us to move towards that question more closer, that there is diversity of symptoms. Although when you look at the SARS-CoV-2 genomes of all those 100 patients, we don't find diversity in those SARS-CoV-2 genomes. So they all essentially belong to the same clade of SARS-CoV-2 at that point of time in May, June 2020. So what is the additional factors which may be modulating what we are seeing? So when we looked into the whole, so this approach is called holotranscriptome. So whatever is present in the nasopharyngeal RNA, we sequenced everything, and we found that in addition to SARS-CoV-2, there are other viruses which are present in these samples, which includes human coronavirus 29E, human masterinovirus, and other viruses with differential proportions. So the B section of this figure shows the differential presence of these different viruses in this patient group. So then we looked into whether there is any correlation between the phenotypes which we are seeing in terms of shortness of breath, in terms of requirement of respiratory support, and differential presence of these viruses. And we found that there was a correlation in terms of the differential presence of these viruses as well as the disease patient subphenotypes. Then we looked into the bacterial component, that what is happening there. So it is interesting to see that if you see the figure B, you will see that there is a whole diversity. There is a range of bacterial reads from these patients ranging from 35% to 65%. So it can be either just a technical noise, because sequencing may a possibility have, but then we broke this into under different patient subtypes. If you see specifically the figure C and the one in which it is written shortness of breath, we found that in the patients who came to the hospital with shortness of breath, there is increased abundance of bacteria, and this has been normalized with respect to age-matched controls. But it is important to emphasize here that we have consciously, in the studies in the lab, we have compared it within COVID patients. So we have not compared it with healthy patients. We have looked all within COVID patients. So these all are 100 COVID patients, which has been confirmed by RT-PCR, followed by sequencing. Within those COVID patients, what is the differential phenotype which we are seeing? So we found that the shortness of breath, patients who came with shortness of breath had a higher abundance of bacteria. So what does it mean? Because this was a study which was being done for the first time globally, so it was important for us to benchmark the method as well, that we are not erring anything on the technical aspect of it. So we validated using two parallel approaches. One is probe-based approaches, another is sequencing everything what is there in the bucket. And we found that there was, the yellow ones in the middle shows that there is concordance of certain viruses which are captured by both the platforms, whereas there is uniqueness which are being captured by either of them, because which is not surprising, because one of them was a targeted approach wherein it had probes for SARS-CoV-2 plus other 42 respiratory viruses, whereas other one was sequencing everything which was there in the pool. So the one on the my left hand side, you can see that the ones which are in maroon are actually the bacteria discovered by holotranscriptome. So because not much was known during that time for COVID with respect to co-infection. So for the top 100 bacterial reads which we found, we went back as a group studying what may be the functional role which they may do. So we found, which was not unexpected, was a majority of them were anaerobes and a very small subset which was aerobes. But what was interesting and important for us, that of all those top 100 which we studied, more than 65% were the ones which were known to cause respiratory distress, which was not, which helped us to explain the findings, because these were the patient subsets which were having either shortness of breath or respiratory distress. So if you look at the figure B, for example, the three bacteria which are highlighted here, the Clostridium, Bacillus, and Halomonas, they are present in all the 100 samples which we have studied. But if we see their differential presence, they're differing, and this has been normalized with respect to the reads generated from each of the patients. So what we are seeing here is reflecting that when we talk about patient-to-patient differences, they're having differential abundance. And the C and D, what we see here, are essentially a specific example from specific patients. Specifically, if you see Halomonas SP is known to cause respiratory distress, and in the patients who required respiratory support, the percentage of this bacterial leads in those patients were extremely high. But if you summarize the whole story together, we started with 100 COVID-19 positive patients, and through a combination of sequencing based on two different approaches and analysis, we finally ended up identifying 43 different bacteria, 29 viruses, and pointing towards a possible role of co-infection in respiratory in COVID-19 manifestation. But it had a lesson for us as well, that we didn't find any significant association of any bacteria or virus with any of the subphenotypes which we looked into. For example, the shortness of breath and respiratory requirement of respiratory support being the main. So that took us a step back, and we asked that, is it relevant for us to move further in this direction? But at the same time, a kind of an offshoot for us was that when we found that the bacterial abundance was very much ranging between 35 to 65% and correlating with specific patients, we thought that possibly it may be because we haven't looked into the spectrum of disease phenotypes that far in this study. So in the phase 2, when we were looking at a stage where there were now patients reporting for more severe disease manifestations, and also we started to have mortalities because of COVID-19, we did a phase 2 of this study wherein we had more concrete clinical data to classify patients into mild, moderate, severe, and cases of mortality. So I will start with the summary slide first. And in this study, we found that there are specific signature of bacteria which are significantly associated with different disease phenotypes of mild, moderate, severe, and mortality. A case to remember, which I'll refer to at the last, is Achromobacter xylos oxidans. So Achromobacter xylos oxidans was found to be highly abundant in the patients who could not survive. And there has been a wealth of literature which points out that Achromobacter xylosoxidans has a big role in microbial resistance or so we hypothesized that possibly as a standard line of treatment, all of these patients were given antibiotics, and we had got data from the clinicians supporting that all of them were given antibiotics. So there is a possibility that the patients who did not respond in terms of controlling the secondary infections are possibly the ones in which because of the higher abundance of this bacteria, maybe the efficacy of those antibiotics was not as was desired. So again, starting off briefly going through it. So we have started first looking at the clinical data, and we found that the age was definitely different when we look into mild, moderate, severe, and mortality, wherein the higher age group of patients had severe or mortality situations. And then we looked into the SpO2 levels, which was available for these patients, and definitely the SpO2 levels was lower in case of severe and mortality patients. And when we look at the hospital stay, it is interesting to find that the patients who actually had moderate symptoms stayed in the hospital longer compared to the mild and other patients. But we didn't find any correlation between the CT value of SARS-CoV-2 in all of these patients. And I have depicted here for one gene, but we looked for more than one gene, but we didn't find any significant correlation between disease severity and the CT value. And then we looked at all the clinical data which we have for these patients. We again found some of the patient clinical symptoms were significantly present in some of the disease subtypes. So building on to what we did before, again, we looked at the SARS-CoV-2 clades, and this was a time when internationally there was more analytic tools available to classify and understand the SARS-CoV-2 more and more. But still what was evident from our analysis as represented in figure A, that the patients who had differential disease trajectory were not particularly present in particular clade of SARS-CoV-2. So there were mix of patients in different clades. So that again indicated us that it's not the only driver, whereas some other studies in the lab did indicate that it may be one, but it's not the only one. So we went to understanding that what is there any frequency level, is there any specific set of mutations which are present in these patients who either survived or who did not survive. And we did found that there were some specific mutations which were present, which is part of another study which is ongoing in the lab. So this time around, we directly started with the bacterial abundance, and we will come to the viral one at a later on. So when we look at the diversity of the bacteria, we didn't find significant diversity within the bacteria. But what is important that if we look at the figure C, we found that in the cases of severe and mortality, there was higher abundance of bacteria. So that was a positive finding from the work to dig deeper and see that why the abundance is higher in severe or mortality. Is it the cause or is it due to effect part of it? So if we look at the whole top 30 bacteria which were present in this cohort of patients, we found that 3 which were present in most of the patients, which is Veillonella, Raystonia, and Staphylococcus, and then rest of them had a differential abundance across the disease phenotypes. And please remember Veillonella at this point of time, which I'll refer to after a couple of minutes. So when we look into whether any of these top 30 bacteria, and why top 30 bacteria, because we also wanted to be sure that these are the top candidates, because based on the sequencing data, we wanted to have a definitive number of reads mapping to such bacteria so that we are confident about the findings of the study. So when we look between different disease groups, we found that Achromobacter xylosoxidans is highly abundant in mortality as well as Bacillus cereus. And then Leptotrichia was different between higher in mortality and as well as moderate, and whereas Veillonella was higher in the moderate patients. Veillonella is an important candidate because around this time there was another study from China which showed that when you compare the flu, healthy, and COVID patients, Veillonella was found to be a signature for COVID-19. So in an independent cohort from India, it was an important finding. But at the same time, what is more important for us that if I pool the data together, all COVID under one umbrella, then it doesn't come significantly different. It comes significantly different when I look at the patient subphenotype, that a patient who has mild symptom, moderate symptom, or a severe symptom, when I classify the data or a patient into different subphenotypes based on the disease severity, then Villanella is abundant in moderate. So that was a lesson for us, and that's why the paper, when we submitted, it had one strength, that we need to look at the patients in a group rather than as a pool, everyone together, because everyone is not the same. So we need to look at what is the similarity, and even try, instead of personalized, possibly looking at in a stratified way is a better way, so that we can have a better disease management in these patients. So because this was a holotranscriptome approach, we captured all the bacterial genes from this data, and we looked at what is the functional enrichment of these genes. One is the way of looking at the bacterial species way. Other is to look that if I have 4,000 bacterial genes in this data set, what is the overall of a functional direction of those genes in terms of what they can do. So we found that when we look at the gene enrichment analysis, we found that the ribosome, bacterial motility proteins, and bacterial chemotaxis, these are again different between the subphenotypes. Yeah, I can wind up in 2 minutes, not much. It should be okay. So we found that if we, so building upon say bacterial motility proteins, for example, we found that it is different between mild and mortality. For example, it is higher in mild and lower in mortality. Why? What is the relevance of if there is a lower abundance of bacterial motility proteins in mortality patients? One of the hypotheses, again going to literature, then coming synthesizing the finding over some literature over there, we feel that possibly the clearance of the bacteria is not happening that way, or even if when an antibiotics is given, the assimilation or the entry of that within the bacteria is not happening, because the ability of the bacteria to for its intake is compromised, because it is kind of in a static mode rather than in an expansive mode. So there is an evidence in literature around it, and many of these leads are now being followed further in the lab. And briefly touching on what we found in terms of the viruses, we found again, in addition to SARS-CoV-2, there are other viruses also present within these patients who have different disease phenotypes. So if we put everything together as a story and try to understand that what did we understand, which we didn't know 6 months back. So if we put everything together and try to see what did we understand, first thing which we understood was that there are differential signatures of bacteria in disease severity subphenotypes. So it is important to look at the patients based on the symptoms which they are displaying rather than as a monolith. And what may be the possibility as to why we are finding what we are finding. So in that case, we seem that if we find higher abundance of Bacillus cereus or Achromobacter xylus oxidans, with known role of Achromobacter xylus oxidans in microbial resistance, then possibly we need to look at the treatment regime of antibiotics which can be given. So now we are talking to clinical partner to see whether we can use these 6 bacteria primers and use it for RT-PCR in addition to SARS-CoV-2 in future. And we said that we are happy to do the proof of concept within IGIB, that anyways you do RT-PCR to screen out patients. How about if we include primers for these 6 months, and we can build some data to see that with what confidence we, in the prospective cohort, we are able to sub-stratify patients based on the expression of these bacteria, whether we are able to move into a situation where we can prioritize a subcategory of patients and look them or monitor them closely for a possible disease severity. So this is just summary of the whole thing. So the road ahead, what we are doing currently in the lab, we are now studying what is happening across VOCs. Why Delta and Omicron waves, both were waves in terms of magnitude, but then why the unease was much more during Delta times. One easier way of, or probably a bigger way, is the difference in the vaccination coverage. But based on during Omicron also, we found a good number of patients who could not survive, although they were double dose vaccinated. So we are also conducting a study in that to see whether there is anything different over there, whether we can differentiate between patients who died due to COVID or patients who died with COVID. So I may be admitted to hospital for something else and I may have COVID at a later on. Whereas the other may be true that I came to hospital because of COVID. So looking at different COVID-19 cohorts, because most of these findings are from clinical partner in Delhi, Max Hospital. So now we are extending it beyond Delhi to other cohorts with other clinical partners. Then looking between VOCs, looking between vaccination breakthroughs, and then between diseases as well. And with that, I will stop and thank you so much.
Hello. Dr. Rajesh has done tremendous justice to a very complex topic, number one. Number two, the thing is that we all have, witnessed the tragedy associated with the virus. I have one query.
Please, sir.
That most of these studies, they are, retro. The event has gone and then we are trying to analyze. After an experience of about 2 years plus, can we say, though the similarity may not be there again, because as a so-called genetic specialist, it may not recur. The virus may have 10 different shades of, what it was. So can we say confidently that whatever knowledge world over what we have acquired, like your colleagues, and that we will be able to handle it in advance, if at all it is of almost similar nature?
So let me start with an honest admission that, and that is a conversation which I have with my colleagues at Institute, as well as with funding partners, as well as through funding partners, worldwide collaborators, that till now we have been reactive in terms of something has challenged us, and then we have reacted that how do we best understand or best respond to it. As a group, we have tried to take up the challenge that whether we can do something prospective. And the last couple of slides were an effort in that direction. And that's what I have consistently talked to clinicians and said that, well, don't mention it anywhere. This is not, anyways, you are going to do RT-PCR. So that's given. Well, how about this is one part of the study which I have said. There are other part of the study wherein we identified gene signatures as well. So we said that we are working on a panel of 30-40 candidates, which is bacterial, which is host genes, which is non-coding RNA, with definitive role in disease severity. So we are proposing that how about we use it as a panel to screen patients and see whether we are successful. I'm sure I will make more learning, because as you said, and as we now all understand that probably when the next wave comes, if it comes, it will be not on the same background. So whether what is the role of those, virus genome architecture as well. So there are different variant specific mutations also what we have identified with some protein structural studies which we are doing to see that if these particular mutations which are present in alpha, delta, and omicron, why they are not having a same sort of a problem when I look at the ground level patients who are infected. Then we found, and this is a study we have just sent it to a journal couple of days back, that it is the combination which is important, not the individual. For example, when D614G initially came or was reported, it was found to be a magic bullet that if a virus has D614G, it will be problematic. We soon now have seen data that it is stabilized all across the globe. So definitely that's not. But again, when we look at the data for last 2 years, and that we have looked closely at our own lab data, wherein we have sequenced thousands of COVID samples or COVID genome only, we find that it's a combination which is important. So what comes along with D614G, that is important. So it's like, wearing a dress for the day. What I wear on top is also important if the contrast is going right or not. So if I wear something which is white, it will be different. So we are trying to, again, that's a different genetic panel we are developing for screening of patients and see whether we are able to stratify patients at the level of pathogen and then at the level of host response, capturing this all three different hierarchies
But I agree with you that that's a challenge, and that challenge we should actually take on us, because it's a challenging thing to do. Because if you see here, we are not talking about one pathogen. We are talking about hundreds of bacteria which are much bigger than SARS-CoV-2. SARS-CoV-2 is only 30,000 and normal bacteria would be 4 MB.
Rajesh, let me put it that way. People have forgotten probably the importance of virologist and microbiologist. So now they have been brought into limelight and you are very much on the front. So I won't say best of luck to you so that your importance comes up again, but notwithstanding that, the good work will never go waste. I think we'll have a creditful knowledge and that will be utilized somewhere in future. Right?
Thank you so much.
Any question from the audience? Any query, any comment? Yeah.
Excellent work. Really, I really, it was very, very impressive, the work that you are doing in this field. It's amazing. So I have one query that this new variant that has come, XC variant. So the strains that it has, I think, of BA1 and BA2 also. So do you think it is going to cause a severe disease or a less serious disease?
I will be honest.
This is the question on everyone's mind.
Yeah, I mean, still the jury is not completely out in terms of whether it is an analysis or a sequencing artifact or it's an actual thing. There has been conflicting reports in that direction. Whether it would be that way or not, your prediction would be as good as mine, very frankly. Because if I or anyone was so wise, we could have predicted about Delta. Because again, it's a matter of what combination it works. We may know the sequence of XC which we are talking about, but it's not alone. When that virus comes into me or you, it's a different other factors also it will come. It will have other, for company, it will have other bacteria within me. It will have my immune system. So how it will be, I do not know at this point of time, but based on the experience of BA.1 and BA.2, if I can profess, then I don't think it would be that severe for us all to be so worried, but definitely masking up is the best thing which I have practiced.
That's really, really reassuring to know. Thank you so much.
This state is what Madam has asked is something like that. If there is a tiger in front, what will happen? Whatever has to be done by the tiger knows. We don't know what is going to happen. So anyway, thank you very much, Dr. Rajesh, and very elusive and very complex thing. So now may I request organizers to do their part of the duty. Thanks a lot. Thank you.
Thank you so much, Dr. Rajesh, for providing a beautiful insight on a very difficult topic. Now I request the chairpersons to please come on the stage to felicitate the speaker. A big round of applause, please.
Proud privilege to have him here, and on behalf of the organizing team, I am giving this short to him.
Dr. Girish, Dr. Girish. I would now like request Dr. Divya Srivastava, Professor in HOD Department of Physiology, SN Medical College, Agra, to please felicitate the chairpersons. Now we have with us the award ceremony for poster presentation on behalf of the organizing committee. I request Dr. Rajkumar Yadav to please come on the stage for giving away the awards. Yes, sir. The first prize goes to Dr. Pooja Kumari. The second prize goes to Dr. Hina Parihar. Third prize goes to Dr. Gayatri Devi. Sir, 1 minute. Now the certificate for the presenters. I would request Dr. Kuhu Chatterjee, presenter. Is she here? Okay. Poster, sir. Dr. Pradeep Barde. Dr. Nikita Parmar. Dr. Pravina Sinha. Dr. Vivek Sharma. Dr. Bhumika Jaising. Dr. Saroj Agarwal. Dr. Sankalp Jha. Pravina, you can receive on behalf of Sankalp. Thank you, sir. Thanks a lot. Now we have a video message, Save the Soil from Isha Foundation. Before that, we have volunteer Alka ji with us, who is a volunteer from Isha Foundation. Please welcome, ma'am.
Namaskaram, all of you. I'm Alka. I would like to thank, first of all, Head Department, Physiology and Registrar Academics, Professor A.K. Pandey. You know, he has allowed us to spread awareness about safe soil. As you all know, when we talk of environment, we talk of pollution and global warming and water scarcity, but we never think of soil. Soil is a dire situation, you know, we are facing. Soil is getting extinct. So Sadhguru is giving some message. You can just go through this video and support this movement. Thank you so much.
Live in being hit by less and less fertile soil, making crop growing increasingly difficult.
Sandstorm conditions prevail in the Indian capital, and now there are fears of early desertification of the region.
Desertification and erosion are both concerns.
Soil is the habitat upon which zillions of lives thrive. Because of that thriving life, everything grows. We eat food. Other animals grow, everything happens because soil is rich. Once there is no richness in soil, then you have forsaken the planet in many ways. We talk of carbon, we talk of emissions, we talk of pollution at various levels. Before all that, we need to address the most important concern, because there is a misunderstanding in the world. There is a campaign to project civic issues as environmental issues. Right now, if plastic bags are floating in the city, this is not an ecological issue, this is a civic issue. If our rivers are polluted, this can be fixed. In 1 or 2 years, if you set up the necessary purification plants and enforce the law, these are civic issues which can be fixed with a little bit of law enforcement and awareness. But the real issue is soil.
The United Nations agencies with enough scientific data, they're clearly saying that we have soil, agricultural soil, for another 80 to 100 crops on the planet. This is 45 to 60 years is what we have agricultural soil. We are calling this as soil extinction. You've heard of rhinoceros going extinct, you have heard of dodos going extinct, but this is soil extinction is what we are looking at. The real problem is soil extinction because in the last 30 years, 80% of the biomass insects have disappeared from the planet. 80%. This is a suicide. You know, this is a real suicide.
So in 45 years' time or 50 years' time, there will be serious food crisis on the planet, it's inevitable. When food crisis comes, well, whoever has the biggest guns will come and take the food. And the chaos and the suffering that we will create for populations around the world is unimaginable. Don't think only the poor people will die. They will kill the rich and which will… So this is not to paint a dark picture. This is a reality which has happened many times in our history, and once again it is being predicted by top scientists in the world. So what are we going to do?
Why is soil going away? Where is it going away? See, what is sand becomes soil if you add organic content to it. What is soil becomes sand if you take away all the organic content from it. If you go into a rainforest, the organic content in the soil will be over 70%. In normal agricultural soil, the minimum organic content that has to be there to call soil soil is 3 to 6%. 3% is the most minimum. But today, for example, in India, 62% of India's soil, the organic content is 0.5% or below that. So literally we are on the verge of desertification. This is across the world, this is not in one country. In United States, the way the land has been used in terms of herbicides, weedicides, pesticides, well, we need to understand nearly 82 to 86% of biodiversity is within the first 12 inches of topsoil. When we plow with machines, like tractors plow to a depth of 9 to 12 inches and leave it open, this means we are destroying the biodiversity completely. What biodiversity means is, it's the humus in the soil. The word human comes from the word humus. That means this is actually living soil.
It's very, very important that soil becomes the focus, because if you put 1/3 to 40% of the land, especially in the tropical world, under tree shade, your climate change could be easily reversed. Land is getting hot simply because it is plowed or it is paved. Land has to go under vegetation, whatever kind, natural grasses, bushes, trees, whatever, because all these are serving the ecological activity. And we must also understand soil is a very significant carbon sink. And soil is the largest water soak on the planet. And soil is the basis of all life. This 36 to 39 inches of topsoil on average around the planet is the basis of 87% of life on this planet. To keep the biodiversity alive is the most important thing that we need to do right now. Unless we start now, this will not happen. As a part of this, we are unfolding a movement called Conscious Planet to bring maximum number of people. Right now, it looks like climate change, ecology, all these are playground for the rich and elite. No, this must change. Individual human beings should become conscious about the danger that we are facing. Ecological issues must become election issues, and political parties must give significance to ecological issues in their manifestos. Governments must be elected for their concern for ecological issues. This needs to happen.
So we are seeing how to bring about a policy recommendation for 192 countries. The rally is starting on 21st of March, which is the equinox day in London. And from London, it's a single lone motorcycle riding through 24 countries, 30,000 kilometers, reaching the Kaveri Basin, where we are on ground working in a river basin which is 83,000 square kilometers, and 5.2 million farmers work here.
The very body that we carry is soil. Without soil being rich and well, this body and every other life cannot be well. So in terms of ecology, in terms of climate change, the most important thing is that we need to have a conscious approach as to how we manage our soil, how we rejuvenate our soil, how we revitalize our soil. This conscious approach and creating a conscious planet is what is most important. Without involving large mass of people, this will not become a reality, because we are democratic nations. Unless people say this is what they want, that is not going to happen. So let's create a conscious planet. Let us make it happen.
Save Soil is a global movement to bring about a conscious approach to our soil and our planet. It seeks to bring about policies to save soil in all democratic nations. Towards this, as a lone motorcyclist, Sadhguru will ride across 24 nations to activate the support of 3 billion citizens worldwide. The rally will start in London and culminate in the Kaveri Basin in southern India, where 62 million trees have been planted under the Kaveri Calling Project. Unless we save soil, we cannot protect our environment. Too much carbon dioxide in the atmosphere is causing the planet to heat up. Without reviving soil, we cannot stop the rise of carbon dioxide and global warming. Healthy soil will increase food production and can allow us to feed 2 billion more people. Improving soil quality will increase water stored in soils and help provide water for 600 million more people. Rich soil can increase the income of farmers and help eliminate global poverty. Soil is the biggest ecosystem on the planet. 87% of all life depends on soil. For the future of our planet, let us come together to save soil.
Evening, everyone. I think many of you have put a lucky draw from the AD counter stall. So now this is time to announce the result. Who is the luckiest or lucky one? क्या करना है? एक ही निकालना? ओके, एक एक करके ये है अच्छा मुझे क्या है अनीता मल्होत्रा डॉक्टर अनीता मल्होत्रा
GMC
Chandigarh. She is here. देना इनको Dr. Vishal Vaibhav from ESIC Medical College Bihita. नहीं विशाल वैभव ओके नहीं है सबको दिखा दूं इधर The third one is Dr. Divya Singh. Dr. Divya Srivastava. Oh madam, SN Medical College Agra. Dr. Ashish Arvind, AIMS Gorakhpur. Dr. Ashish Arvind, AIMS Gorakhpur. है? Anyone from Gorakhpur? मुरुगनाथन ESIC फरीदाबाद स्टूडेंट एलिल अच्छा हाँ कोई स्टूडेंट हो सकते किस बैच के भाई ESIC फरीदाबाद एलिल मुरुगनाथन any student because it's not faculty ESIC फरीदाबाद प्राची श्रीवास्तव एम्स दिल्ली प्राची श्रीवास्तव एनीवन फ्रॉम एम्स दिल्ली हो गए हाँ भाई डॉक्टर राजकुमार मेरी सी बस हो गए आई थिंक दीज आर अच्छा ये कौन है पूर्वी कुलश्रेष्ठ एम्स ऋषिकेश डॉक्टर पूर्वी वो तो थी अभी आई थिंक कल सुबह ठीक है उनको दे दूंगा आई थिंक दैट्स ऑल दिस 6 लकी नाउ आप उनको फोन करके बता दें आ जाओ प्रवेश
हाँ सर नाम लिखना है क्या
I think we announced that GBM will be at 5. So I think shall we go for tea break then GBM or we can start GBM followed by tea break? Because none of the office bearers and finance secretary already left. Right. Thank you, sir. So I think only I will read the minutes of this meeting. Because without the finance secretary and IGPP, so whatever, because and some issues were there that were need to place in the GBM, so it may be carried forward to the next meeting on that.
hello
No, but all otherwise also Dr. Nilal I don't know by department orthopedic where he was there.
Things are so important, then forget about GBM.
See, that's why I propose that this EVM may not be complete, but at least whatever EC meeting, that only that content of EC meeting. EVM of DPPI includes IGPP as well. And he is the executive editor of IGPP, so his presence is equally important.
No, no, it is part of the office bureau. It should be here. Plus,
let me call him.
Yeah, all those people are required. Pandya Bhaus is just not.
No, Dr. Neelam Bani is already she resigned and has been accepted. उनका कुछ अर्जेंट बेसिस पर आया तो एक हम अपना ऑफिस बेयरर्स की मीटिंग करके एक्सेप्ट किए थे वर्चुअल मीटिंग में so that also need to be
to request, I would like to request office bearers of APPI to come on the dais, please, for the GBM. Oh, okay. Okay.
Good evening, everyone. I think today's scientific session is over, and the last session, Dr. Rajesh Pandey already left, was excellent plenary session, very interactive, followed by a video message by ISAF Foundation. That was also very informative and required. Now, this is the time for GBM, General Body Meeting, that is as per protocol very much required. And to initiate the GBM, we must have someone to chair the General Body Meeting. So may I request anyone from audience to propose to chair this GBM? Anyone senior faculty member who is life member of APPI may propose. Okay, thank you everyone. May I request Professor H.N. Malik to chair the GBM. Agenda, sir, इसमें only agenda because quorum, I know that it's not going to complete. So agenda will be to read the EC meeting, but that's all. And now it's the general body to approve all points or few points or whatever. Yes, yes. Yes, I hope. कितना आपको आधा घंटा लगेगा सेट करने में? ठीक.
Finance Secretary. Finance Secretary, Editor Physiology and Editor Pharmacology. बाहर भी कोई है तो बुला लीजिए. I welcome all the members. And those who are not members, please raise your hands.
How many are members? Okay. They may attend, but without voting right. If there is any issue or agenda, they may attend to experience what is GBM, what are the proceedings. Any live members of APPI outside, please come inside.
May I have the agenda, please? आप बैठो, I'll run the meeting. आप बैठो. The first item in the agenda is report by the General Secretary. Dr. Pandey, please.
The report, whatever submitted in the Executive Council meeting, including all the agenda, let me read the minutes of the meeting. So, at the request of members of Executive Committee, Professor T.R. Raju agreed to chair that meeting of the Executive Council. So, he already left for Bengaluru, but we thanks to chair the EC meeting. The meeting was attended by General Secretary, APPI, Professor H.N. Malik, Professor K.K. Deepak, Dr. Dinu Chandran, Associate Editor, Physiology, IJPP, Professor Anita Malhotra, Organizing Secretary for APCON 2022, proposed, and it was approved by EC. That's why ultimately GB to decide that. Professor Kiran Prakash, Member, Organizing Committee, Dr. A.K. Jaryal, Head Office, Finance and Finance Secretary, APPI, Professor Ramji Singh, former General Secretary, invited member, Professor T. Well Pandian, Editor Pharmacology, could not attend the meeting due to simultaneous commitment, and they informed through mail. The meeting began with welcome note by General Secretary in his capacity as General Secretary as well as member of Organizing Committee of 67th APCON at ESIC Faridabad. The committee was informed that Professor Neelam Vani has requested to be relieved of her responsibility as editor of physiology. It was communicated through mail and accepted by all the office bearers of APPI because of her personal commitment of many issues, and she the same things requested telephonically as well as through mail. The committee was Dr. Dinu Chandran presented the report of Executive Editor IJPP, and it was informed that mandatory period of 2 years required for technical compliance with PubMed will be complete with publication of upcoming issue of IJPP. The process of re-indexing with Medline will be initiated, and the members appreciated the efforts being taken by editors of IJPP for the charges made in technical as well as quality of submitted and published articles in IJPP. Now, Dr. A.K. Jaryal presented the report of Head Office, and it was informed that in the year 2021, 40 new members have joined the association. In 2022, till the making of this report, means 7 days before, 39 new members had joined the association, and it was informed that website of APPI has been redesigned with interactive features, and a database of 7,000 physiologists and pharmacologists of India in various medical colleges has been generated. The website has now engagement of more than 1,000. Till date, it is 1,017 actually members through the web account, and attempts are made to engage present and potential members of APPI. Professor K.K. Deepak suggests that additional efforts in the form of short training course may be initiated to increase engagement of association with current and potential members. Now, the executive committee was informed that election are required. These are actually one of the agenda for today, to be held for the post of executive editor IJPP, editor physiology, editor pharmacology. Now, the post of editor physiology is vacant because Dr. Neelam Bani was not ready for further extension, so we accepted that. Now, the tenure of editors has ended 31st March 2022. In view of the hybrid nature of this present conference and possibility of limited attendance of members during the GVM, it had been decided to defer the election of GVM during the conference of APPI in 2022, next APCON. Meanwhile, to ensure smooth functioning of IJPP, the members requested Professor K.K. Deepak and Professor Val Pandya to continue with designation till election are held in December. That is proposed date I am reading because it was the minutes of EC meeting 2022. At the suggestion of Professor Neelam Bani, it was decided to nominate Professor Abhinav Dikshit to take charge of editor physiology till December, until formal elections are held in the next APCON. So this was the one important agenda for today's GVM. Professor Anita Talwar, HOD Department of Physiology, GMC Chandigarh, informed that EPICON 2022 shall be held in collaboration with Department of Pharmacology, PGI Chandigarh, and the proposed dates, tentative date for conference was 26th to 30th December, 26, 27, 28, 29, and 30th, any 3 days conference and 1 day for the workshop. Am I right? What they proposed by GMC team. So now it's they have to fix from these dates what they inform to the EC. The committee also advised the head office to begin the process of invited application for EPICON 2023 onwards, and the decision on the post can be taken at the GBM during this December conference, next EPICON. So it was also informed from head office that 2 new chapters have been provisionally made. The EC approved the formation of this Batinda chapter of APPI and Rajkot chapter of APPI. Anyone from Rajkot? Yeah, Dr. Vivek. The issue of one-time life membership was raised by Dr. Jaryal, and it was suggested that in order to maintain financial health of association and to have funds to start activities for benefit of members, renewal of membership every 5 years could be started, and after discussion on advantages and consequences were decided to take up the matter at a later date with information on pattern of membership of other organizations of similar nature. So we did not take any decision on whether there should be any renewal of the membership or annual charge or 5-year charge. So it is same as on date. The committee was informed that demise of Professor K.K. Sharma, the former head of pharmacology UCMS, and Professor S.D. Nisit, former head of physiology KGMU, the member paid their respect to departed members, and it was informed that write-ups of the lives have been put on the website under in memoriam section of the APPI website. The then meeting, and these are all the matters. So I think let us start with a 2-minute ka maun in the memory of Professor K.K. Sharma.
May I request the members to observe 1 minute silence for the departed souls of the live members of APPI. There should be a letter from the association to the bereaved family. The executive has recommended few points to be discussed. The first one is extension of tenure of the office bearer. So now it is open for discussion. Shall we extend them till December?
Thank you.
And the second issue was the fee.
No, sir. In this office bearers, one nomination for the editor physiology.
Okay.
For Dr. Abhinav Dikshit till the next election.
Dr. Neelam Bani has resigned. So in her absence, till the election, Dr. Abhinav Dikshit's name has been nominated to officiate as editor physiology. Is it approved?
Next EPICON.
The next EPICON will be in Chandigarh. So that is also approved. We'll request you to address at the end.
No.
The dates
Last
are.
week of December they desire. They will discuss in the department and then let us know what are the 3 days conference and pre-conference workshop.
As early as possible, so that you will have more preparation time.
As soon as possible. Yeah,
Are you ready today to take? No, no, dates. 4 days? So you'll do 5 days for tomorrow?
बनाना होता है
From Kazara.
Great. Very nice. Yes.
Sir, ये number कौन? हाँ, sure.
So you are proposing 26, 27, 28, 29, 30th of December. December 2022. Most of us as faculty during that time has winter vacation. Okay. That is what I am saying, and please let me complete. So vacations are given to, why vacations are, it's why it is being provided to as a faculty by the government. The same thing is for Dr. Anil. Again, it's my comment. You can take it as a positive feedback or negative feedback or suggestion. It's definitely comment. Your dates of conference was 13th, 14th, 15th, and the tomorrow 16th of this month. Out of this, 14th and 15th is government guested holidays.
So we lose it.
Yes. So holidays are given by government. What are the purposes of holidays and the vacation? If you do the academic activities, then in one option is why you should be given the winter vacation or these holidays. Why not it should be abolished? Simple. You do the work. So I mean to say the same comment for
No, you have a very valid point. You have a very valid point.
Yes, yes,
Yeah,
sir.
yeah.
So the same comment is for your conference, and the same suggestions for you. You may change the dates. That is my view. That winter vacation should or any vacation or any holidays should be avoided to organize a conference or even CMEs. In US, working culture is Monday to Friday. Saturday, Sunday holidays means holidays. Do the work at your maximum. During holidays, enjoy.
नहीं और औसत जो मैंडेटरी है वो करना है पहले. नहीं वो भी करेंगे अभी. रिपोर्ट्स है, दो रिपोर्ट्स है. Yeah, sure, sir. Please, no side talk.
You will be given an opportunity, so speak on this. With permission of chair, ma'am, apart from what Dr. Rajkumar has conveyed, I think due consideration may be given.
One point I just want to add. We have tried our best, but till 24th of December, that we are planning our conference in the campus of PGI. They have 2-3 big auditoriums. Until 24th December, actually we got to know we were planning for the year 2023, and that time for that year we were ready, but since because of this COVID and these things, our Epicon has been delayed. So we are trying to be on time and make it regularized. So that's why we have been suggested to conduct in the year of 2022, and we have done our groundwork until 24th of the December. Major auditoriums are already booked at PGI, and during those days it's available.
Ma'am, another point. The thing is, during those days, 24th to 26th to extreme cold will be there. And we are in northern part of India. Had it been in Bangalore, Goa, people would have loved. But you being at Chandigarh, so due consideration should also be given that most of us will be shivering in that extreme cold. So kindly take it to November.
November and
November.
Dr. Kiran, see, there are valid points, and there is not much of this difference between November and December. Only 1 month difference. So if you work every day 3 hours extra, so that 1 month you can make it up. If it is feasible, then do it in the last week of November. No, last week of November, I'm telling. November. Have a rethink about the dates. Yeah, yeah, yeah. No, we'll wait for your decision. Yeah. Let us finish routine items so that any discussion we can do at the end. Report by the finance secretary and report by the editor, physiology.
So I have the report. I can just read out for the year. We are in a happy situation regarding IGPP. So from publication point of view, it's perfectly going on in time. We have completed 2 years for submission for the PubMed, and we fulfill all requirement for the PubMed. We never had a requirement for PubMed, like it was, electronic registration was not available since beginning, so we got it done. Only print registration was there, and review process and scientific editorial management was not there, so we have engaged. It's doing well. So scientific engagement is going on well, and process is very streamlined. Reviewers process, everything is now like an international standard. So this year we hope that we'll get the PubMed registration. There's nothing, no point is hanging. We've been in touch with them. Scopus is already there. We are still getting a lot of papers from here and abroad. Second point about readership, the library subscription has gone up significantly. International level also, we are getting requests for the hard copies. So that all has resulted in a good kind of a financial status. I'm very happy to announce, I read the reverse direction, all this. It is 1.22 crore. We started with 26 lakhs when I joined, something like maybe or less. But then thanks to all the systems, we have put everything in order. So that's what the finance, and both audit reports have already been done. And if we wish, we can put on website and everything. Thank you so much. Thank you.
You should spend some money out of this also. Yeah.
So may I?
और एक खत्म करता हूँ उसका, जो पॉइंट्स इकट्ठा ले लेंगे, हाँ सब इकट्ठा ले लेंगे. Then the finance secretary report, as informed by the general secretary, it was approved in the executive body, but now Dr. Ashok is not here, so he will email the statement to the members, all the members. Then the next one is admission of the new members. So we have 40 new live members, and I request the GBM to admit them.
List will be made. 43 new members, so we will mail.
Name का मुश्किल हो जाता है. If there are 200 names, then फिर शाम तक चलता रहेगा. So then we have some applications for the future conferences. One is from Jodhpur for 2025. Any other?
Any other, actually, they have.
There is nothing on paper, so no point to discuss.
Yeah.
And rest, now we can have discussion on all these points.
We application for 23 and 24, and it will be placed on the website also. In application will be invited through website, and anyone who is interested for 23-4, they may apply to General Secretary.
So any question related to these matters from the members?
Some apprehension from those who wish to submit papers or those who are contemplating or whatever, that probably our journal is not among the top. So how true is it? PubMed, as you said, why it has happened, and when are we going to be enrolled with PubMed? So a lot of things, because our competitors are already there. They are hijacking. So situation should not go little, bad. I won't say bad to worst, but more bad. So kindly take some appropriate corrective action so that we are back into the.
And thank you for this comment. It's a supportive comment, and we knew the situation. Over the years, some time back, electronic registration should have been done, like IESN number, EESN number. So that was not there. So that was major issue. Second issue having an online kind of a thing. First, we tried ourselves having online. We did online. however professional touch. And now these agencies are required for PubMed also. That what we required. So I think we have gone through, we are doing corrective measures till 2015. I think it was there already PubMed. 3030 articles are already available on PubMed. We already there. So when we do it, probably this all will happen. So we are in for this and we are trying to do it. Thank you so much. We need all support. We need good articles for this, and that's what review process is. Thank you.
Any other points? What?
2019. 2019 abstract on the website. I'll check again, and yeah, summation, because those are the abstract, and regular issues are there, because now we have to handshake with the organizing other persons. Earlier we have been uploading ourselves. That's what we upload all the data. Then we have to take away that data from, it's a data transfer from one server to other server, and always handshaking. So we'll take care. It's a small issue. Thank you.
If no other issues, now we have a very important duty to perform. I request Dr. Pandey and his team, Dr. Shivani and Dr. Monica, to come on the dais. So we have to propose a vote of thanks for the organizing team. They have done a wonderful job amidst all the odd circumstances. They have brought out this conference and doing excellent jobs. Only thing we are lacking from our part, that we are not attending in large numbers. So the team,
all the team, Dr. Shivani, Dr. Monica, Dr. Santan, Dr. Sumanta, Dr. Silpa, Dr. Namrata, Dr. Girish. I think all are still doing, Girish is here.
itne mein kaam chala le.
बिल्कुल.
So let's give them a big applause.
First time we could meet physically, so all standing ovation.
We have broken the barrier and we are here.
Yeah. Dr. Girish, please come.
Any comments from the audience for the team?
Anybody?
The organizing committee is hard pressed with time. The cultural program is waiting. So they have asked me to finish the meeting as quickly as possible. If there is any other pertaining matter, let me know. Otherwise, thank you all very much.
I thank you, Chairperson, other office bearers, all the delegates, life members, and especially the local organizing committee members. Thank you very much for wonderful session, and especially I personally thanks Professor H.N. Malik for administrative support and make this GVM at least happen. Thank you very much, sir.
No, I'll make a comment before I disperse. We should take it seriously, the GVM. Every year we are meeting once, so many important issues, not only about the association, regarding the discipline. There are many things. So this is the right platform to discuss. So there should be in future, we office bearer from ABPI, once you take a responsibility, you must be present in the GVM, nothing else. Unless and otherwise there is something.
If at all there is such a this thing, okay, be there on the screen, isn't it? Face the audience. Ways and means are there if you want to do it.
Yes.
I just want to thank the ABPI committee and everyone at ABPI for granting us the opportunity.
You please come and invite.
Yes.
Yes.
Sorry, we forgot you.
Yes, actually.
Yes. Sure, sir. Sure, sir. So on behalf. अरे हड़बड़ा क्यों रहा है? रुक जाओ, मैं बाद में invite करूँ।
क्योंकि लाइट पड़ रहा है ना उधर, ठीक नहीं आएगा।
हाँ ये बंद।
प्रोजेक्टर थोड़ी बंद करेगा, प्रोजेक्टर की लाइट है। प्रोजेक्टर की लाइट है। प्रोजेक्टर बंद कर दे। ये लाइट ऑन कर दे।
थोड़ा सामने आ जाए।
Yes. Very good. Thank you. पढ़ा दिया।
Thank you. Yes, sir. Well, okay, on the, thank you, sir. Okay, okay. Sir, शुरू करूं? So on the behalf of, last minute attention to everyone, please. Sure, sir. Yes, sir. And so on the behalf of Department of Physiology and Pharmacology from Government Medical College, Chandigarh, and Department of Pharmacology from PGI MER, I am privileged to invite you all for the next Epicon, 68th Epicon at the Chandigarh, the City Beautiful, for the wonderful academic treat as well as the other non-academic treat as well. And my special thanks to the APPI core body, general body and executive body members for providing us the opportunity to host the next Epicon. And thank you very much. Thank you, sir.
पे लग रहा है कुछ लूज कनेक्शन है क्या? एक बार देख लीजिएगा। मेरा ज्यादा छोड़ना ठीक नहीं, इससे भी जाऊंगा ज्यादा छोड़ना इससे भी जाऊंगा।
बॉक्सेस सब हटवा दीजिए एवरीथिंग।
Good evening to one and all present here. I welcome all the dignitaries. They have embraced the second day of our occasion. Before beginning, to keep the spirits high, I would like to request audience to please put up the loud applause. Before commencing further, I would like all the dignitaries present here to assemble near the stage for Deep Prajwalan. I request Dean Sir, our guest of honor ma'am, our medical superintendent ma'am, Dr. A.K. Pandey, and the other dignitaries.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदम् शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदम् शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
साहित्य संगीत कला विहीना साक्षात पशु पृच्छ विशीना, meaning thereby a person devoid of interest in music, literature, and arts is indeed an animal without horns and tail. With this, I open my heart to welcome you to yet another gorgeous musical evening, or rather, few moments of ecstasy transcendental. I now take the pleasure to introduce you to our performance par excellence of the evening, Pandit Shubhendru Rao, with his tabla accompanist, Shri Pranshu Chaturlal. Mr. Shubhendru Rao is a composer and sitar player who's ranked among the top soloists of India. The press described him as a musical bridge to many cultures and a thinking musician, constantly endeavoring to carry his instrument beyond conventional boundaries. A disciple of Pandit Ravi Shankar, he is acknowledged by critics as a worthy successor to his teacher's tradition. How can I not mention that he has performed in prestigious venues like the Kennedy Center, the Sydney Opera House, Theatre de la Ville, to name a few. बेहतरीन को भी बेहतर बनाने के लिए, to give us the elixir of music, accompanying him, we have Mr. Pranshu Chaturlal, who has literally married the classical, the folk, the jazz, the experimental, and other popular traditions, I might offend my art-hungry audience if I delay in welcoming the due on stage. I would like to request the audience to please put up the loud applause for these performers.
Namaskar and a very good evening to all of you. It's wonderful to be back in the same place where we were just before the COVID struck. So I was, these last 2 years are kind of like a blur in everybody's minds. We don't know whether what happened in 2020 and 2021. मेरा तो ये सोच था कि शायद मैं यहाँ पे 2019 में आया था, लेकिन बताया गया कि नहीं 2020 में, February 2020 बसंत पंचमी के दिन. So after which we know what has happened and what has transpired in the whole world. All the industries, entertainment, travel, hospitality, they have all suffered a lot. And I think the one that has prospered, of course, is the medicine. Thankfully, because of that, I just got my booster and hopefully rid of whatever dangers that we can see. लेकिन हाँ, खत्म तो नहीं हुआ है. We need to still be very vigilant and careful. लेकिन I think through this whole process, I think we have learned a lot. And the one thing at least I have learned is the beauty of, I mean, I've always known it, but even more so now in the last 2 years of forced exile, sitting at home, is the beauty of music and the relevance of art in society and what it brings to, and like he described, just beautifully that, इसके बिना तो कुछ अधूरा रहता है. I think we need to learn to love, respect, and make it a part of our life in every sense of the word. So today, I think appropriately, I just was thinking what to play. And आते वक्त Pranshu just asked me, I said, कुछ पता नहीं है क्योंकि क्या बजाना है. लेकिन यहाँ आने के बाद लगा कि नहीं, जो appropriate होगा, राग सरस्वती. इससे अच्छा तो शायद कुछ हो ही नहीं सकते. To reignite and restart, reboot everything that we have had to put to a stop for some time. तो राग सरस्वती में आप लोगों के सामने पहले आलाप झोट झाला, उसके बाद in a 10-beat cycle झपताल और faster 12-beat cycle एकताल. उसके बाद, as I said, even I didn't know what Saraswati would be, so I'll go ahead with whatever comes into the mind at that point. So राग सरस्वती से आप लोगों के सामने शुरू करूंगा. कार्यक्रम के अंत में एक लाइट क्लासिकल मेलोडी जो फोक म्यूजिक या ऐसे भी बोल सकते हैं, बेस्ड ऑन मिश्र पीलू, इस राग को लेके एक छोटा सा चलिए छोटा सा
I feel saying thanks to sir is no justice at all. I have overused this word a lot, and I think now there is some overuse atrophy with this word. The conspiracy of language now leaves me speechless. In state of unwavering devotion, I say, I flew with your music, sir. I fell with your words. I drove with your rag, and I was reborn with your passion. Sir, to be very frank, I love you. The ESIC fraternity love you. The nation loves you. And most importantly, the whole globe loves you. I suddenly feel rich as today you fill my heart, unlike my salary or job, which always fill just my pocket. I now invite our esteemed guest of honor, ma'am, Tripta Thakur, ma'am, and Dean Sir Dr. Asim Das to please felicitate the artists. I request all the dignitaries to please felicitate the artist. I request Dr. Pandey to please join the dignitaries in felicitating this artist. A loud applause by the audience, please. Yes, sir. No worries. I once again thank both the artists, and I request audience to please once again give standing ovation to both the artists. Sir, on behalf of all the organizing people and me, I have witnessed, you would like to know the secret energy which the artists carry. Yesterday, Dr. Shovna, and today you. like we can never imagine. Sir, is it the extra packet of caffeine you took from us, the tea bag, or is it's your natural energy? Music.
तो जितने भी टायर्ड है या जितने भी थकावट लगता है, एक बार अगर संगीत से जुड़ गए तो फिर वो थकान वकान सब निकल जाता है, पता ही नहीं चलता।
थैंक यू सर, थैंक यू सो मच।
थैंक यू।
I now take the honor in welcoming our distinguished guest of honor, Tripta Thakur ma'am. She is the Director General, National Power Training Institute, apex body of Ministry of Power, Government of India. She is a graduate in electrical engineering with master's degree in power electronics from IIT Kanpur and has a PhD from IIT Delhi. She has been recipient of several awards such as Commonwealth Research Scholar at University of Dundee, UK, Commonwealth Academic Fellow at Durham University Business School, UK, Co-Fund Senior Research at Durham University Business School, visiting faculty at Asian Institute of Technology, Bangkok, technical member for International Electronical Commission, SEG4 group and working group member, etc. I now request ma'am to please address our audience.
Good evening to all. Thanks for inviting and giving this opportunity. इतनी अच्छी संगीत संध्या के बाद हम लोग किसी दूसरे प्लेन में हैं, तो ये भाषण देने का बिल्कुल भी समय नहीं है. We must enjoy this aura. शुभेंद्र जी, आपने इतना अच्छा आज हमको कहीं और लेके गए, और यही संगीत है जो कि हमारी भारतीय संस्कृति है, और यही संस्कृति जो है वो हमको सिखाती है कि जीवन को कैसे जीना है. तो आज हम सब लोगों ने शुभेंद्र जी के साथ यहाँ पर इस पल को महसूस किया है और जिया है, और आपका बहुत बहुत धन्यवाद. और साथ ही साथ ESIC को मैं कॉन्ग्रेचुलेट करूंगी कि उन्होंने इतनी अच्छी कॉन्फ्रेंस ऑर्गेनाइज की. अभी एक और दिन है, और साथ ही साथ मेडिकल कॉलेज में उन्होंने ये समझा कि संगीत कितना जरूरी है, और स्पेशली भारतीय संगीत. तो इसलिए मैं असीम दास जी को बहुत बहुत बधाई देती हूँ कि उन्होंने जो अपनी दोनों कल्चरल इवनिंग आप पार्टिसिपेशन की जो आए हैं जगह जगह से इस कॉन्फ्रेंस को अटेंड करने के लिए, उनके लिए जो संगीत संध्या वो आयोजित की है वो बहुत ही सोच विचार के साथ की है. और आज सारी दुनिया भी यही कर रही है कि वो ये जान रही है कि संगीत और हमारा जो ये साइंस है, मेडिकल साइंस है, उसको कैसे को रिलेट करते हैं. मुझे अभी भी याद है कि मैं शुभेंद्र जी के साथ विदिशा के मेडिकल कॉलेज में एक प्रोग्राम में साथ में गई थी भोपाल में. तो वहां पर उन्होंने इसी विषय को लेकर के बहुत कोरिलेट करके बहुत अच्छे से डॉक्टर्स को समझाया कि किस किस तरह के प्रयोग हो रहे हैं संगीत में और मेडिसिन में. अभी समय अगर हो तो शुभेंद्र जी से ही रिक्वेस्ट करूंगी. मैं आपको क्या बताऊंगी, उन्होंने इतने अच्छे से समझाया कि किस तरीके से डॉक्टर्स आज इस चीज को यूज कर रहे हैं. और अभी अभी रिसेंटली मैंने एक बायोलॉजी ऑफ बिलीफ की बुक पढ़ी है, तो मुझे समझ में आया कि ये जो बायोलॉजी और बिलीफ और जो हमारा सिस्टम है वो किस तरीके से इंट्रिकेट करके फाइनली ये भी साइंस है और वो भी एक साइंस है जिसे आज जानने की बहुत आवश्यकता है. और आज हम इस फ्रंट पर सारी दुनिया को लीड कर सकते हैं कि म्यूजिक और साइंस और मेडिसिन कितने को रिलेटेड है. आप शांत हो गए तो देखिए सारी चीजें शांत हो गई. तो शुभेंद्र जी आप ही कुछ बोलिए इस विषय में. धन्यवाद. मैं तो बस सबको आपका धन्यवाद और मुझे बुलाने के लिए धन्यवाद. नहीं, आपने कितने अच्छे से रिलेट किया था. आई स्टिल रिमेम्बर.
अपने experts के सामने, you know, I mean, in the field of music, I mean, medicine, लेकिन एक ही है, I think maybe the correlation is both of them start with M, music and medicine. Lekin importantly, of course, music is something that perhaps is, मैंने आपको क्या दिया मुझे कुछ नहीं पता है, आपने क्या लिया मुझे आपको भी नहीं पता होगा, but फिर भी there was an energy that was exchanged, and that energy, and वही है, we try to bring that positivity. लेकिन तृप्ता जी ने कहा, मुझे याद नहीं है मैंने क्या बोला था, but you know, over the last few years, of course, I've been very active in understanding, in studying music education, क्योंकि I strongly believe that music should be a part of every child's growth. तो इस सिलसिले में हम लोग काफी मेहनत करके we are doing a lot of work, और उस research में the one thing that we have discovered, of course, thanks to the research done by experts in that field, कि music activity in a child's development is like, agar मान लीजिए there are photographs, or rather there are, you know, photographs of the research that is done, बोलते हैं कि जब एक activity that not just activates the right side of the brain or the left side of the brain, but also the connecting part, and that is the most important thing, that all these three things are reactivated by music, which no other activity can do. And they say a child who learns music from, say, very, very early childhood, or even maybe even before it's born, unka brain ka wiring hi kuch alag hota hai. So that is the activity of, that is the power of music. And as I said, there is nothing I gave you, there is nothing you took, but still there is so much more we exchanged, and that is music. So that's all I have to say.
Thanks a lot to Tripta ma'am. I would now request Dean sir to please felicitate our guest of honor, Tripta ma'am. I must tell the audience that ma'am's CV was so long that it could be a possible topic for my thesis research. It was so extensive. I request MS ma'am, Dr. Praveen Guliani, to please be on the stage. Thank you. Thank you. I now request Dr. Anshu Chabra, MCME, ESIC, to please be on the stage. I request Dean sir and MS ma'am to please felicitate. I request Dr. Pandey to be on the stage to felicitate Dr. Anshu Chabra. I request MCME ma'am to please address our audience.
So good evening, everybody. It's been a wonderful evening, and really, Shubhenduji has been able to transport us to another world. And especially in a medical college setup where we talk of so much of mental stress in the students, what the wonders that music can do. It is really exhilarating. And thank you, Tripta ma'am, for sparing this time, being here with us. And it's been a wonderful evening. Music has always, they say it's the food of the soul. So, जैसे इन्होंने बोला that energy that has transpired, been exchanged between the performers and the audience, and it will be carried for a long time later also. So I really appreciate the efforts made by Dr. Asim Das, the Dean, and all his team, the whole team, which has worked so hard. The conference, the whole day, managing all the sessions, and then ending the day with such a wonderful cultural evening. It's a commendable job. Congratulations once again, and thanks, and really my hearty thanks to the performers also. Thank you.
Before concluding, once again, on behalf of all the members of the ESIC fraternity, I would like to extend my heartfelt gratitude to Dean Sir, Dr. Asim Das, Dr. A.K. Pandey, two very young boys of our college, because their spirit is just unbeatable. They have made unwavering commitment and dedication towards making this event a success. Now, before concluding, before signing off, I would like to invite Dr. A.K. Pandey on stage to present vote of thanks to the audience.
Honorable Tripta ma'am, the guest of honor, our very dynamic medical commissioner, medical education, ESIC headquarters, for approving this event to be hosted at ESIC Faridabad. Not only this event, but sanction some good financial amount also. So I'm grateful to MC ma'am for that. All the delegates connected through virtual platforms, physically here, all the students, postgraduate, PhD scholars, undergraduate students, Dr. S.K. Bajpai, very senior professor, former dean of Government Medical College, Surat, and founder, president of Indian Society of Hypertension, Professor K.K. Deepak, professor and head physiology, AIIMS, Delhi, Dr. H.N. Malik, and many senior professors. Actually, since last 3 days, it started with 8 workshops on 13th, then 11 symposium, 6 plenary lectures, many free paper and poster presentation, around 123 e-poster, and 40 physical poster presentation, scientific sessions, postgraduate award, undergraduate award, then young investigator workshop. Tomorrow we have a ESIC specific rare genetic disorder work, symposium also. So all these scientific events, it's well, because it was very difficult to conduct this such type of national conference in hybrid mode, especially physiology pharmacology. You are the first to host in a hybrid mode where physical attendance was also better than what we expected. So more than 600 delegates through various virtual platform connected. So in this way, I feel relaxed that it is a successful event. And already the scientific inauguration was held yesterday only. So in the last but not the least, because my role is a general secretary of APPI on behalf of Association of Physiologists and Pharmacologists of India. But the organizing committee led by Dr. Shivani, she is the organizing secretary of APPI, and Dr. Monica Agarwal, co-organizing secretary. And also whatever this inaugural and cultural event, it's only the credit goes to Dr. Monica Agarwal. She managed both the artists for both the days. So it's not a easy job to manage, especially in such time where people are scared still to come in person to attend the events. including the inaugural. So our Dean sir has played a very important role, because actually I was busy with lot of project, and we took this conferences and to manage it. So you know that ESIC already we are working on lot of services here. So he sit here till 8, because he said that related to conference I'll start working after 5 p.m. 9 to 5 is for the ESIC, and after 5 only I will take and give time for this conference. So then it was difficult to stay all the staff, because after 5, so he took responsibility for managing how to host, means hospitality, the accommodation for the delegates, for the good food, whatever I think people enjoy, the this catering services. So all these I am see that it's a maximum work done by Dr. Asim Das, and that's why I'm really grateful, thankful to Dean sir. Now mainly Dr. Girish, we cannot ignore him, because he is the main person for all these, you see the virtual things he is managing for all the scientific events. Dr. Mayank Hans, if you see anyone without any discomfort or uncomfort from airport, pick and drop, from the railway station, from the venue to their, so what he is again doing the, single-handedly he is managing all these things. So Dr. Namrata, Dr. Silpa Khuller, from other all the senior resident, postgraduate student, even Dr. Archit, he joined as a postgraduate student, psychiatry. And just I call him 3 days before, look sir, I will manage all the scientific, means how to coordinate, I know that. So even Dr. Archit also deserve a special thanks. So this our virtual platform professional team, the Ghazal caterer, few sponsors, the audio visual team from the Honey DJ. So I am grateful everyone for making this event a successful event. Thank you very much.
I request the audience to please stand for the national anthem. I would like all the dignitaries and the delegates to please proceed for dinner. The dinner will be at the same venue as yesterday, Aravali Golf Course.